Welcome and good morning, everyone. We're so glad that you've chosen to spend some time with us today. I'm Franklin Walker. I am a VP at the North Carolina Medical Society and North Carolina Medical Society Foundation. So welcome to the Lifestyle Medicine Summit and the CPP annual meeting. And before we delve into the important and fascinating topic of lifestyle medicine, I do want to recognize our community practitioner program participants and share a few facts about this program, which has been in existence for about 32 years. Over the course of these 3 decades plus, CPP participants have had a major impact in our rural and underserved communities in exchange for help in repaying their medical education loans. These dedicated men and women help provide care to those who may not otherwise have access to it. In the last 32 years, the North Carolina Medical Society Foundation, through the Community Practitioner Program, has placed 515 providers serving in 88 of North Carolina's 100 counties, representing 242 unique locations. This is a large footprint covering our state. Our CPPers are an impressive bunch. They've earned degrees from over 130 different professional schools in North Carolina and throughout the country before joining the program. But the most impressive part to me is the fact that we've put out over the 32 years, $16 million in grants that were awarded to these participants. And they've resulted in about $671 million in free and reduced care, which is just a great ROI and a great story. As we embark on our Healthy North Carolina 2030 initiative and learn about lifestyle medicine, we're going to also congratulate the CPPers today. So I think hope you'll recognize their major contributions. I want to thank you for coming today. I also want to thank some supporters of getting this program together, the North Carolina Research Campus and the Cabarrus Health Department. Now I'd like to turn it over to Dr. Bonnie Coyle. Bonnie is the health director at Cabarrus County, a lifestyle medicine physician, and she's also a participant in the North Carolina Medical Society Foundation's Leadership College. Dr. Coyle.
Thanks, Franklin. Good morning, everyone. I would like to start by welcoming all of you to the conference today and thank you for joining us. I'm really excited about this opportunity for this conference, and I'm hoping that it'll be an annual symposium for North Carolina providers, allied health personnel, public health professionals, researchers, educators, and other academicians interested and passionate about improving the health of our communities and our state. I think many of you are probably aware that our country spends more on healthcare than any other country in the world. And yet, unfortunately, we're less healthy than many of those same countries. Not only are we less healthy, but for some of the metrics, we've actually been getting more unhealthy over the past couple of years. The chronic disease epidemics are ravaging our communities just as violently as the COVID pandemic is right now. And North Carolina is no exception to the declining health we're seeing in the United States. North Carolina is only ranked in about the middle of the pack of all states for how healthy it is. And among all of the states, many of the health outcomes are far off from the goals that Healthy North Carolina 2030 has set. So we've got some work to do if we want to make healthy communities. And that's really the main purpose of this symposium. We want to create a forum that brings together individuals and agencies that are committed to improving the health of North Carolina residents and are thinking about how we can transform healthcare, public health services, and education and research to focus on those main contributors to poor health. And in the Healthy North Carolina 2030 plan, you'll see that it's really clear that social determinants of health and lifestyle behaviors are driving the poor health outcomes that we see. So through this conference, we want to educate all of you about some of these key concepts: Healthy North Carolina 2030, social determinants, lifestyle medicine, so we can all be more informed and find new ways of collaborating. We want to be able to move the proverbial needle on health status in our state. Wouldn't it be really exciting if we could make North Carolina the healthiest state in the country and by reversing the decline in chronic diseases. So this conference is really just the beginning. The real work will begin when the conference ends. The North Carolina Medical Society is supporting a pilot project with the CPP program. You'll hear about that later on today. And while we're starting with a pilot project trying to implement social determinants in lifestyle medicine, we really hope to engage many practices, agencies, educators, again, into doing the work of bringing folks together, sharing best practices, successes and challenges as we try to transform all of our work for the better. So day one, we'll be providing an overview of a number of concepts that I've already mentioned: Healthy North Carolina, lifestyle medicine, social determinants, and NC Care 360. We'll also have an introduction to culinary medicine, and then even an optional cooking demonstration that I hope you'll all join at the end of the day. And then day two, we'll delve deeper into the topics of lifestyle medicine and social determinants as we bring practical examples of how various professionals across the state are incorporating social determinants and lifestyle medicine efforts into their work. So with that, let's get it started with our exciting lineup of presenters for the day, and I'll turn it back over to Franklin. Thanks.
Thank you. So I want to introduce our first presenter, Kathy Colville, who is the president and CEO of the North Carolina Institute of Medicine, is going to provide an overview of the Healthy North Carolina 2030 report. Kathy, welcome.
Thank you so much, Franklin. And thank you also to the Medical Society for the opportunity to be with everyone today. You know, when we were talking about this months ago, Franklin, we were going to be together, weren't we? And we were so excited about that opportunity to maybe be one of the first gatherings of people getting together. And we are not, and we know all of the reasons behind that, and it is wise that we are all connecting over Zoom land. But I am so grateful still for the opportunity to be a part of this extraordinary agenda. They've done a wonderful job of, I think, starting with what I'm going to talk about, which is really sort of a big picture. And then over the course of today and tomorrow, you'll go deeper and deeper into more of the specifics for pulling out all of these different areas and dimensions of lifestyle medicine, social determinants of health, and others. And I'm really excited that I get to present to you on kind of an umbrella piece of this. Next up after me is a group called Ruckus Health. And I have to say that when I saw that there was a group called Ruckus Health, I thought to myself, that's a pretty cool name. And I'm kind of glad I'm going before Ruckus Health rather than after Ruckus Health, because I have a feeling they're going to be awfully fun. I'm going to start my slides in a second, but I'll just let you know the very first slide that you're going to see is that disclosure slide. And so neither myself nor my family have any relevant financial disclosures. And then the second slide you're going to see is just my overview piece. But back to that topic of Ruckus Health. I was thinking that the Institute of Medicine sounds a little boring compared to that concept of Ruckus Health. All right, here we go. Can you see my slides now? All right, and I'm going to try and get rid of all this stuff. Start my slideshow. You see the disclosure, right? Bonnie, I need your head nod. Thank you. Okay, great. And again, I'm Kathy Colville at the Institute of Medicine. But when I heard again Ruckus Health, I was thinking of that Maurice Sendak children's book where all of a sudden at the end they say, "Let the wild rumpus begin." And they're playing and it's the monsters and so on. And so I thought maybe we could do with a little name change at the Institute of Medicine. And I'm thinking it might be good to be Institute of Medicine where the wild things are, just a little bit more exciting aspect of what we bring to you all in North Carolina. Now we are the Institute of Medicine, and that conjures up images of stability and and sort of standards and quality. And I hope that's what you associate with the Institute of Medicine. Just very quickly, a reminder that we were chartered in 1983 by the General Assembly. And our work at the Institute of Medicine is to think about public policy and how public policy can move forward in order to solve some of the issues related to health and healthcare for everyone in North Carolina. We work with diverse stakeholder groups from across the state. We pull them together. We work together on task forces on important issues. Right now, we're working on things like pandemic preparedness, the future of local public health and maternal health, and we come up with recommendations. And typically, most or close to all of those recommendations within several years are adopted by legislators. And we think the reason why is these 4 bullet points right here, because the NCIOM does this very special thing, which is commitment to nonpartisanship, evidence-based, solution-focused, and consensus-driven recommendations that represent in many ways the common ground of where North Carolinians believe that we need to go. Now, I mentioned that I'm going to be talking about some big picture things. Back in 2019, the North Carolina Institute of Medicine began work on Healthy North Carolina 2030. And this was, like you may, if you're familiar with NCIOM task forces, a big production. We spent over a year pulling all of this work together, many people across the state mobilizing and working on this, pulling the best of their minds together. And I just wanted to sort of pose this, that, if you work at the individual level, if you're working primarily directly with patients, I know that very few clinicians walk into the office every day and say, how can I increase the average life expectancy in North Carolina today? And how can I eliminate the disparities in life expectancy in North Carolina today? And yet, the work that many of you do as clinicians or health educators or health administrators is very closely aligned to that overall statistic. The work that we're talking about with Healthy NC 2030 is truly a group of people coming together and saying, how can we increase the average life expectancy in North Carolina and the quality of life and the well-being in our communities across our state altogether? So the primary aim of the Healthy North Carolina process is to mobilize the state to achieve a common set of health objectives. And we've been doing this for 4 decades. And we have steadily been winnowing those down. You can see Healthy NC 2010 had 100 objectives, 40 objectives in 2020. In 2030, that has been really distilled down to 21 objectives that this group of people from across the state agreed have the most power for us to meet that goal of increasing life expectancy and overall well-being. The other things that are new with Healthy NC 2030 are that there's an intentional look at breaking out data by race, ethnicity, sex, and income, and looking at differences within those groups to understand where we can take action in order to eliminate disparities and improve things for all groups. There's also a specific call within Healthy NC 2030 to dismantle structural racism, and an understanding that structural racism has this foundational contribution to poor health outcomes for all of us and disparities. And then the other thing that's really important in this Healthy NC 2030 is that it takes a multi-sector population health approach. What's really interesting is that those 21 indicators are called health indicators, but they might not be health indicators that you're used to. We might not be used to things like the incarceration rate being called a health indicator, or the 3rd grade reading levels being called a health indicator, but they are in Healthy NC 2030. There's a real attention to multiple dimensions and things that you're used to, clinical care, health behaviors, as well as things like social and economic factors and the environment. So often when we start a process like this, a decade-long, sort of what are we shooting for kind of process, we might go back and look at data that tell us about things like, what are the major causes of death? What are the most common comorbidities? And start with that. But the Healthy NC 2030 process really starts with a statement of possibility, or an understanding and a vision of health and well-being, and moving towards that. So I want to share this vision with you and talk about it in terms of a North Carolina child. And his name is Jesse. And let's imagine that he is born today. And let's imagine Jesse being born today in 2030 is about 8 or 9 years old. And he lives with his family just outside a medium-sized North Carolina city. And his house, where he has his very own room and enjoys meals with his family, is right down the street from a big park where he likes to play. He likes to play mostly on the playground, but sometimes he likes to join the bigger boys and play on the soccer fields and the pickup games that sometimes happen there. All right, I've got to get my clicker back in the right spot. The grocery store a couple blocks away from his house is a good place to get affordable fruits and vegetables along with the other snacks that Jesse likes to eat. And at school, Jesse has become a voracious reader. He also likes to talk in class a little bit, and sometimes he and his classmates get a little bit carried away. But his teacher has a lot of training in this. She takes it in stride, and she uses effective disciplinary approaches to handle disruptions in class and keep all of the students learning together. Jesse was born with a health condition, which his mother was prepared for because she got early prenatal care. And his family uses Medicaid, which helps pay for his primary care visits, as well as the specialty care that Jesse needs occasionally still from time to time. Now, Jesse's parents are divorced, and his father struggled with substance use when Jesse was younger. And actually, his father was briefly incarcerated, and he participated while he was imprisoned in a medication-assisted substance use treatment program during that time. His family's really actually gone through a lot, but they're doing much better thanks to a trauma-informed parenting program, behavioral health treatment, and lots of hard work on their part. Now, Jesse's parents are both have jobs that pay a sustainable wage for this area. It's a little bit over $15 an hour, and this has helped his family keep up with the bills, pay for a very fun after-school program for Jesse, and help with their transportation so that they can get to work, school, medical appointments, and do fun things as a family. So when I look at this picture of the vision for health and well-being, a couple of things occur to me. One is that on the one hand, these are all very modest and fair goals. Isn't this something that we as a robust American country should be able to achieve for most or all of our citizens and residents here? And on the other hand, sometimes I think it's so hard to be hopeful that we can achieve something like this and to not dismiss this type of vision as something like pie in the sky. But I think what Healthy NC 2030 is not asking us to say, are we 100% doing this? And it doesn't promise that it's going to meet all of the targets, but what it really asks us is this worth working towards? And is this worth working towards as clinicians, as educators, as public health, as healthcare, as teachers, as people who work in the court system, as people across all these sectors? And I think the answer for most of us is yes, this vision is really worth working towards. I want to share a little bit more about how that vision looks in the words of the people that came together for Healthy NC 2030. And I'm not going to read all of these, but I am going to call attention to these things that are in green here. The goals are healthy, thriving lives and well-being, and also for all, and that we don't leave groups behind on this, and that for all takes a look at the ways that we've done that in the past. We want to eliminate health disparities, achieve health equity, and attain health literacy. And that we're going to pay attention to social, physical, and economic environments. And we're also going to look at all life stages, from birth to end of life, middle age, older adults, adolescents, and all of those stages that have unique needs. And that we're also talking about engaging people across multiple sectors to take action and design policies for change. I'm going to talk with you a little bit about the sort of logistics behind this. This is the overall idea, is that there's a vision for Healthy NC 2030. A group comes to consensus on indicators, and then the report is published. At that point, we're all about awareness and mobilization, helping people to understand what these indicators are, how do they make sense, how do people connect with them. The state is also working on a state health improvement plan so that they're starting to talk about strategies and tactics. And then together, along with the state and many other organizations, we're taking collective action to meet these goals. Now, the tricky thing about this is that the vision, which was in 2019, and the consensus on indicators, all of that work was published in February of 2020. And so there's been so much disruption to so many things, including to Healthy NC 2030. So in many cases where we'd like to be at the collective action stage right now, we find ourselves back at awareness and mobilization. I will say, though, that there are some things that we look back with our pandemic eyes, things that happened in January of 2020 or February or before that, and we say to ourselves, oh, bless my heart, I thought that was important back then. When we look back at Healthy NC 2030, I think we see the people who worked on this couldn't have predicted a better way to help us lay out collective action and a vision in a post-pandemic world as well. And I think it helps give us a blueprint for how we pull ourselves out and where we focus as we enter these new and hopefully resolution and post-pandemic stages. I'll share again, as I mentioned, a little bit more about the methods behind this so that you know how we got to these indicators. All right, now I have to figure out, okay, there we go. I wanted to share again that this is a shift from how some of this has been approached in the past. If you look on the left-hand side of this slide, you can see Healthy 2020. There were 13 dimensions and 40 objectives. And if you see this quote in the middle from one of our leaders that worked on this, talking about this being a reorientation from Healthy NC 2030, shifting from a focus on individual health topics to a focus on health equity and overall drivers. And on the right-hand side, I'm sure that this is new to just a couple of you, but many of you are very familiar with the county health rankings model, also created by the University of Wisconsin Population Health Institute. And if you don't know the story behind it, very quickly, they looked at life expectancy and quality of life for every single county in the United States. And then they went back and said, why is it higher in some places and lower in others? What's the cause of that variation? And they built a model for that. And oops. And that model shows us that about 50% of that is due to social and economic factors and physical environment. And the other 50%, and again, these are the modifiable health factors, relates to things that we're very familiar with in public health and healthcare, health behaviors and clinical care. And for me, the work of the county health rankings and the University of Wisconsin Population Health Institute has really been a game changer that's shifted us to say, gosh, we need to understand, we need to connect with, and we need to be integrating these social and economic factors. And how do we do that? And that's, I think, in many ways, the work of this Healthy NC 2030 project writ large. All right. So the work was really organized by an overall steering committee and a task force. And I'll just draw your attention to the bottom of this here, 4 work groups focused on 4 dimensions: health behaviors, clinical care, social and economic factors, and physical environment. There were between 20 and 30 people in each of these work groups that met multiple times to consider all of the data. And there was also considerable public input. And there were multiple meetings across the state where regular folks could show up and weigh in on what they thought was important. I will also just take a second to recognize the co-chairs of this: Laura Gerald of Kate B. Reynolds, Ronnie Bell of Wake Forest, Jack Cecil of Biltmore, and Betsy Tilson of NCDHHS. So really representing philanthropy, representing business, representing state and governmental public health, and a wide range of backgrounds there as well. I mentioned that there was community input sessions. All told, this was 350 people came to these. Multiple different meetings where people were weighing in on what's important to them and what they believe is important to the state for our health. Around 80 counties altogether were represented. There's overlap in some of these, so it looks like more than 100 counties on these, but you can see that there was an attempt to really do listening sessions in a variety of different ways. I think post-pandemic, we know many different new ways to get input on this, but these were in-person sessions where people had the chance to be face-to-face. And people were able to say what's important to them and what they believe is important to the state. And then the task for all of these work groups became, well, how the heck do you measure that? Right? And how do we find indicators that we can, that will represent the consensus here? So they went looking for indicators that were measurable, that would make sense, not just to experts, but to people in general, that were oriented towards prevention, that could be broken out so that we could look at health inequities that are available at the county level and that were measured every 3 years or less. And for those of you that work with a lot of public health data, you know that actually, surprisingly and worryingly, we don't have a lot of indicators that meet all of these criteria. And not everything in Healthy NC 2030 does either. So there is a call for data development in this as well. And the idea behind setting this set of indicators is that it all gives us a chance to start rowing in the same direction. In order to produce the Healthy NC 2030 report, they looked at the data for these indicators, considered trends over time, reviewed disparity data to see if there were some disparities that were potentially masked in the overall figures. They set goals for 2030, and they identified some potential ways to get there. And those are the types of things that you'll see in the Healthy NC 2030 report. We're going to talk now and dive a little bit more into some of these health indicators. So you can see that county health rankings model on the left-hand side and how that relates back to the indicators that were chosen in those dimensions. So again, altogether 21. The health outcomes that were chosen overall were infant mortality and life expectancy. And I hope that you'll see in these indicators some of that vision that we talked about with Jesse being recognized here, so that this is a picture of health and well-being. This isn't just the absence of disease. This is really a desire to work towards health. I'm going to just stop here for a second and focus on some of the areas that might be more familiar to us in health and healthcare, the health behaviors and the clinical care. So just to recognize that there's sometimes some slippage between what we really want to know and what we're able to measure. So if we look at clinical care, for example, I think what we probably really want to know about North Carolina is how many North Carolinians have access to affordable care when they need it, with a trusted provider who's doing a really good job attending to their physical and mental health needs. We don't have a way to measure that in one indicator. And so what we have is a set of proxy indicators that get us as close as possible reasonably to understanding exactly that issue. And that ends up for us in Healthy NC 2030 as the uninsured early prenatal care, the ratio of primary care clinicians, and the suicide rate. So you can understand there's this sort of overall what we want, and then translating that into indicators that we can measure and that we can do to track our progress over time. I'll also just point out that the health behaviors indicators here are pretty focused on substances and on sexual health. There isn't an indicator here for physical activity, which is something that people ask about a lot. I wasn't a part of this, so I don't know the inside story on that, but you will see indicator related to physical activity that shows up in the social and environmental factors. And so we'll go there next, and we'll spend a little bit of time on these social and economic factors, because they can be the ones that sometimes are a little bit more confusing, or it's helpful to look at them together. So we know that there's obviously really complex interplay between environments, social and economic status, behaviors, and health outcomes, right? We often think of our environments and our social economic status as being very determinant of the types of health behaviors that we may exhibit because of the exposures that we have in our environment, right? If we have access to a grocery store pretty close, like Jesse does, we're probably more likely to go to a grocery store. But if there's a whole bunch of fast food there, we're probably more likely to hit there first, right? We also understand that that we can intervene in those environments, and that intervening in those environments and making changes to environments through things like bike lanes and safe crossings and ways to get to school and so on can make a difference in people's health outcomes and in their behaviors as well. I want to focus right now on this multi-sector population health approach, and just to point out that all of these indicators are again based on the Population Health Institute's estimates of the drivers of health. And I want to take us now through just a couple of mental models that help this stuff, which seems so big picture and huge, seem a little bit closer to clinical practice or to direct patient care practice. And I'm going to start here just with a model that comes from some of the medical literature on asthma, to just remind us that while, sometimes it can feel really crazy to have things like short-term suspension as a health indicator, at the same time, we've understood, especially for things like asthma, for a long time, that there's a complex interplay here. We understand that there's a person and environment perspective, that for something like asthma, as you can see here, we've got that personal physiological risk and protective factors. If that's a child or an adult, they're often within a family unit that may have a certain amount of capacity, maybe the income that they need, and the health literacy in order to keep, in order to recognize triggers, identify triggers, and keep asthma controlled. We also recognize that an individual lives within housing, and that the ability to be in safe housing that's affordable, where you can eliminate triggers and have control over that environment, is a key issue in asthma outcomes. So again, just one of our models that we're very familiar with, where we understand that that health outcome of controlled or uncontrolled asthma is really dependent on a variety of factors. I also think it's helpful to look at this report from the National Academies, and this came out in 2019. And this does a nice job of giving us, again, a set of mental model, or a mental model for us to understand how we might engage with this. For many people, it really is new to integrate social care into the delivery of healthcare. For many people on this, you may be sort of the early adopters. You may be somebody who's here because you're curious and you're trying to figure this out. And most of us at this point are figuring this out. And I think that what they offer in terms of these, excuse me, I have to move things around so that I can see things, and I end up moving the wrong thing. They offer us these ideas of starting with awareness, moving to adjustment, assistance, alignment, and advocacy. And I just want to talk you through a very concrete example of this. And I actually took this from them, so if you cite them, it's not plagiarism. Their example that they give in their report is a transportation example. And this awareness phase is really just, in the clinical setting, are you asking people about their access to transportation? This adjustment phase is when you might alter something in clinical care to accommodate for that. For example, if somebody has problems with access to transportation, you might see if you can reduce the number of in-person appointments. You might do something creative with scheduling. You might figure out if something could be a telehealth visit. That next step up, assistance, is when you might do something like offer a voucher for transportation for people who have trouble affording transportation. And then there's kind of a switch between assistance and alignment, between focus on individuals, which is really the first 3 bullet points, and focus on community. Alignment and advocacy are the community level pieces of this. The alignment level, according to the National Academy, is when you look at what your existing transportation infrastructure is, not just for your patient, but for your community as a whole. And perhaps you or your health system invest in that. Maybe that's, using one of your parking lots as a park and ride lot. Maybe it's purchasing a bus shelter, or donating, something to the existing transportation system. And then the advocacy step of this is a little bit different. This is where you are getting involved in the policy arena and advocating for policies that could fundamentally change your transit infrastructure. So for example, when I was at Cone Health, my role prior to being at the Institute of Medicine, we did a lot of advocacy with our local system to try and get expanded hours. So to go further in the weekend for our transit system and then hours on the weekend, and to bring the stories from healthcare about what a difference that could make for our patients. And the reason why we knew the difference that it would make for our patients is because we did that first bullet point. We asked people what their problems were, and then we learned about them, and we learned how important it could be to make affordable and feasible changes in our transit infrastructure, and got involved. This is a similar picture of this, and instead of talking about it in those 5 ways, it really talks about this upstream, midstream, and downstream. A lot of the integrative work, things like NC Care 360, is really at that midstream level. It's where we're asking people, screening people about social factors, using that data to send referrals, either stuff that we can do in our own offices, or we're using some sort of system, either the old system where you call up the people that you know, or this new system, NC Care 360, which we're building here in North Carolina. The upstream stuff is kind of that alignment and advocacy part that I talked about. And this is, in many cases, in many of our communities, an important role for our public health leaders and for our other sectors. This may be where you're working with public health and housing. It may be where you're working with the people who are advocating around food access. But it's an interesting part of what the national academies and others are calling us to, which is to start with that awareness level, but to figure out ways that we can engage to have that community impact. Where in the old-fashioned version of population health, we are changing things for whole communities through this work. And again, this is very closely aligned to the types of indicators that we see in Healthy NC 2030. And I'll just, if I advance my slides one time, you can see how that aligns up, that awareness, adjustment, and assistance from the National Academies work, and then an alignment and advocacy having that community impact. These things are closer than we may sometimes be able to see, or that it seems at certain points. I'm going to talk us through it's just sort of a case study very quickly that I'm very familiar with. Again, this came from my work prior to coming to the NCIOM, when I worked with a group of community advocates in Greensboro. And you can see on the left-hand side of this, the old redlining maps back from the 1930s that designated places in red that were considered by the government to not be worthy of investment. Those are places where businesses and homeowners had a very difficult time getting access to financing and mortgages. And you can see the places in green considered the best, and blue still desirable. And this is, of course, where we get that understanding of redlining that many of you have heard from. Now, redlining has had a legacy over the decades, and while those redlining policies are no longer officially and formally in place, you can see how those geographies get repeated over and over. So if we look on the right-hand side of this, this is a map of substandard housing density in Greensboro. And it makes sense that if you weren't able to get financing and investment in those redlined areas, that we would find that substandard housing density map looking very similar to the redlining map of the 1930s. And I want to focus in right here on another map which looked at those issues of substandard housing, poverty, and asthma. And if you look in the area that I've circled right here, this is where the neighborhood of Cottage Grove is in Greensboro. And it happens to be the area where you overlap with both substandard housing, highest rates of substandard housing, and highest rates of asthma burden in the community in Greensboro. And there are a lot of people working on exactly that issue. So you see here a group of neighborhood residents, housing advocates, and university researchers that have formed a coalition that endures to this day. At this point, they were looking at the utility bills for Avalon Trace, which was an apartment complex that was so poorly maintained that people were paying hundreds and hundreds of dollars in utilities because the roofs were leaking and the windows were not tight and the doors had big cracks underneath them and many other things that were there. And I just wanted to also draw your attention to the letter at the bottom here. So this is a good example of a physician, Dr. Beth Mulberry, who started to listen to her patients and ask about these things. So she went through that awareness phase. And she aligned herself with community advocates. And then she took action herself and wrote this letter to the Minimum Housing Standards Commission about a family with a 15-month-old with asthma. And because they were listening and because they had a health outreach team, they knew that they didn't have heat. They knew that there was a leak that left their carpet soaked. And this has health outcomes. The baby developed a fever and needed to be seen in the emergency room. Now, there were many, many stories like this that came out of Avalon Trace, and the collection of those stories really helped to make a long story short for these advocates to make the case for renovations at Avalon Trace, which is now called Cottage Gardens. The enterprise analytics team at Cone Health was really interested in trying to figure out what the effect of those renovations were on asthma, respiratory, and emergency department visits. And so that advocacy period that you see over on the left-hand side, you can see that things aren't really changing. But after construction begins and those renovations happen, you see this stepwise turn down in the number of asthma and respiratory emergency department visits. So looking at, again, not just solving this for this particular patients, but for this whole apartment complex community as a whole, and that resulting in measurable outcomes for a specific population. So again, just a good reminder of us of the ways that we can connect that midstream work and that asking with that alignment and advocacy work that can make things change for entire populations and move things like housing indicators and health indicators in the right direction at the same time. I'm going to move away from the case study for just a couple of minutes and talk us through kind of what this Healthy NC report looks like. I'm going to just kind of go through the anatomy of an indicator. And we've again got 21 of these. For each of the indicators in the report, we talk about the desired outcome. We give you a definition of what it is and tell you what the source is. And then for this one in particular, you can see that this was consistently ranked, the highest ranked in the community meeting discussion. So if this one came up and was a part of that community input, that will be indicated there. We also share the current information and the target. And of course, this was published in 2020, so that some of those things have changed, unfortunately, because of the pandemic. Too many of these have gone in the wrong direction. Some of them haven't. And then we show at the bottom, you can see how we show the current and the target and how that relates across race and ethnicity, sex, and the federal poverty level, so that it is pulling out for us those differences in so that we can pay attention and we can focus resources where they're most needed. I also wanted to point out that for some of the indicators, we're also able, like on the left-hand corner, to show if we continue in this same direction, what would our drug overdose deaths look like if the trend that has begun continues on that? And really the goal of this, and there are targets here and we would love to meet all of those targets, but one of the biggest goals of HNC 2030 is turning the curve. Something like this. Can we put interventions into place that are going to turn that and start us towards the right direction in that? So I also wanted to show that for some of our indicators, we already are going in the right direction. If you look at the incarceration rate and the forecast, that is going down, and that is a good thing. But part of what the work of HNC 2030 does is say, let's not be fooled by that forecast because we have work to do. And one of the biggest things that we have to do is look at that inequity right there, with the Black and African American rate being so much higher than the rates for whites, Hispanic, and Latinx. We have work to do to figure out the reasons for that and to take action to eliminate that health inequity. Because we know that things like the incarceration rate affect entire families. They affect income in the future. They affect communities as well. All right, so in January of 2020, Healthy NC 2030 was published, and in December of 2020, the North Carolina State Health Improvement Plan came out. Now, something was happening around that same time. Obviously, many of us had to turn our focus to response to the pandemic. So you may not, again, have heard too much about many of these things, but all of this is available to you. And I'll just share a little bit. We shared the anatomy of an indicator. This is what it looks like in Healthy NC 2030. And this is what it looks like in the State Health Improvement Plan. So these things are very, very closely aligned. I'm not going to go too much into the State Health Improvement Plan because that's really the work of North Carolina DHHS. They'd be a great, Kathy Dale and her team would be a great group to come back. but this is taking that information and asking results-based accountability questions. If you're familiar with that model of community change, saying, what is it that we really want? Why is this important? How are we doing, and what works? And moving in that direction. There's a lot of different work that has to be done by multiple organizations and individuals to achieve these. And one of the ways that you can organize that is just by tracking, tracking information over time. This is an in-development version of the scorecard that North Carolina is publishing, and we'll see and hear more about this over the course of this year. But this, I think, is really exciting work of trying to turn consensus on indicators into collective action. Now, many times NCIOM works with a group of individuals on a task force, and then our work as the NCIOM is done. And that's in part because we're not an advocacy organization. We pull people together, we make recommendations, or the task forces make recommendations on policy changes, but we are specifically not chartered by the General Assembly not to be an advocacy organization. But in this particular issue, the NCIOM is really committed to assisting with this awareness and mobilization phase. And I wanted to just make you aware of a couple of opportunities for that. First of all, the annual meeting this year, which is October 20th, it is virtual from 9 to 1, is completely focused on the behavioral health indicators of Healthy NC 2030. We've got a keynote address that will speak to behavioral health, specifically during the pandemic and specifically to health inequities. We've also got a speaker coming from the North Carolina Supreme Court's task force on trauma-informed courts, on their, I think it's actually adverse childhood experiences informed courts, that will be talking about the work of the court system to understand ACEs and to understand how they can intervene in that. And then we've got breakout sessions on overdose, adverse childhood experiences, access, excessive drinking, tobacco use, and suicide and self-harm. I'm very excited about this because we've got wonderful people from across North Carolina and from other places nationally that are going to be sharing information, again, to both make us aware and help us get good ideas to move forward on that. And the other work that we're doing as the North Carolina Institute of Medicine is that we're focusing our 2022 North Carolina Medical Journal issues on each of these domains that are within Healthy NC 2030. So starting in January of 2022, we'll be doing a full issue on social and economic factors. In March and April, a full issue on the physical environment. And then we'll also have, of course, clinical care and behavioral, and health behaviors as full issues in 2022. So again, many resources and many ways for us to continue to learn, become more aware, and think about ways that we can mobilize to work together. I'm particularly interested in the ways that people find this useful and in the barriers or the questions that people have about this. I think we have a couple of minutes now potentially to do some question and answer, but I've got my contact information up here, and of course that's available through the Medical Society or on our website. I believe that we'll be sharing slides with you so that you can click on these links as well to get to many of the documents that I mentioned while I was talking. All right, I'm going to take a breath and we'll get ready to hear any comments or questions that you may have as well.
Kathy, this is Franklin. Thank you for that wonderful presentation. A lot of great information there. I'm not seeing any questions in the chat right now. So if anybody would like to ask a question, please unmute and ask Kathy your question. And we'll give a few minutes for questions.
This is Lisa Kaufman from Watauga Medical Center in Boone. And obviously you had to give a very high level overview, but I'd be interested in whether you've parsed the data also by all the variables with attention to the socioeconomic factors, because like up here, there is very little racial disparity. 97% of the people in our catchment area are white. And most of the others are associated with the university, and many of them are faculty. So this might be one of the few places in the world where being African American actually means you have a higher income than a lot of the white population.
Mhm.
But we have the same issues. And I think when you look at the Appalachian catchment area, it's really helpful if we can also make sure that we have the same access, but not, how can I say it, not only through a racial disparity lens. So, I mean, that may be in the links, but I think it's important for us who are trying to use the data up here.
Thank you. And will you share your first name again? Was it Lisa?
Yes, ma'am.
Okay, great. Thank you for that. Yeah, I mean, this is the hard part about this is to create something that's not 705 pages long, but that gives people enough information that they can start to work on these things. Watauga County, if I remember correctly, is also often close to like #1 in the county health rankings. Does that sound familiar to you, Lisa? Like very, very strong on many of those indicators on the county health rankings model.
It's pretty good considering the large number of people that are living in poverty. And I attribute that to the very strong voluntary social safety net.
Mm-hmm.
But our catchment area isn't confined to this county.
Mm-hmm.
And the surrounding counties do not share that health status.
Right, right. And I think it's, when we think about that, I like to look at the county health rankings and I take them all with a grain of salt, but I think they're helpful in some ways. And I think we see many of those things that you mentioned, which is high education level. And probably, you do have a certain amount of poverty, but you also have this economic engine of the university, which has an effect on the health outcomes in Watauga, but also is an economic engine for areas around there as well. I take your point very much that we have such important regional differences in North Carolina. We have many places in North Carolina where some of these statistics don't make sense at the county level, because they're either rare outcomes. For example, infant mortality is really, really hard when you have fewer than 20 infant deaths a year to really recognize trends in that. Nonetheless, at the state level, it really is an important indicator for us to look at. So we're always sort of navigating that difference. There is a place on the NCIOM website to get access to, there's a lot of stuff on the State Center for Health Statistics, as you probably already know, but I will send over to Franklin and others. We created some county health data pages that are the sort of county by county access to some of this overview data as well. It's not all completely aligned to Healthy NC 2030, but it might be helpful. And I take very much your point. We can't look at every single county in North Carolina as if they're the same as others. I do think, and I will credit the people who put this together, which saying that race and ethnicity is not the only salient difference, and that they're looking at sex, they're looking at income as well to try and recognize those things too. We don't have data for all of that though, and that's one of the issues. Great question, Lisa. Thank you for that.
Do we have other questions? Okay. Well, I want to thank you, Kathy, for everything that you presented today. It was fantastic, and we will be happy to share these slides with folks. And I think the contact information is going to be on those slides. Kathy, thank you again. Okay.
Absolutely. Thank you, Franklin. You guys get ready for Ruckus Health because they're coming at you. Let the wild rumpus begin. Again, I will just say in closing that I'm very, very interested in people, especially people that work most directly with patients, looking at this stuff and saying, this is where I get it. This is where I don't get it. This is where I need help to connect on that. Because that's really, I think, such a critical missing piece. You can see that I'm really trying to figure that out with some of the things that I presented today. But if there's something that you think would be useful for me to know, I do hope that you'll contact me at my email address or, in any way, and that we can continue to have dialogue about this. Thanks a lot. Take care.
Super. Thank you. Okay. That was a great way to kick this summit off. And Kathy provided a great intro to Doctors Brian Asbill and Mike Cowan, who are our next presenters. They are the co-founders of Ruckus Health. So let the wild rumpus begin, right, Kathy? And they are both certified lifestyle medicine physicians. So Brian and Mike, take it away, please.
Thanks, Franklin. I'm going to See if I can share my screen with you guys. Can everyone see the screen okay?
Yes, yes, it can.
So thank you so much, guys. Thanks for allowing us to be here this morning to talk with you about lifestyle medicine. My name is Brian Asbill. I like to refer to myself as a recovering cardiologist. I've been practicing cardiology in Asheville since 2001. And around 2014, I had this pivotal interaction with a patient who he came to see me because he'd had 2 bypass surgeries, and it had been recommended that he have a third because he was having angina every day and taking nitroglycerin every day. And I happened to have a book called Prevent Reverse Heart Disease that I shared with this patient. And 3 months later, he came back to see me, and he had lost 27 pounds, which was good. His cholesterol dropped 100 points, which I was fascinated by. But what really blew me away is that this man, with 3 months of switching from a standard American diet to a whole food plant-based diet, had no angina and had not taken a single nitroglycerin in 3 months and was walking on a treadmill every day for 30 minutes. And that was the beginning of the end of cardiology for me, and the beginning of a new relationship with my college friend, Mike, who I'll let him introduce. And we were focusing on letting that wild rumpus begin.
Thanks, Brian. So I also had a different but similar experience to Brian. I've been I'm a neurosurgeon in Charlotte, North Carolina. And about 4 years ago, I switched to a whole food plant-based diet after being told by my primary care physician that I would need to start thyroid replacement for Hashimoto's hypothyroiditis. I was extremely active, did triathlons, played tennis. I was nonstop movement. But I was really despondent that I was about to have to start medication at age 50. So I had heard about the book, How Not to Die by Michael Greger. And because of my attention deficit disorder, I couldn't read it. So I watched a YouTube video instead. And within about 30 minutes was absolutely floored that in 35 years of medical education, this was the first time I was ever hearing anything about the power of whole food plant-based nutrition to not only prevent, but to completely reverse some of our chronic diseases like coronary atherosclerotic disease, type 2 diabetes mellitus, hypertension, and the list goes on and on. So I just decided to give it a go. Started a plant-based diet, which in retrospect was not a very good plant-based diet, but a week later, with no meat and dairy, I couldn't believe my energy levels. I'd actually given up caffeine, which I was a coffee addict. Within 2 weeks, I felt better, trained better, everything was better. So I just kept going. 6 months later, I got my labs redrawn, and much to my doctor's surprise, my labs had completely normalized. And that was after 5 years of elevated TSH. So that got my attention. 2 years later, I decided to leave private practice neurosurgery and to pursue endeavors with lifestyle medicine. And Brian and I rekindled a college friendship. We co-founded Ruckus Health with my sister, Susan Cowan Morse, and Fred Byers, who is here in Charlotte. Susan's in New Hampshire. And our goal is to, as the definition of ruckus is to cause a disturbance or a commotion. We realized that the healthcare system can't really be significantly changed, and we need to create a new healthcare system different than the current sick care system. And that is our goal, to bring that to individuals and organizations in the North Carolina area right now, but hopefully regionally and then nationally. I'll let Brian go ahead and get us started with the talk.
So thank you to the North Carolina group and to the organizers for the conference. We really are pleased to be here. We want to talk with you for the next 45 minutes or so on lifestyle medicine, longevity, health span, and a Japanese term called ikigai. I love this quote, and I've attributed it to a wise man because I'm not sure who it came from. It could have been a wise woman. It was certainly a wise person. That your health is not everything, but without your health, everything is nothing. The first time I heard this, it took me a minute to really figure out exactly what it meant. But we are all going to die. And we need to shift our focus sometimes from simply focusing on living longer to living better in the years that are given to us. And at the end, that will come back full circle to this Japanese concept of ikigai. I want to show you just a short 1-minute video. You may have seen this before, but I've seen it 1,000 times. It is so well done. It's Canadian, but very germane to the situation right now in the United States. You might want to adjust your volume depending on your volume setting for the video.
What will your last 10 years look like? Will you be quick enough for a game of tag with your grandchild? Strong enough to embrace every moment? Will you grow old with vitality? Or get old with disease? It's time to decide. The average Canadian will spend their last 10 years in sickness. Change your future at makehealthlast.ca.
I think the video is so well done. As a cardiologist for 20 years, I've taken care of the gentleman on the right. And after learning about lifestyle medicine over the past maybe 8 years, I'm just convinced that in the vast majority of cases, we can reverse the chronic disease states that we all see as providers on a daily basis, so that our patients can actually die young as late as possible. Sorry, I should have muted my phone. So I think we need to think more about health span instead of simply lifespan. We're used to thinking about health span. If you look at the dark line here at the bottom, this black line, this is the average United States population. And most people live to over 80, but the last 20% of their lives or so are spent with chronic disease states that rob us of the joy of living. So what we need to start thinking about more is health span, compressing that morbidity to a shorter period of time so that you're operating at optimal health until the very end of your life when, as I said earlier, we all die. So we want to increase health span and compress morbidity and really recapture the joy of living. So what we want to discuss today is our failing current medical system, how lifestyle medicine can cure us and the system, optimal nutrition for optimal health, our experience with lifestyle medicine, and then how can we each individually live longer and better, and how do we teach our patients about that? So these are the leading causes of death in the United States in 2019, and I don't think there are any surprises here. All of us were well aware that heart disease and cancer are by far the number 1 and 2 most common causes of death in this country. But if you look at the others on this list, there are a lot of other disease states here that are lifestyle behavior related. Chronic lower respiratory diseases in smokers, stroke, same atherosclerotic process as coronary heart disease, Alzheimer's, which has increased about 90% in the first 15 years of this millennium. I'm not sure about the increase since around 2015, but up about 90% from 2000 to 2015. Diabetes, of course, and then things like chronic kidney disease.
Brian, this is Mike. I think the volume went down after that video, and I'm noticing a lot of people in the chat have noticed it too. So I don't know if it's your volume or something else.
I don't know. My volume's all the way up. Is that
okay? It's still down low for me. I don't know if anybody else wants to comment.
I can hear again. I did have to go down into the corner of my computer screen and turn the volume up to be able to hear Brian.
Okay.
Yes, I agree. I think that's the only thing to do. To just increase your individual volumes on your respective laptops, I think will help.
Okay. Thanks. I just wanted to be sure people could hear.
Yeah, that's great. I'm glad you noticed that. I don't know how that happened. Maybe it was related to the phone call that I ignored. So if you look at the actual causes of death, you see that tobacco, poor diet, and physical inactivity, they really are the causes of our death in this country. And about 80% of our deaths are caused by our lifestyles. You know, I like this. This quote is from Sir William Osler's textbook, The Prevalence of Coronary Heart Disease in North America. This is about 100 years ago, that you could expect one heart attack per year in an average hospital in an average sized town. Those were the days of easy cardiology call. Today, the number of heart attacks is actually 4,000 per day. And I had the Mission data. My hospital system is Mission Health System here in Asheville. And as you probably all know, was sold to Hospital Corporation of America 2.5 years ago. This was the data from 2019. We took care of 625 STEMIs, which is ST elevation, myocardial infarction, the big heart attacks, almost 2 a day. Over 1,600 PCI cases. PCI stands for percutaneous coronary intervention, so things like stents and balloons, almost 5 a day. Heart disease today, in really the treatment of all chronic disease, is very much focused on pills and procedures. In 1990, we spent $40 billion on prescriptions. In 2015, 25 years later, we spent $330 billion on prescription medication. So a 900+% increase. That is enough prescriptions filled in 2019 for every person in the United States, man, woman, and child, to be on 11. That is not an efficient system, and certainly an expensive system. As we all know, we have the most expensive system in the world for healthcare, and it's not close. Second place is not close. And our results are just not commensurate with the level of spending. You can look at different things. I think the last one I saw, we were like 41st, just under someone like Bulgaria. And that's just, if that was a business, I tell people, you wouldn't sell it, you'd just close it. So we've got to do something about that. And this is 2011 data. 180,000 serious or fatal adverse drug reactions were reported. So if you go back to that actual causes of death slide, that would make adverse drug reactions number 4. So certainly not a system that works for us. And of course, the procedures that we talked about in heart disease, as we all know, that's bypass surgeries, angioplasties, and stents. Now, there is a subset of patients for whom bypass surgery is associated with improved mortality versus medical therapy or stenting. That essentially that boils down to patients with multi-vessel disease who are either a diabetic or have cardiomyopathy, so weakened heart muscle squeezing function. But for most patients, it's about symptom relief. And it's not as well known, I think, that about up to half, a third to half of bypass grafts will develop at least a 75% narrowing within the first year to year and a half after surgery. We do many more angioplasties and stents than we do bypass surgeries. And again, that is most useful for symptom relief. Certainly there is a mortality benefit if you're in the middle of an ST elevation MI. If you're having a big heart attack and you have an acutely occluded artery, we need to open the artery, and there's mortality benefit, but most of those procedures are being done for symptom relief. So this doesn't make sense. This is really what this always reminds me of, is the Indian fable of the blind men and the elephant. And you see the gentleman on the right there grabbing the elephant by the tail and would describe the elephant perhaps as a rope or a whip. And then the one next to him has his hand on the side of the elephant and would say, the elephant is clearly like a wall. You have someone else grabbing the ear, might say that the elephant's like a large fan. The elephant in our waiting rooms and in our operating rooms today is chronic disease. The cardiologist is treating chronic disease with bypasses and stents, the neurosurgeon perhaps with back surgery, the oncologist with chemotherapy, the bariatric surgeon with bariatric surgery. No one is looking at the big picture, and the big picture is lifestyle-related chronic disease. So this is really what the health treatment pyramid should look like. And this is from Mark Brahman, who's a fellow with many of us in the American College of Lifestyle Medicine. Lifestyle must be the foundation of this this healthcare system. And when necessary, we can add to it physiology, natural therapies that restore healthy physiology. In this, I would put physical therapy in this level of the pyramid. And I'm not saying, please understand, I'm not saying that there's not a role for, none of us would say there's no role for pills and procedures. It's simply that they need to exist here at the apex of the pyramid, and they cannot function as the foundation for our healthcare system. It's still strange to me that I can recommend a whole food plant-based diet for my patient with, recurrent angina who's already had bypass surgery, and that is seen as radical and crazy. And sawing someone's chest open with the skill saw and taking their veins from their leg and plugging it into their heart and asking those veins to be arteries, that's considered normal. If you just landed here from Mars, you would say, oh, these poor people, they don't get it at all. So I love this quote by Thomas Edison. This is also about 100 years ago. The doctor of the future will give no medicine, but will instruct his patient in the care of the human frame, in diet, and in the cause and prevention of disease. I think we are slowly moving in that direction. And really what people ultimately want, what they need, is not more healthcare, but better health. So let's talk about that.
Thanks, Brian. What a great quote by Thomas Edison. Very, very telling. So lifestyle is actually the cause and it's the cure of today's medical dilemma. Next slide. So the definition of lifestyle medicine is evidence-based practice. It's important to understand this is evidence-based compared to other types of medicine that are practiced. Lifestyle medicine is evidence-based practice of helping individuals and families adopt and sustain natural, healthy behaviors that affect health and quality of life. So what you do is actually more important than what you know. We all know we need to eat fruits and vegetables, but it doesn't matter how much we know if we don't actually do something about it. Next slide, please. So the American College of Lifestyle Medicine was founded on these 6 basic pillars. And again, I want to reiterate that it's all evidence-based. And the cornerstone of lifestyle medicine is a whole food plant-based diet. That's been shown to not only prevent, but reverse many of the diseases that we've mentioned so far. The other tenets or pillars are increasing physical activity, developing strategies to manage stress, cessation of tobacco and other risky substances, to improve sleep. And I would stress sleep is almost as important, if not more important, than diet, and forming and maintaining meaningful relationships. Next slide, please. Let food be thy medicine, and medicine be thy food. So this is often attributed to Hippocrates, but in fact, we can't find any records that he actually made this statement, but it certainly fits with some of his wise teachings. Take a look at this picture. For all of the healthcare professionals here, how familiar does this look? You go to make rounds, you see your patient, regardless of the procedure or what they're in the hospital for, and this is what they're being fed. Eggs, looks like some potatoes there in the left corner, some sausage links, some milk. That looks like a little bit of cantaloupe down in the bottom right. I don't think that it's put in a location where the patient can actually reach it. But ironically enough, for the vast majority of patients who are in the hospital, what's on this plate is exactly why they're there. And so what do we feed them while they're there? We feed them the same thing that's killing them. Next slide.
Mike, that patient was post-op day 1 from Cabbage. And when I walked in his room, he actually told me, hey, I think we're working on repeat business.
That's pretty sad, but that's very, very true. So the American diet, also called the Standard American Diet, which the acronym is SAD, the American diet is designed for disease. 51% of our current American diet is refined and processed foods. 42% is dairy and meat and animal foods, and only 7% of the American diet right now is constituted with fruits and vegetables. So you don't have to be a dietitian or healthcare provider to know that something's wrong with this picture. Also want to mention here that cholesterol can only be found in animal products. That's very important to understand. And fiber, conversely, can only be found in plants. So this diet that's on this slide is extremely fiber deficient and a great diet to elevate cholesterol. Next slide. So David Katz likes to say that the master levers of destiny are our fingers, such as bringing the cigarette up to our mouth to smoke, our feet, whether or not we propel ourselves, and lastly, our forks. What's on the tip of our forks decides what our health and wellness is going to be like. So take a look at this. No wonder the average American is completely and utterly confused about what is healthy and what is good for them, because it's being told to them by the news media and the marketing from companies that are trying to make money, not actually promote health. So if you don't keep up with the data, you don't really know what to do. And unfortunately, the average person doesn't know where to look for data. Next slide. Michael Pollan really did a great job of summing up the basis for how we should eat. Eat food, not too much, and mostly plants. And if we can shift from processed food, animal, and dairy to plants, we'll naturally become healthier. I want to give you one quick anecdote before I turn it back over to Brian. My stepfather is 92 years old. His mother died at 103. I didn't, unfortunately, get those genes. But he tells me that when he was a young child, and even into his teenage years and young adulthood, meat was an absolute luxury. And if he had meat once a week, that was considered a win. And of course, back in those days, really most of the processed food that we're accustomed to today that constitutes 51% of our diet, it just didn't exist. So they ate fruits and vegetables and beans and grains. So, you know, our grandparents and our great-grandparents, none of this is a surprise to them. And what we want to do at Ruckus Health is not reinvent anything or create anything new. We just want to get back to the ways that older people and generations before us know is what was successful for health and wellness. Okay, Brian.
So we wanted to share with you guys some of the nutritional data. And this first one from 2012, this is the second Adventist health study. And that may be familiar to many of you, certainly all of you who studied for the board certification are familiar with this study. This is a really an interesting group of patients to study because the Adventists, as you may know, mostly in Loma Linda, but there are quite a few actually in Asheville as well, see, because of their religious beliefs, they see the body as the temple. And for that reason, they tend to engage in more healthy behaviors than the standard population. Specifically, when related to diet, they tend to eat more plant-based. There were 90,000 people in this study, and this is sort of how they broke out. The majority of them were non-vegetarian, so it's sort of, again, the standard American diet, omnivorous. Some were semi-vegetarian, they just ate meat less often. About 10% were pescatarian or pesco-vegetarian. They ate fish as their only flesh food, but also eggs and dairy. A full third were vegetarian. It was sometimes called lacto-ovo-vegetarian. No flesh foods, no poultry, no fish, no beef, but dairy and eggs. And then about 5% were vegan. This is interesting. You're looking here at body mass index in this first column, diabetes and hypertension. And if you set the reference as the non-vegetarian with a hazard ratio of 1, what you see is that as you eat less meat, whether or not you're semi-vegetarian, pescatarian, vegetarian, or vegan, as you decrease your animal products, you approach and, for the vegans, actually reach ideal body weight, in this case defined as a BMI, body mass index, less than 25. The hazard ratio for diabetes was 0.22 in those who were not eating any animal products, meaning that there was a 78% reduction in the incidence or prevalence here of diabetes compared to the non-vegetarian, and a 75% reduction in the risk of hypertension. I like to show this study because if you look at the authors here, you see some real heavy hitters in the nutritional space. Walter Willett was the 25-year chairman, I think 25 years or about that, chairman of the Department of Nutrition at the School of Public Health for Harvard. Frank Hu is now the chair. Andrew Chan is also at Harvard and working with those guys. Walter Longo is the director of the Center for Longevity at the University of Southern California. Has done a lot of research in a fasting mimicking diet. His name may be familiar, but these are really the heavy hitters. At the very top of this slide, I want you to read that title, The Risk for Mortality Associated with Replacing 3% of Energy from Various Animal Protein Sources with Plant Protein. So let's put that in some perspective. Say you eat a 2,000 calorie diet, because the math is easier for me to do, and you're going to replace 3% of that energy. We're talking about 60 calories. And we're talking about protein, which is 4 calories per gram. So we're talking about replacing 15 grams of protein, switching it from animal protein to plant protein. To give you some perspective, a AAA battery is 12 grams. So 15 grams is just slightly larger than the amount of protein by weight of a AAA battery. And there are a couple of things that you want to notice on this slide without really getting too hung up in the boxes and the lines. One is that in all of these situations, all-cause mortalities, cardiovascular disease, cancer, and other, in all of those disease states, plant protein favored reduction in mortality. Plant protein was associated with less mortality. The other thing to note here are these boxes here out on the left. Those boxes in every case are processed red meat. Processed red meat reduce the risk of cancer, cardiovascular disease, and all-cause mortality. I'm from Columbia, South Carolina. You know, it was hard for me to say goodbye to bacon and sausage and Bojangles and Lizard's Thicket. And it's just going to be hard for our patients in North Carolina too. But when you look at the data, I think that the data is clear. So that the conclusion of the authors was that high animal protein intake was associated with mortality. High plant protein intake was inversely associated with mortality, especially among individuals with at least one lifestyle risk factor, which for me was all my patients, and probably for you is 95% of your patients again. Substitution of plant protein, especially for processed red meat, was associated with lower mortality. I include this one because this was from JACC, the Journal of the American College of Cardiology, which is like the New England Journal of Medicine for cardiologists. I mean, if you're going to get one journal, this is the one you get. Again, you see some familiar names here, Walter Willett and Frank Hu, among others. And I included it because for a couple of reasons. One is to point out that when we're talking about a plant-based diet, we need to distinguish between a healthful plant-based diet and an unhealthful one. Mike talked about this earlier with processed food. If you look at the hazard ratio for coronary heart disease here, the hazard actually increases with this dashed line here is an unhealthy plant-based diet. This is bad vegan. Okay, this is vegan junk food. You know, you're eating a plant-based diet if you have a Coke and a jelly donut for breakfast, but that's actually associated with worse outcomes with coronary heart disease. To get the beneficial outcomes here, we're talking about a healthful, this solid red line, a healthful plant-based diet. And here you see 2 lines that were associated with increased risk for coronary heart disease. Animal foods is the red line and the unhealthy vegan diet is the dashed line. It actually may be worse for you than the animal protein diet. Again, we're talking about whole plant-based foods. The other reason that I would show this slide is to point out that, and to thank Kim Williams, who Kim was the past president of the American College of Cardiology, and like me, had sort of an epiphany. I changed my diet after the patient that I shared with you earlier. I changed my diet I committed to 1 month. That was all a Columbia, South Carolinian could commit to at the time, was 1 month. And my LDL I was a lipidologist as well, board certified until 2018. My LDL dropped 45% in 30 days. I was blown away. Kim did the same thing and had the same experience. And so a couple of things, Kim has just really done wonders for introducing lifestyle medicine to the cardiologists in this country. He said a couple of things that I think are interesting to repeat. He said, I know I'm going to die. I just don't want it to be my fault. And he also said, somewhat more controversially for cardiologists, he said there are two types of cardiologists in the world, those that are plant-based and those who don't know the data. So we're sharing the data, and thanks to him for helping us along that path. From 2014 to 2018, 2016 to 2020, I was the medical director in Asheville for the Ornish Reversal Program. And that sadly went away at the end of December of last year when HCA terminated that program. We're going to be migrating to a Pritikin program, which I am excited to roll out, hope will be equally impactful for our patients. For those of you who aren't familiar with the Ornish program, it consists of 4 one-hour sessions together twice a week. This is a big commitment for patients who are looking for cardiac rehab programs. You come 4 hours on Tuesday and Thursday, 8 hours a week for 9 weeks for a total of 72 hours. You learn a lot. Each of these domains is equally weighted. So we would feed people a whole food plant-based diet and lecture to them about the benefits on their health. Exercise for an hour, stress management for an hour, which was mostly yoga, hatha yoga and meditation, and then community, which is our group support session, which by the way was the only hour that I was not, as the medical director, I was not allowed to participate in. So what happened in group sort of stayed in group. I could participate in these other modalities. And frankly, I was very comfortable with the nutrition thing by this time, and I was comfortable with the exercise piece. I was learning about, interested in the stress management piece, now more a part of my daily routine. And I just completely disregarded, to be honest, the community piece at the beginning. But what I heard routinely from people who finished this program was that it was the community piece that allowed the other pieces to happen in their lives. And Mike, talking about the domains of the ACLM in that circle, that community piece, the last mentioned, and the last I've mentioned here, frankly, in my opinion, now may be the most important piece. So that's why I think that meeting together and like we are and talking about this is just so valuable. This is really important. I tell my cardiac patients, if you're falling asleep, wake up for this piece. This is the important slide for you. What Ornish did was everyone had a heart cath and then was randomized either to optimal medical therapy or to his lifestyle program. Optimal medical therapy at the time was primarily aspirin, beta blockers, antihypertensives, and antianginals. At 1 year, everybody had a cath again, and you can see there was a slight progression in the medical group and a slight regression in the Ornish group. People didn't know what to make out of that, so we carried it out to 5 years. And at 5 years, what you can see here, third heart cath, by the way, was that there was about a 28% relative worsening in the control group, more stenosis, and about an 8% relative improvement in the Ornish group, which led to the idea of cardiovascular disease reversal. And we still have patients that say, or providers, frankly, who say, I don't believe it. And I would even tell patients, somewhat startlingly to them, as a clinical cardiologist, I frankly don't even care whether or not you have a 42% blockage or a 37% blockage or a 50% blockage. What we care about is making people feel better and live longer. And so that's what we need to focus on when we look at, in my opinion, what we need to look at in the Ornish data is how do people feel? They had a 90% decrease in angina, similar to my patient that I told you about, versus a 165% increase in angina over 5 years in the medical therapy group on anti-anginal medical therapy. And did they live longer? In fact, they did. At 5 years, they were 2.5 times less likely to have a cardiovascular event, including fatal or non-fatal heart attack, compared to the control group or being the medical therapy group. I think it's interesting as a lipidologist too, to look at the LDL reduction. There was a 20% LDL reduction in both groups. Now there was a 60% in the medical therapy group were on statins, Today, this is 1990 when this data was initially published. Today, of course, it would be 98%. And as many of you have experienced, your bonus may be related, your hospital bonus may be related to how many of the patients actually are going home on their medical therapy. But note that the LDL reduction was the same, and that the medical therapy group did not do as well as the lifestyle group. It's sort of reminiscent of the diabetes prevention program again, isn't it? For those of you who are familiar with that program. Almost all patients stopped to reverse their coronary heart disease and averaged a 300% increase in their blood flow on PET scanning. This works. It works, it works, it works. But as Mike said, it's not about what you know, it's about what you do. Point here is that lifestyle medicine is never all or none. The Orange program is a prescriptive program, and we make a big deal out of that with participants, but change occurs no matter the adherence. If you're on the low adherence group, you get some change, but the more you are adherent, the better the change. It is not all or none. Don't let perfect be the enemy of good in our patients. These are data from the first quarter of 2019. And as you would expect, all of these biometrics are moving in the right direction. Weight loss, BMI, this should be a minus. Total cholesterol is down, triglycerides are down, blood pressure's down, A1C is down. And as you can see here, depression score was actually cut in half and exercise capacity increased by 50%. So this speaks again to the quality of life and the joy of living and adding really life to years and not simply years to life. It's important to note that I've been presenting a lot of the cardiology data. Our oncology colleagues are having the same discussion. These are the 2018 prevention recommendations from the World Cancer Research Fund and the AICR. And it looks like the wheel that Mike presented earlier. Be a healthy weight, be active, eat the right foods, don't eat fast foods and fried foods, limit the consumption of red and especially processed meat, don't consume sugar, limit alcohol. This is exactly what cardiologists are talking about. This is a chromosome. Probably haven't seen this in a while. The green ends here are the telomeres, and the telomeres are essentially the caps on the DNA to prevent it from unwinding. It's kind of like the plastic ends on the end of your shoelaces so that things don't unwind. What Ornish showed is that in his group, we actually increased telomere length. And increasing telomere length is associated with longer life. This is what happens as we age. As we age and cells divide over time, that telomere gets shorter and shorter and shorter with each division, and ultimately there's no telomere left. And when there is no telomere left, that cell undergoes apoptosis, which you'll remember is programmed cell death, and that cell's gone. We can actually increase telomere length by eating right, by not smoking, by exercising, by having the right relationships, not just with ourselves, but with our communities. And on contrary, on the other flip side, when we don't have those things, our telomeres actually do shorten. I'm also interested in this. This is men with early prostate cancer, so low PSAs, who did not have any sort of surgical intervention. No surgery, no radiation, no hormonal therapy. They participated in the Ornish program. And what you see here on the left, the red squares are oncogenes, which are cancer promoters. The green squares are tumor suppressor genes. 3 months after being in the Ornish program and eating a whole food plant-based diet, tumor suppressor genes, the green squares, were upregulated. There's more of them. There are fewer of the red squares, the oncogenes. They were downregulated. They were turned off. And patients actually had improvement in their PSA levels. That's the first time that had ever been shown. This is from 2008, the Proceedings of the National Academy of Sciences. This goes to the concept, speaks to the concept of epigenetics, which if I had to do it all over again, I would be interested in epigenetics and particle physics. I wouldn't be very good at it. I'd be the dumbest guy in the room, but it's just so interesting to me. Epigenetics is fascinating. It really is about turning on and off genes, affecting not the genetic code, but your genetic expression. And the classic example of this is the so-called agouti mouse. And you can see here the agouti mouse, when the agouti gene is expressed, is a fat yellow mouse. And that mouse, just like an obese person, is at increased risk for diabetes, mouse diabetes, and also at increased risk for certain cancers, also the case in humans. So what they did is they fed the mom mouse, the agouti large yellow mouse, with regular mouse chow or mouse chow supplemented with some vitamins that you can see down there at the bottom of the right part of the screen. When they were fed the rat chow plus, mice chow plus, the agouti gene was methylated. A methyl group was attached to the outside of the gene, literally epigenetic above the gene. And that methyl group turned off the agouti gene so that it was not expressed. The baby then was a thin, normal looking brown mouse who is not at increased risk for diabetes and not at increased risk for certain cancers. Absolutely fascinating that the mom's diet affected the health outcomes of the offspring. Classic example of epigenetics. So that brings us to this slide, the Power 9. And I think many of you are probably familiar with the Blue Zones and the Blue Zones project. Dan Buettner arguably has the best job in the world, traveling the country, the world for National Geographic and being paid to do it. And he found 5 areas in the world that had the highest number of living centenarians, so people over 100 years old. Okinawa in Japan, Ikaria, Greece, Sardinia, Nicoya Peninsula in Costa Rica. And I was initially, quite honestly, shocked to see a blue dot on the United States at all. And of course, that's in Loma Linda, California, which, as I mentioned earlier, is really that was the epicenter of the Adventists. And they're eating differently than we are, and they're living longer than we are. And then Dan gets to go around the country giving the same lecture over and over, and just meeting fun people. And again, what a great job. So he boiled it down to what commonalities do these people in these disparate places, what commonalities do they have that might be contributing to their longevity, and how then can we individually and collectively incorporate those behaviors so that we see similar benefits? How can we create our own blue zones to live not just longer, but better? So the first is to move naturally. Except for Loma Linda, where they were going to the gym, most of these other communities, they're not going to the YMCA. They're not doing high intensity interval training. They're just active. They are spurred to action, moved to action because of their daily environment. They're working out in the garden. They're walking to their friend's house. They're walking to the market. They're naturally moving throughout the day. It doesn't have to be in the gym. The 80% rule kind of goes back to Pollan's not too much. The Japanese have a term for this. It's called hara hachibu, which literally translates to eat until you're 80% full, which is not the American way, is it? I mean, it's just the opposite of the all-you-can-eat buffet. Plant slant, we've, I think, spent plenty of time on that. Mike's addressed that. Wine at 5 is somewhat controversial. I'm glad it's in there because I like wine and it's plant-based, and I don't want it to go away. But it is controversial because alcohol clearly is related to an increased risk of some cancers, including breast cancer. And we're not really sure how much of it really is the alcohol component versus just the social component. Brevard, North Carolina, as many of you may know, has a Blue Zones project underway. We just met with that group earlier this week to learn more about it in Asheville to see if perhaps we could replicate something like that here. And they've actually changed this to, what did they change it to? Friends at 5. To really focus on the social aspect. And frankly, they told me that we're introducing all this into the school system. And it's kind of hard to go into this public school system and talk about wine at 5, but we can talk about friends at 5 and not get thrown out. Know your purpose is huge. This is in the Blue Zones data. it seems that knowing your purpose, why are you here? What are you doing with your life? Adds 7 years to your life. This is time well spent. And this is the Japanese concept of ikigai, which means your reason for being. As you can see there in the center of the slide, it is the intersection of what you love, what the world needs, what you can actually be paid for, and what you're good at. I also like this quote by Howard Thurman that really sort of qualifies that for me to some degree. Don't ask what the world needs, ask what makes you come alive and go do it. Because what the world needs is people who have come alive. And so that if you cross out what the world needs and we're not going to worry about what you're paid for, then we're left with the intersection of what you're good at and what you love, which is passion. So when I think of ikigai, I think of ikigai with sort of a Northwest focus on purpose and passion. So finishing up the 9, downshifting. Downshifting is simply having some routine for shedding stress in our lives. The lion is no longer our stressor, and our stressors are things like emails and bad internet connections during a Zoom meeting, and people can't hear the volume, and traffic jams and things that are just a product of the current world. We have to have some way to deal with that chronic stress and cut that cortisol production down, off ideally if we can, but down, so that we can really live as we were meant to. Belong speaks again to that community aspect. In a lot of the blue zones, quite frankly, this was belonging to faith-based communities. And it added somewhere between 4 and 14 years of life. And it doesn't have to be a faith-based community. It has to be a community that you feel like you are an important member of. The ACLM community, for example. Family first. These people in these places, these blue zones, celebrate family. They live in multi-generational homes. They care for their elderly parents. They have kids around all the time, learning from their elders and passing down the wisdom of generations. And that is important. And finally, the right tribe. And the Japanese term for this was moai. And in Brevard, in their Blue Zones project, they're putting together moai. Actually, in Japan, when you're born, your play group, I say, would be the American version of this. The 3 or 4 or 5 little kids that you're crawling around with, those are your moai, and that's the tribe that supports you for life. So when you're 94 years old, you have gone through your life with that group, that small group of people. Those are your people. When you've been asked, and I know you have been, if the shit hits the fan, who are you really going to call? I mean, who's your one person that you know will drop everything? It's your moai. And then Japan, you knew exactly who to call because you've known them from the first day of your life. So in summary, our chronic diseases are not the cause of our healthcare crisis. Genetics are probably responsible for somewhere around 1/3 of healthcare outcomes. Our lifestyle choices are. Epigenetics really probably responsible for maybe 2/3 of our outcomes. We can nurture nature. Our genes are not our destiny. And it's a gradual process. Any change that you make will benefit you. Small changes bring big results over time. And you can see these results very quickly. We're in a pilot project now with a group doing a lifestyle medicine program, and we're doing second biometrics at 2 weeks. That's not a long time, but that's enough time for us to impress on the participants that these changes can happen very quickly. My patient's angina was relieved within a week, and I think that's an important message. So as David Katz, who is the ACLM president, said some years ago, lifestyle is the medicine. Education really is the first step. You don't know what you don't know. And as Mike always tells me, once you know it, once you see it, you can't unsee it. So lifestyle is the medicine. Education is the first step. It is based on good science. And then we need to change the culture. The culture is what supports the behavior changes. As Mike said, it's not about what you know, it's about what you do. So the culture, the blue zone, creating that community so that the healthy choice is the easy choice, that's what allows us to translate that knowledge into behavior change. And and ikigai. I hope that we're all coming alive at this conference, and that you will help us in some way change the culture of healthcare in our country. I think we ended at a good time. So Franklin, I'll let you direct us on questions.
Sure, and thanks. That was a great presentation. I think that there was a question in the chat that might have been forwarded to you guys, but let me read it to you and we can address it. Are there any studies that compare grass-fed pasteurized meats, eggs, and dairies for those sources with plant-based diet?
Mike, you want to comment?
Yeah, Brian, I saw that pop up while you were talking, and of course I've got an immediate response. I cannot off the top of my head think of the studies. I know they're there, but the problem is no matter how healthy the animal food is, it contains the animal proteins that actually cause disease. So, and if you can remember, Brian, I do believe there are some studies, but I hesitated in typing back in that chat because I wanted to give accurate information.
No, I think you're right. I might add that the protein is the key here, but also that I think they are healthier. The pasture raised grass-fed is healthier with a better fatty acid profile, a better omega-3 fatty acid profile, and less fat. But I kind of feel like it's saying that light cigarettes are better for you than cigarettes, less tar, less nicotine. They're still not a good choice relative to, the choice is always about relative to what? Is this good for me? Relative to what? It's better relative to feedlot beef, but it's not as good for you as salmon, is not as good for you as broccoli. So, I think I hear your question, and Mike and I have talked about this a lot too. It's not just about the health, individual health, it's also about the health of our planet. And there's no doubt that it's, plant-based is better for the cows, no matter whether or not they were pasture raised or not.
Hey, Brian and Mike, if you don't mind me jumping in here too. The other thing to be careful about is understanding what does get labeled in those manners, because I'm not an expert on this, but from some of what I've read, something that's labeled as pastured meat, it just means the cow had to have access to a pasture, but not that it was actually spent a whole lot of time there. And
Yeah.
Same thing with cage-free eggs. A lot of times all that means is that the chicken was maintained in a slightly larger area, and yet you're still doing all the unhealthy things. You're still giving the antibiotics and the steroids and that. And so that you've got to be really careful, because how things get labeled may be somewhat misleading based on what our federal guidelines say. So just another thing to think about there.
I think that's a great point, Bonnie. And I always joke with Brian that when I'm ready to eat an egg, it's going to be from my neighbor's hen house, or when I'm ready to have a steak, it's going to be from the cow that I know that's in the pasture down the road. Interestingly enough, after a while of eating a whole food plant-based diet, you lose your taste for all of that. And in fact, the animals are just the intermediaries anyway. I mean, when people ask, where do you get your protein from? Well, the protein actually came from the plants that the animals ate. And unfortunately, the cow in a feedlot is eating a genetically modified grain that we're growing on land that we've deforested most of the forests to grow. So it's, to Bonnie's point, that's a really critical thing to think about. Even if you don't want to change your diet to increase or switch to whole food plant-based, at the very least, look for some more local sources, because the bioaccumulation in animals is significant. And certainly plants are sprayed with Roundup, and that's a concern, but the bioaccumulation is much lower than it is in an animal.
Okay, we have several questions, guys, that are in the chat. So I'm just going to read them off to you. The first one is, how can lifestyle medicine / Ruckus address the COVID-19 challenge we face?
Thank you. I actually had that on my list of things to mention. that it's interesting now, a year and a half to 2 years into this, the studies that are coming out on people who are on whole food plant-based diet and their risk of COVID, it's extremely low. And as we know, the biggest risk factors for hospitalization with COVID are a comorbidity or obesity, and that all has to do with the gut microbiome. So if you're on a whole food plant-based diet, you have a gut microbiome that is stable. The vast majority of our immune system is actually in our gut. That's the number one interaction in our environment. And so once you've stabilized that immune system, you're much healthier and safer. To me, lifestyle medicine is about reducing stress, and stress can be psychological stress. It can be physical stress, emotional stress, but we forget about the fact that what we put in our gut, if it actually causes stress. So when you do eat a whole food plant-based diet, it significantly reduces the stress on the system. And like Brian said earlier, actually decreases your risk of depression, risk of suicide, and increases your sense of well-being. But there are some studies that are coming out, and a lot of the experts like Kim Williams, who Brian mentioned, have spoken to that. You got anything to add, Brian?
Okay, I'm going to read you another one. This is from Josh, and he wants to know, are there any recommendations for books and websites with specific plant-based meals recipes, starting with Not How to Die, and he'd love to give this to some of his patients. So maybe instead of ticking that off, you guys can post some of that recommendations in the chat so everybody can pick that up.
Yeah.
The next question is from Alex, and he says, is plant-based protein powder considered processed?
Brian?
Yes.
Yes. Okay.
It's protein powder. I mean,
okay. That sounds like, go ahead.
A second. Yes, it's processed, and it's better for you than whey protein. And unless you probably don't need the extra protein, honestly. The protein requirement is 0.8 grams per kilogram of body weight. If you're an athlete, you probably are, if you're asking this question, doing high intensity interval training, a lot of cardiovascular work, muscle building, you probably need more like 1.6 to maybe even a high of 2 grams per kilogram. And I think if you really just do a dietary recall for 24-hour dietary recall, write down what you ate, I think you'll see that you don't need that extra protein from the protein powder. But yes, it is processed food.
Thank you. And as a follow-up, Carol wants to know, do you recommend taking supplemental vitamins? I bet I know the answer to that one. Go ahead.
Mike, do you have a comment there?
Well, you're more educated in this than I am, but you really, if you are really on a whole food plant-based diet, then you really don't need supplements other than vitamin B12. And in fact, the vast majority of the American population is deficient in vitamin B12, even if they eat animal products, and they get the vitamin B12 from the fecal contamination of the animal products, by the way, which that was earth-shattering to me to realize. But that's really the only thing. Adequate vitamin D, if you're not getting sunlight exposure, you might want to supplement. But other than that, Bonnie or Brian, if you want to add to that, I don't think there's any real need.
There's not. I was looking through the book, Whole. Have you read that one, Bonnie? Colin Campbell's book, Whole, H-O-W?
Yes. Yeah.
I think he's right on about this. I mean, all of the supplement studies have been very disappointing. Have not shown that they make us feel better or live longer. You're getting everything you need from that, eating the rainbow in a whole food plant-based diet. The body knows exactly how to extract exactly what you need from your diet. And it's packaged in the right way. It's packaged as nature intended to interact in the way that it should. The vitamin C, for example, is packaged with the iron, which facilitates iron absorption. So yeah, I agree with Mike. The short answer is no, you don't need the supplements, except for the B12.
In fact, there are some of the studies that have been done have demonstrated that vitamin supplements have worse outcomes. Looking at vitamin A and lung cancer, people taking the supplements, actually, they use smokers. They took populations of smokers and gave some of them placebo and others vitamin A. And the ones taking the supplements actually developed higher rates of lung cancer. So again, you have to be, the research has shown that your health advantage in both mortality and morbidity comes from the whole foods, not from protein powders, supplements, vitamins, that sort of thing.
Okay. This is an interesting question because it harkens back to when we did our Lifestyle Medicine Power Hour last year. In some ways, combining the previous topic presented, do you find this as more expensive diet to maintain, and how do you overcome the social determinants of health? In this case, what do you recommend to your patients that say, I can't afford organic or a plant-based diet?
Take it away, Mike.
Well, I mean, in fact, it's significantly cheaper to eat a plant-based diet. I don't want to say that my protein for the week is all the food I eat is protein, but my beans that I eat for a week come in a bag that I purchased for $2, and that lasts me for 6 days, and that's 3 servings of beans a day. And so that's significantly cheaper than any animal product that I could buy. For the people who live in food deserts, that's a whole different issue. And access to food, and organic is great if you can afford it and want to do it. But again, you're still better off to eat non-organic fruits and vegetables than you are to not eat them. And the access to food is a real issue. And that's something at Ruckus Health that we're working on with some different people, even some people who are here at this meeting, to try to come up with ways to actually provide access to food for people who just don't have access. I don't know that I answered all of that question, Brian.
If I could jump in too and say, this is a plug for sticking around for the rest of the conference, especially tomorrow, because we have some presenters tomorrow, Greg Stewart, Jen West, Dr. Wilson, Dr. Nance, who are all working with low-income families and patients, and they will have lots of great tips and ideas for how you can absolutely follow a healthy whole foods diet on a budget.
Okay, I think we've gone through most of the questions. There have been a lot of people who've posted with some books and other articles in there. But if we don't have any other questions, I'm going to close this up. And a couple of things I want to announce before we go away. One is thanks to Mike and Brian for this fabulous presentation. Thank you so much. Welcome back. I hope you all had a great lunch after this morning's session. That got us off to a rousing start. So kicking us off this afternoon is going to be Madeline Morelli, who is the Managing Attorney, Medical Legal Aid Partnership of North Carolina. And Madeline is going to be presenting on the social determinants of health. Madeline?
Good afternoon. It's wonderful to be with all of you today. I'm thrilled to be a part of the conversation and talk with you about how community partners can help you with this difficult but important effort to address the social drivers of health for the patients and families that you're serving. So I did a little pre-test. Let's see if I can share my screen again. In the beginning. And can you see that?
Yes.
All right, great. Again, thank you, Franklin, for the invitation. For those of you who wonder why there's a lawyer speaking with you, I'm a public health lawyer who has been working who went to law school at age 40, whose second life ambition behind wanting to be the first woman on the moon was to be a lawyer. And I sort of put that on hold for a little while and found my way into public health and policy by way of the HIV/AIDS pandemic and other things. So I'm to borrow someone's phrase from the morning, I'm a recovering academic. Actually, I was part of the faculty at Johns Hopkins in the School of Public Health and Health Policy and Management and Maternal and Child Health. I did a lot of consulting work with the Society for Adolescent Medicine and American Academy of Pediatrics to try and help healthcare professionals enhance their advocacy skills on behalf of the patients and families and caregivers that they served. And in the course, and also worked prior to that as a congressional staff member, working with policies and programs related to children, youth, and families. In the course of the earlier part of my career, it became crystal clear that in order to really improve health, we needed to focus on the interconnections between poverty and health. And I went to law school thinking I really wanted to learn that skill set and be able to provide direct assistance to families, but with this sort of broader lens of public health and community collaborations. So I look forward to telling you a little bit more about our organization, but much more important to talk about how it is that healthcare professionals who are overwhelmed, as we all are, and have a whole lot of things we're trying to accomplish, can get better outcomes by learning how to collaborate differently with community partners who bring a different skill set to the challenges that we're all facing. So here's our standard disclosure slide. To reiterate, as Kathy Colville did earlier, neither I nor my family members have any relevant financial or professional relationships with any commercial interests. All right, here's the agenda. It looks kind of long, but I want to parse it out a little bit. I want to introduce the organization that I work for and connect it to what the legal advocates have to do with the social drivers of health and health equity and addressing health disparities. And then in particular, the program that I run within Legal Aid of North Carolina, which is really about integrating legal advocates into team-based clinical care efforts. Second part, I'm going to go a little bit quickly through this, but I just can't miss the opportunity to share news that you can share immediately with the patients and families that you serve. There are a number of programs out there that may benefit the folks that you're serving. They may not know they exist. And as I go through part 2 here, my goal is that each slide you'll see a full link. And most of these programs that I'll be describing in part 2, we're hoping you're going to be able to connect families to those programs. And there's direct links to how to get posters and other materials. And then the third part really is to try and connect what the state's trying to do to address social drivers of health within the Medicaid managed care transition. And so that'll sort of come back to this concept of team-based care and the role of community partners in addressing the social drivers of health for the Medicaid managed care enrolled population. So that's what we're going to try to go accomplish today. So it's not a surprise to me that Kathy Colville shared this slide. It's something that we public health people do all the time. And so my question, I won't cover it much further except to say that to maybe even rephrase the question that I had typed on the slide when I shared it submitted it earlier. So my question had been, which of these are social drivers of health? And to flip it on its head, I challenge you to think of any of these that are not influenced by social drivers of health. Whether it's health behavior, your access to healthy food is driven by the neighborhood you live in, is driven by your economic situation. So I've always been interested in the categorization of social and economic factors when I think, all of these things, the quality of the housing that you live in, the quality of the air and water that that's available to you, all of these things in the Morelli opinion really are driven by that complex intersection that Kathy was describing between all of these things. I don't know of a single family that's only got one of these challenges, right? So what's the role of legal aid or legal advocates in addressing health equity and health disparities? So I'm pretty fond of the Robert Wood Johnson Foundation way of thinking about this. So, and lawyers think that every word and probably every syllable is absolutely essential. So like, I like to underline things, but health equity means that everyone has a fair and just opportunity to be as healthy as possible. And to do that, it requires removing obstacles to health, and that means poverty and discrimination and their consequences. And those consequences include powerlessness, lack of access to jobs with fair pay, and all of those other things. And you all already know this, but sort of the distinction between how health equity and health equity approaches really interconnect with the efforts to reduce and eliminate health disparities, which again are driven by social drivers of health. All right, so you say social determinant or social driver of health, and what do we say? So I like to frame the work of Legal Aid of North Carolina as examples of legal remedies to social drivers of health. So in the world of safe and affordable housing, what can legal advocates do? We can prevent improper and illegal evictions and terminations of housing subsidies. We can work with our clients to ensure that their landlords make repairs and provide services that they're legally required to do if those folks are living in unsafe rental homes. In many rural communities where you all live and work, not a whole lot of subsidized housing out there. There are a lot of small homes, owner-occupied homes where people are falling behind on or have already fallen behind on their mortgage payments. So we can often work with mortgage companies to save homes from foreclosure. And I can say this in any audience across the state, we do a lot of work around assisting people, not only in the housing world, but when natural disasters hit North Carolina, and they do, there's a lot of work that legal aid can do to assist people who are struggling, whether they've been displaced from their homes or unable to access the schools or the other services that they need. So I won't go through this every example here, but I wanted to just sort of show the breadth of the kinds of things that lawyers do. This is what's in our wheelhouse. And these are often things that your patients and families and caregivers need, but don't know that if someone's housing, they may not, or food insecure, they may not realize there's a potential legal remedy there, right? So let's go to sort of that public benefits group down, the second to the bottom group. We can help with things like access to food and other safety net supports and services. We don't help people apply for SNAP, but we can help when people's SNAP benefits have been improperly denied or terminated, or benefits have been reduced. And the same thing for Medicaid services, unemployment benefits, disability, and other things. So those are just examples. I'm going to say, okay, I just saw that there was a chat up there. I don't mind if anyone interrupts, but it's going to be hard for me to drive the slides. So if folks have questions, feel free to unmute and ask, and I'm happy to. It doesn't matter to me if we get through all of these slides. They will be available to you if they're not already. And all the slides that I'm sharing with you have full text links in case you want to get to additional information. So, all right, next slide. In trouble advancing the slide. There it is. So what's Legal Aid in North Carolina? We're statewide. We serve residents of all 100 counties. We're nonprofit. I think we're the third biggest law firm in the state, and we're free to our clients. And so we have, it's actually 25 local offices now. And so our Smoky Mountain office happens to sit in the city of Silva, but it serves those counties in the far western part. We've got a high country office up in Boone, and we've got, we're all over the state. So any one of our local offices likely serves a range of counties in its surrounding area. So our mission is to provide free legal assistance, civil matters. What's that? Well, when you go to law school, you realize there's sort of two doors you're going to go through. You're either going to go into criminal law or civil law. Most people here know what criminal law is. The civil law is the everything else. And our mission is to ensure equal access to justice and remove legal barriers to economic opportunity. So how do people get to us? 95% of the people who become our clients know they have a legal problem and either find us through Google search or know that there's some way to get to us, and they apply. They apply online, or they call us by phone, or they are directly referred by specific community partners. So across the state, we work with domestic violence agencies. We're working with survivors who may need a whole lot of things, safety plans and all kinds of stuff. And our role there is to help with domestic violence protective orders. I run a statewide program within legal aid where we get direct referrals from specific clinics, hospitals, and health systems. The eligibility for our assistance, we have to screen on income, assets, and for a lot of our work, we also have to screen on immigration status. These limits are set by our federal funder. We've got a number of statewide programs that I mentioned. I want to sort of take a pause here to give you a bit of a frame here. So pre-pandemic, we had about 100,000 applicants a year for service, and we were able to serve about 20,000 households a year. Last June, before the eviction and foreclosure moratorium were lifted, we had about 2,000 applicants a day. So that's times 365 days a year. So we are doing the best we can to help as many people who are eligible for our assistance. In addition to people who become our clients, we run the state's ACA Navigator program. So we help tens of thousands of people, not legal assistants, get access to health insurance. We help another 25,000 or so households a year understand their legal rights. And the average income for a family of four that we serve is under $13,000. All right. So many of the folks that you're serving don't know about us, don't know that we're free, don't know how to get access to information that we call sort of know your rights information. So we produce, short videos, YouTube videos, we do Facebook Live sessions. And if you're working with families who may need assistance, we hope you'll direct them to our website so that they can find information they need and apply if that's the case. All right, so the project that I run is called the Medical Legal Partnership Program. So we do the same kind of work, but it's integrated team-based care. So we work with health professionals in a variety of settings to incorporate sort of the skill set, the credentialing of legal advocates into the efforts of clinical folks in clinical settings who are trying to address the social drivers of health. So this sort of goes back to, what's the big challenge here, which is, I just love this cartoon, Jack Maypole, if you don't know him, he's fantastic. I love this, hooray, that ear's better, anything else? And this mother's thinking, did she really just ask me that? And eventually that pediatrician might say, did I just really ask her that? Because we all know that it's really hard to do this. We can't do it on our own. It was only 10 years ago that the Robert Wood Johnson Foundation issued a report called the Blind Side of Healthcare. And it was a really important study that looked at it was a survey of the primary care physicians across the country, and 85% of those primary care physicians, again, this is back in 2011, believed that patients' social needs were as important to address as their physical health needs, and the percent was even higher, 95% among those who were surveyed who were serving low-income communities. The problem was that 80% of those folks didn't know how to do it. So the title, Healthcare's Blind Side, the overlooked connection between social needs and good health, is that, physicians, clinicians, they don't know how to do it. They don't have the time, they don't have the staff, but they know it's important. And that's where working with community partners comes in. The need to leverage the resources that are the programs, the services, the community-based organizations that are out there doing this work and trying to serve the same folks that you are. So we don't need more clients. Legal aid doesn't need more clients, right? We're unable to assist a huge number of people who apply for assistance, despite doing everything we can. So why are we working with health clinics, hospitals, and health, clinics, hospitals, and health systems to elevate the visibility of what we do? Well, the answer is because we think we can get better outcomes when we work with you all. When you all understand what we do, we can probably not only help you all get better health outcomes, but we think working with you can help us get better legal outcomes on behalf of our shared patients clients. So it's the concept there is that we've got limited resources. How can we align with other professionals who bring different skill sets and all work at the top of our licenses to get better results? So a moment here on what do we mean by partnership? It's really a different thing. We want you to know how to get people to us. We want you to, direct people to our website and know about community resources. But partnership really is not just a soft handoff or even a direct referral. The idea is that we work collaboratively with our partners to figure out what our priorities, how to do this, what are the right workflows, how do we close the loop, how do we work collaboratively once we've got a shared patients clients, how do we figure out what's going well and not going well, and how do we commit ourselves to working together through things that are not always that easy. All right, so I'm going to shift now to the news you can use. And again, my goal here is so what can help, let me just back up. What can health professionals do when they're working with patients and families who need assistance that's outside of your wheelhouse? One, you can provide information about services and programs that are out there. Two, you can provide some kind of direct assistance. An example of that would be, lots of clinics have, emergency food on site. Some clinics have people on site who can assist folks who need to apply for certain public benefits. But the third sort of category is referrals to community-based organizations who may be able to provide help. And then fourth is this sort of model of integrated team-based care. So now we're in the provide information category for about a number of services, programs that may be helpful to the families that you're serving. So first, I hope you know about this. I'm sure you've heard about the Ombudsman for Providers, the Medicaid Managed Care Ombudsman for Providers. There's a parallel program for the rest of us, which is the North Carolina Medicaid Ombudsman. And so this is a lot of text. Again, you'll get the text and you'll see when you have if you haven't got them already, that a lot of all these sort of screenshots are text heavy, but they provide a lot of information and hopefully they're useful to you. So the Medicaid Ombudsman Program, Legal Aid of North Carolina actually got the contract from the state, and we partner with Pisgah Legal Services and Charlotte Center for Legal Advocacy to do the Ombudsman Program. But it's not, you don't see our logo on the Ombudsman stuff. It is a partitioned program. The staff that do that are not doing legal work. They're doing that upstream work to try and educate people about their rights and responsibilities, to try and advocate when someone's got an issue and they start with the North Carolina Medicaid Ombudsman Program. Those folks, can connect to the plans, can try and resolve things, and hopefully get things solved quickly. If someone needs more than that, if the ombudsman can't get it solved, there are many folks who are going to still need a lawyer to help with the grievances and appeals, and so the Ombudsman Program will offer to those folks that they, to connect those folks to legal aid and other legal services providers to help with the grievances and appeals. But a very important part of the Ombudsman Program is also communicating, tracking what's going on and communicating with the state so that there's an opportunity to, when issues are coming up over and over, to help the state get things resolved. So here is the first of few different ways I'm going to do this. We hope that you would consider, I hope that you would consider, providing information about the North Carolina Medicaid Ombudsman Program to the patients and families that you serve. If you go to their website, you can see downloadable posters, flyers, handouts, things you can link into your after visits. ABS summary, there you go. Information that you can use. And if you want to, invite ombudsman staff to make presentations to your colleagues or to community groups, there's ways to do that. All right, switching gears. The North Carolina Navigator Consortium, again, we're the lead entity there, but we partner with a number of other organizations across the country. If you don't know about it, I hope that you will learn more about it. The Navigator program provides free assistance. In fact, it's one-on-one free assistance, impartial, confidential, and it's an opportunity for people to work one-on-one with someone who can help them figure out how to apply for and access ACA coverage. Now, there's an open enrollment period that begins November 1st. But please understand that many of the families that you're working with will qualify for ACA outside of that open enrollment period. If you're working with families who have changes in their income or household size, it's quite likely that may have an impact. So if they applied for ACA 4 months ago and then lost or gained a job or had a child or had other life circumstances, that may trigger an opportunity to come in and qualify at this point if they hadn't previously qualified. So again, I hope that you'll get the word out to the families that you're serving. There's some awesome, really terrific work, terrific news. If you hadn't heard it before, in around mid-August, there was an announcement that SNAP benefits will be increasing effective October 1st. And this is a significant increase in benefits. And so hopefully the families that you're working with know about how to apply, how to get nutrition assistance, including SNAP. But as you'll see in this slide, the benefit level increase for families in North Carolina is significant. And this is just terrific news. As with ACA coverage, and many of the other things, there's sort of been an expansion of benefits and eligibility as a result of the pandemic. Folks who may not have known about programs or may not have previously qualified may now qualify for services. And I realize this is a little bit small. Again, my goal, give you direct links for posters and information that you can put up on the walls or hand to the families you're working with. A lot of people just don't know beyond SNAP and WIC about wide range of nutrition assistance programs. There are programs in North Carolina for low-income seniors. There are programs that are specifically for members of the Eastern Band Cherokee and specific counties, Native Americans in specific counties. There's a wide range of nutrition assistance programs. And again, I hope that you'll consider making this information available to the families that you serve. I've got just a little bit more here. I think I've got tax credits and housing. So tax credits, another really important big piece of news, and a lot of folks don't know about it. And for a lot of the families that you serve, if they're very low income, they may not be required to file taxes, but they also can't get access to these tax credits unless for those folks who don't file, they have to do something in order to get the access to the benefits. So starting in July, families can receive up to $300 a month per young child, and up to $250 a month per child ages 6 to 17. That is a significant amount of additional financial assistance to many of the families that you serve, but they have to apply. And the good news is when you get folks who are receiving that tax credit, it's not going to affect their eligibility for SNAP and Medicaid and other public benefits programs. So it's more money in the house and it has no impact on their SNAP benefits or their eligibility for other things. And again, I know that many of you work with patients who are in mixed immigration status families. So just to make it clear, children in families with mixed status, when the children are US citizens, that they are eligible to receive these tax credits, even if their parents are not. So I've given you links here for how to get to the posters, how to get to the information. There's a bit of a timing issue. I guess I'll go back one. If a family wants to get monthly payments starting now, there's a deadline to do so by October 15th. If they don't do it before October 15th, they can still get it retroactive when they file their taxes in 2022. But most families would rather have it now than later. Okay. And the last thing is, we all know that the eviction moratorium has ended, and hundreds of thousands of people in North Carolina are at severe risk of homelessness because they're unable to pay the rent or the mortgage. So I hope you will share information about rent and utility assistance programs that we're in phase 2 of these, right? So there was HOPE assistance and other kinds of rental assistance available earlier in the pandemic, but there's been a new influx of funds. And so the HOPE program is serving 88 counties, and you can find the program. There's some basic information about the kind of assistance that will be available. So outside of those 88 counties, there are a number of government and tribal specific programs. And so if you go to the website here, you'll learn how to connect to those locally funded and administered programs. And similar assistance will be available for those low-income homeowners that you're working with. Okay, I'm going to do a little time check. We're now in part 3. And how are we doing on time? Doing okay, I think. All right. I'm sure you're in lots of conversations about the impact of the July 1 start date for Medicaid transformation. And so I don't need to sort of go into that from a global perspective. I wanted to focus here on how the state is intentionally trying to build into the operations of Medicaid transformation the effort to not only screen for, but actually address the social drivers of health for Medicaid managed care members. So as we move through this we're sort of going back to the integrated, collaborative, team-based care. So here's the vision. I hope that you've seen it. Secretary Cohen, the goal is to reframe and redefine the system from buying health care to buying health, and to invest in a coordinated system that addresses both the medical and non-medical drivers of health. And the state has chosen to focus initially and primarily in 4 what they call key domains: housing, food, interpersonal violence, and transportation. So I kind of think of we've got 1.6 million people who on July 1st transitioned into Medicaid managed care. So I sort of think of the next couple slides like a funnel. So we got 1.6 million people. By contract, the prepaid health plans, when they sign the contracts with the state, they are by contract required to do a number of things on behalf of all Medicaid managed care members. And as we move through the slides, they have to do more and more for smaller groups of people. So and I hope you know this, if the prepaid health plans aren't doing this directly, they've got to contract with or have these responsibilities delegated to clinically integrated networks or advanced medical homes. But nonetheless, it's still the plan's responsibility, regardless of who is actually carrying out the work. So for all plan members, they've got to, all members are supposed to be screened to identify unmet health related needs. I'm going to show you what that screening tool looks like. The plans are required after the screening to make, best efforts to complete that within 90 days and at least annually. And they're required to provide general care coordination and link people to community resources. And you're going to get to hear next session about this amazing resource called NC Care 360 that will allow folks who are trying to connect folks to community resources to be able to know whether they were actually able to get assistance. Plans also must, for all enrollees, share the results of the care screening with you all if you're the primary care providers or the advanced medical homes or designated care management entities that are working with that particular member, and they've got a timeline to do so. And there are a number of other things that the plans must do on behalf of all of those Medicaid enrollees. So this is a copy of the standardized screening tool that is being used. It was developed by an technical advisory group. For those of you who've already been doing screening in your clinics, you probably recognize a lot of these questions, if not exactly worded the way that you have them already, are probably built into your Epic system already, but screening, as Marian Earls likes to say, is a conversation starter. It is not an intervention. We don't need to screen to identify how many people need assistance. When we're talking about a Medicaid population, many of them are going to say yes to pretty much all these questions, right? So the thing is not to screen, it's to connect people to get them to help. And so the way we like to talk about it is there's screening, assessment, and help. You got to ask a few more questions to know whether if someone's food insecure, are they getting SNAP? If not, help them apply. If they had SNAP and it got denied or terminated, maybe they need a lawyer. So the intervention depends on a whole lot more than a yes or no to any of these questions. Okay, coming back to what's next. So that's what the plans are required by contract to do for everybody, the 1.6 million. Now we're going to start coming down to smaller groups. They shall, lawyers think every word's important, shall perform a comprehensive assessment to determine a care member's need, and I'm now seeing that I can't see some parts of my slides here, to determine a care member's need, a member's care management needs. And that is for two groups of people. People are identified through the screening, right, as being within, priority group, and I'll tell you what those are. And those who are referred, your light should start blinking right here. Where are the real, if you are not doing the care management, you are not part of the care management entity, but you are working with folks who need care management, you can refer them. And so when you do, they shall provide a comprehensive assessment, determine whether those folks need more comprehensive care coordination, care management services. So again, there's some timing requirements, shall within a certain number of days. Okay. So they shall use the findings of these assessments to, gosh, did I miss my, oh no, I seem to have omitted the priority populations. There's a number of priority populations, and I will, sorry, I've deleted that, but people who are experiencing domestic violence, people who have more than one social need identified in the screening tool, people who have children and adults with special health care needs. It's kind of a long list, and a lot of them are the folks that you're serving. So you've got to, once you've done this comprehensive assessment, you have to come up with a plan, right? These are shalls, right? For high need members. So the state, with its contractor Mercer, estimate that there's 320,000 of that 1.6 million Medicaid enrollees who are going to be identified as high need members. Pretty big number. And those high need members are going to get additional services. So for those folks, the prepaid health plans or their designee, if it's a advanced medical home or other clinically integrated network, shall at a minimum provide the following. Use NC Care 360, you're going to learn more about that. Provide in-person assistance to help with applications. Have on staff or by contract housing specialists to help people who are homeless. Provide access to medical legal partnership services. Provide designated care managers and establish a multidisciplinary care team that includes lots of folks to make sure that those high need members can get the assistance that they need. All right, I'm going to switch now to the sort of third group. So we had all enrollees, and then we had priority populations and high need members. And now I'm kind of going to a different group altogether. I hope you've heard about the Healthy Opportunities pilots. It's this, like the whole world's watching this one. CMS has authorized North Carolina to spend up to $650 million of Medicaid funding to support the social safety net in 3 regions of the state. And I'll show you, and they're all, by the way, I'll show you where they are. They're all rural parts of the state. So pilot funds, pilot services are expected to launch February 1, but we're actually going to see Medicaid dollars going into the food banks, going into the shelters, going out to organizations that provide housing remediation services, going out to organizations that help people access transportation. Again, the pilot funds are going to focus in those same 4 key domains. So where? Well, there's three regions and 3 lead entities. So in the far west, Impact Health, which is I want to say subsidiary, but I'm not sure if that's the legal term, but it's a spinoff of Dogwood Health Trust, is the lead entity in the far west. And they've got 18 counties in that region. Community Care of the Lower Cape Fear has got those counties in the lower southwest Cape Fear region, and then Access East in that region. So in those communities, in those rural parts of the state where I hope many of you are working and living, there you will see an infusion of Medicaid dollars to support the non-medical needs that drive health. It's very exciting. So what kinds of services might be available to pilot members in those regions? Again, there's actually 5. We say there's 4, but in the pilots there's 5. So these are examples of services in each of those core domains. Wouldn't it be amazing if your clients who are living in bad housing, unsafe housing, had access to not just inspections, because lots of you don't have code enforcement out there for quality and safety, but also funding to pay for remediation services, healthy home goods, first time security deposit, and one-time security deposit, first month's rent. How about if they're being discharged from the hospital and their housing is unsafe? How about access to Medicaid dollars to support short-term post-hospitalization housing? I'm not going to list all of these in all of these domains, but you should get very excited about this, because the point of this is to test the model. It's part of the Medicaid waiver. If we invest in these things, will they actually impact health? Will they actually reduce costs or align utilization where it should be, right? And will doing so in a way really be something that can lay the foundation to not only expand within North Carolina, but the rest of the country. Lots of people really excited about this. Services related to interpersonal violence, transportation. Again, this is transportation not just for medical care. This is transportation to get to your job, to get to the food bank or the farmer's market, to get to places that people need to be. Services related interpersonal violence, and then there's this sort of dangling 5th thing called cross-domain services. So for people who need enhanced care management services for 2 different things, housing and interpersonal violence, or food and housing, there's this sort of cross-domain thing. And then there's that access to CMS is approved, that Medicaid funding will support basic advice around housing and toxic stress and interpersonal violence. Who's eligible? Again, you're going to get the slide deck. Not everybody in the pilot funded region is going to be eligible. They've got to have a health criteria and at least 1 social risk factor, and then some of the services have additional eligibility rules. I'm going to start going fast because I really hope we'll have some time for conversation and talk. So here's an example: home remediation services. All of these are CMS approved. CMS has approved what's in the bucket and how much money, Medicaid money, is going to the organizations that are going to be providing these services. And here's possibly the most important slide related to the pilots. So what's your role here? You're not in those community-based groups, but you do have an opportunity to identify patients and families that you're serving in those pilot-funded regions who might benefit from these services. So you probably heard the expression no wrong door, but you've got an opportunity to help identify folks that you are serving that might benefit from pilot services. And we hope that you will stay tuned and participate and help us, meaning I'm saying us, legal aid, by the way, I'm not the state, help all of us. We all have a vested interest in knowing whether if we do invest in these things, does it really make a difference? And I think lots of folks think it will, but we've got to show that it works. And this, I think, is the last slide in my deck. So for those of you who are, thinking policy, thinking public health, so this is how the, CMS has approved the evaluation plan for the pilot services. So we're testing not only the impacts, the state's testing not only the impacts on enrollees' health, but also on the process measures, like will the pilots do a better job around screening and connecting people to services? Will participating in the pilots, improve, reduce social risk factors, improve health outcomes, improve utilization, reduce costs? And then that is my last slide. So I'm going to stop sharing slides and I'll come back to them if necessary, but I'd like to see all of you. And I welcome, how are we doing on time? Yeah, we're real close to the end. Sorry, I couldn't see my clock while seeing my slides. So I hope folks will ask questions. I hope people are excited.
Madeline, this is Franklin. I just want to thank you. There is so much information that you presented there. And for one, I was kind of overwhelmed, but my goodness, there's a lot to unpack. So does anybody have a question for Madeline?
Madeline, I'm going to jump in and ask, the $650 million, is any of that going to be going to health practices, or is it all going to the agencies so that they can increase the number of people they're providing social determinant of health services to?
Yeah, so those funds are for the safety net service providers, not the clinical side.
And will they get dollars based on like how many referrals they take, or is it just going to be like lump sum payouts?
Yeah, so there's 29 pilot services that that funds can pay, and how the payment is set up. Some of them are per member per month, and some of them are on an hourly basis. So it does depend on volume of referrals. But lots of effort went into saying, up to, certain things you can get up to 10 hours of assistance. And then if you need more than that, you got to go back and get additional authorization. I saw a little pop in the chat, looking forward to receiving slides. So I think that I've already provided them, but I will do so again immediately if they're not readily available to you. The slide deck I provided earlier did have a typo that I caught at 9:30 this morning. I know it's a lot of information, Franklin, and I kind of set it up that way because I'm hoping that the slide deck itself will be a resource for folks.
Absolutely. No, I meant no harm there. It's a ton of great information for everybody, and we'll make sure that everyone has those resources and they know where to find you at Legal Aid if they need some help, right?
That's right. And Bonnie, I don't know if you had other questions. I didn't want to cut you off. I just want to acknowledge that there was a chat to me. Yeah.
I have no more questions. I just will probably reach out to you to learn about what is going on with Medical Legal Partnership in North Carolina, because I've recently moved from PA and we had a similar program up there. So I would love to incorporate that into all our efforts.
That's great. Thank you so much. Does anybody else have a question? I think we just went past my time.
Well, I want to thank you again, Madeline, for doing the job today. It was very, very informative.
Happy to help. And I think I need to figure out how to stop sharing screens. So I'll mute myself and get that done.
Okay. Take care. Okay, folks, our next presentation is on NC Care 360, which has been mentioned by several of our other presenters this morning and this afternoon. Kelly Calabria, who is the president and CEO of the Foundation for Health Leadership and Innovation, will be joined by Vaughn Crawford, who is the senior customer success manager at NC Care 360 and Unite Us. So Kelly and Vaughn, take it away.
Hi, Franklin. I hope you're well. Thank you. Thank you for the introduction. And it's truly an honor to be with all of you today and appreciate the invitation to meet and share with you a little bit more about NC Care 360. And I was able to hear Madeline give her overview, which was so helpful. And so hopefully during my section with Vaughn, we'll be able to go a little deeper into the components of NC Care 360 that is a part of what you just heard. But I will emphasize, and I encourage you to, as we go through this, to remember that while NC Care 360 is a critical component of the Healthy Opportunities pilots, part of Medicaid transformation, it is a tool and a platform built and designed to support all North Carolinians, not just those within the Medicaid population. So I encourage you to remember that as we go. And I would be doing a disservice to Dr. Betsy Tilson if I didn't hit on that point, because that is something she's consistently reminding us, which is very true. And so let's dive in, and please, we'll take some time for questions. We absolutely want to make sure you get the information you need. I am Kelly Calabria, the president and CEO of the Foundation for Health Leadership and Innovation. We are the organization that is responsible for overseeing and administering NC Care 360 for the entire state, working very closely with DHHS, as well as our partners, including Unite Us, which Vaughn is my co-presenter, Vaughn Crawford, and you will hear from her in just a bit to get in more in the weeds of the actual platform. So a lot of this that I just want to start as I kind of ground all of us and we talk about what NC Care 360 is. Let's just start with those points around healthcare, the medical side, which all of you are, extremely familiar with, right? Around health insurance, watching rural health systems or hospitals close around the states, access issues that we are constantly facing. And then you begin to pair that with some of the overall health and wellness challenges that we're seeing happen across our state. And, I would specifically point out the point around youth with depression, and some of what you'll see and hear from us as we talk is around those mental health challenges and needs that we're seeing even more as we navigate through this pandemic. And so it is true that when you take a minute and you stop, and again, I know you're seeing this and living it, the healthcare needs, the clinical and medical side needs are vast, and the statistics that we see are stark. But when you begin to think about the unmet social needs and the challenges that we have, we know that 80% of a person's health is determined by the social and environmental factors, and then those behaviors that emerge from that. And so if you see here, this is very similar to what you just heard from Madeline. These are the 4 areas, the 4 domains in which we are focused on, not just from the state's perspective as we begin to implement the pilots, but also through NC Care 360. We've pulled these domains into the platform, and these are the areas in which we are focused around as it relates to those unmet social needs. So when you think about those needs, we're often finding ourselves talking a lot about food and transportation and housing. I was just on the phone this morning with 3 of the largest health systems, Duke, UNC, and Wake Med, and they were really emphasizing the challenges around food and housing and what we're seeing. So these remain some of our top focus areas, but it is important to remember that we're also looking at the interpersonal violence around, and looking at some of the adverse childhood events that are happening related to the children in our state. And that's also extremely important. So what's stark about all of this, and what I've shared, some of the stats that you've seen so far, is that all of this is what we were seeing pre-pandemic, right? As we were shifting in and knew we had to begin to look at and adjust and tackle these unmet social needs. as we have navigated through the pandemic, as you can imagine, these statistics and what we're seeing folks suffer from is becoming more and more exacerbated. So the problem is pretty straightforward. And you saw the quote from Secretary Cohen, which is so important, that this is about buying healthcare. It's not about buying healthcare, but buying health. And that's what we're looking at. And so when we take a minute and think about the problem that we're facing, it's a pretty problematic problem, right? Connecting people to these social services and helping get the need met. And so the solution that we're working on and what we have created is around NC Care 360, and it's becoming the cornerstone tool for the state as it looks at beginning to make these connections to services from the providers, insurers, and community organizations. And one of the things that we are so excited about as it relates to NC Care 360 is beginning to build those foundational relationships between those three organizations: the providers, the health systems, insurers, and the community-based organizations. Now, there's a lot of work that has to happen within that, including health systems feeling and being confident in the fact that community-based organizations have the resources and capacity to be able to meet the referral needs that are happening. So there are some, we'll talk some about that, about how we're beginning to think about that to support those community-based organizations who have been even more overwhelmed as we've navigated through this pandemic. So NC Care 360, this is a point of pride for our state. It is the first statewide network that unites healthcare and human services organizations together, really looking at how we identify those social needs that are there and begin to coordinate them through a very person-centered approach, putting that individual at the center of what his or her need is and connecting them so that we're able to deliver better outcomes and quality care for North Carolinians. So just a little bit about this collaborative network that we've worked to build. There's a couple of components that are important to it. And, I made the point that this is about connecting providers, insurers, and community-based organizations together. And they all come together to share and use a shared technology platform. And the benefits of this platform is that it allows us to do a couple of different things. One is that we can communicate with each other in real time. We're able to make these electronic referrals. And then the most important thing is we're able to begin to track outcomes. And so one of the things that we're working on with the health systems is that integration into their electronic health records. And I know Vaughn can speak more to that when she has a chance to speak. But to be able to have that full picture, to see that kind of journey of care and how that is working from an outcomes perspective. And so that's going to be super important as we look to scale NC Care 360 for the long term. The other thing I'll just point out here that is so important, and I think it really showed as we began to navigate the pandemic and having NC Care 360, was that it's the importance of having this infrastructure in place to allow us in North Carolina to quickly respond. If we had not made the progress that we had made so quickly related to NC Care 360 and that technology platform, when the pandemic hit, we would have been very much behind in how we were working to make those connections and those referrals. So even when we were first going through the pandemic and there was the opportunity for CARES Act dollars coming into the state was able to capitalize on that because we had this infrastructure, this first statewide network in place to begin to meet those social needs. So it's really a point of pride that I think for the state, helping us navigate this unprecedented time in which we're all living in. So sometimes I get asked, wait, what's FHLI's role in all of this? And how does NC Care 360 work together? And so I thought it might just be helpful to clarify. It is not, NC Care 360 is not about one organization or one group or one person. It is a collective team that is working together to implement and bring this to our state and to all of you who are using it. So as I mentioned, my organization is the administrator of the program. We're ultimately accountable for how it's delivered. And so I often tell those that I'm talking with, whether it's health systems or those community-based organizations or the payers, I'm here to listen. I can't address and get better and fix if I don't hear the feedback and what's happening. And so that's part of my job, is to make sure we're listening, hearing, and we have some wonderful partners who we get to work with to address that and continue to grow and build this platform. We work very closely with DHHS, as you can imagine, not just through the pilots and the Medicaid transformation work, but in all of the work of bringing NC Care 360 into the state. We also are closely partnered with Unite Us, who is responsible for building the technology platform, as well as overseeing the community engagement in which we have on the ground in different communities. And we are very closely tied with United Way and 211, and you'll see some of this as we work with our navigators and the resource platform we have to build out this tool. So it's a collective effort. One of the things I say often when I'm talking about NC Care 360 is, this program was not meant to be scaled into all 100 counties as quickly as it was, but who of us could have imagined that we were going to be living through a global pandemic? And so I'm very proud of how the team moved as quickly as it did to begin to implement the program so that we could scale into all 100 counties as quickly as we did. Now, does that mean everything's perfect? No, we still have a lot of work to do as we're working to ensure that the platform is robust and working with different community organizations, but we do now have the ability to operate in all 100 counties within North Carolina. And the other thing I think that is so important about NC Care 360, and I think you heard Madeline say this, is it's supposed to be about a no wrong door approach, right? That any entry point that we can get a patient into the system, we can work to get them connected into a resource. And that is something that we're excited about and want to continue to improve on. So let's just take a little bit of a look at what are the components of NC Care 360. When you hear NC Care 360 and what it does, it basically can be broken down into four pieces, if you will. The first is this shared technology platform that we're talking about, and it is the tool that allows that connection of the health systems and providers with the community-based organizations as well as the payers. That is the tool that they have access to, where they can make the referrals, search for the services that they need. Through our partnership with United Way of North Carolina and 211, we work with them to help build a robust statewide directory so that community-based organizations are being vetted and sought out and onboarded and told about NC Care 360 so we can bring them onto the platform. We also have a team of dedicated navigators who are available to help go deeper on referral cases when they're more high touch, or they might be for different services, not just food or not just housing, but multiple different components. We're able to work with our navigators. And then finally, the fourth piece is a community engagement team. And we're able to have this robust network of community engagement managers whose job it is to work within the community, get to know these organizations, build relationships with the community-based organizations, but all the way up to providers and health systems, so that we are training, improving, and constantly building a relationship around trust so that we can help drive use of the platform. So to date, these are just a few stats. This is from as of August 1st. We're well underway. We've served nearly 68,000 clients. At this point, we're proud to have a little over 2,400 organizations on the platform and using it. We're looking to grow, and there are services and areas in which we need more organizations for referrals, particularly as it relates to housing. And the team is working diligently on that to bring more referral organizations on board to meet those needs that we still have in the market. And so here you can see these are, and I've touched on this, these are really the top service requests that we are getting. It definitely is very high around housing and food. So as we think about the role of providers using NC Care 360, and you're going to hear Vaughn talk a little bit more about this, the most important thing that we're looking at is how are we making sure that hospitals and care providers can integrate this tool into their electronic health systems? You know, I mentioned that I was on the phone with some of the other health systems this morning, and they're very direct. You know, they say, and it's true, our staff is very stretched thin. There are certain things and tools that are easy, particularly for our social workers who have a lot on their plate. And so we need the platform to be easy and to work. And so this is the type of feedback that Vaughn and myself and the team are constantly seeking so that we can continue to make the platform as robust as possible for our provider partners, but also ensure that the referrals that are being made are able to be met by those community-based organizations. And so I'll talk a little bit in just a second about how we're looking at beginning to support those CBOs in a more robust way. And so I think we all understand this point, but I really wanted to hit on this as I close my piece out. When you go back to those, you know, stark statistics that were only made worse by this pandemic, you can begin to see how a tool like NC Care 360 that really is helping bridge that gap between not just the medical conditions, but those social needs of keeping people healthier early and often and connecting those patients to the resources available, how we can begin to tackle really some of the long-standing health disparities that we've seen across our state for generations. So what's next as it relates to NC Care 360? There's a lot. We have a lot to do and a lot to continue to do. One of the things we're working hard is to begin to establish an NC Care 360 advisory council. This is really important to me in my role with FHLI to be able to have a group of external advisors who are on the ground, living, breathing, have opinions, have experiences, use examples, so that we're constantly hearing, listening, and ensuring that we can address any challenges and continue to build trust in communities as we're working to have usage of NC Care 360 grow. The one thing I was excited to mention as we talk about community-based organizations is this week we have launched a survey that is going to our community-based organizations who are using the platform, but also to our health systems, social service organizations, our payers, really to begin to not just necessarily, it's not a satisfaction survey, even though I am interested in that. It's not about satisfaction of NC Care 360. It's more getting a sense of what do you need? What would be most helpful to you that we could potentially offer to help you better use NC Care 360? And so is it looking at potentially incentives? Is it looking at capacity? And so we are seeking that feedback to be able to adjust and make adjustments to the overall platform and experience to help ensure usage and that community-based organizations have the resources they need so that health systems and providers feel confident as they're making the referrals. And then we are continuing as a team to work to integrate NC Care 360 into the EHR platforms, working closely right now on the Epic platform. And so this is something that we are well underway and is critical to this program for the long term. So with that, I will pause and flip it to my colleague, Vaughn, who's going to actually walk you through a demo, and then we'll be happy to do some questions. So Vaughn, I'm gonna stop sharing my screen for you.
Vaughn, this is Franklin. I do have a question, or maybe a statement. It could be for you and or Kelly. I recall many months ago as being part of the advisory board for NC Care 360, and I may say we're end users at the North Carolina Medical Society Foundation with our project OBOT. So I've actually used this program to refer patients, and I think it's fairly easy and pretty intuitive. One of the things that I think would be important for some of the people on the phone, particularly our community practitioner folks, is they're working in rural and underserved areas across North Carolina. And a lot of them are very small practices, and we know that those typically are under-resourced. as you're doing the training for your independent and small practices, talk a little bit about what you guys have built in to kind of help them. I mean, if it's a system using it, they have redundancy in staffing. But, you know, and Bonnie's shaking her head, maybe the health department in some of these places doesn't have enough folks. So I think it's really important if we're going to be successful with this thing in North Carolina is in scaling, we got to get everybody we can on this thing. So please.
Absolutely. Vaughn, do you want to start? And then I'll add one point. Go ahead.
Yeah, I just wanted to say, like, thank you for that. We do. And I think Kelly mentioned it earlier that we really view this as state infrastructure. And there are so many opportunities for programming. There are so many opportunities for there's a lot. I think I remember Secretary Cohen also saying that this is a platform on which to build innovation. And so we want to make sure that as people are looking at their programming, they're looking at what they're trying to do within their communities, how they're tracking health, collective impact groups, community collaboratives, sort of all are welcome. And we are just excited to be able to partner. We know that especially in rural areas, you know, health systems, hospitals are the anchors of health in their community. And so we just want to put out that ask and that request to check us out and come join us. We would really love to have you.
So Franklin, I would just add to that, thanks Vaughn, is a big piece of this entire effort is the community engagement component of it, right? Like it's good to have the technology platform, and I will say the technology platform has to work well for the users using it. It can't have, be cumbersome or things like that. So those are things we know we continue to work on. But the community engagement piece is so critical, particularly I would say when you talk about the smaller community-based organizations in rural communities, but also to your point, those independent provider practices on the ground. So one of the things we'll continue to be doing is scaling up our community engagement outreach efforts and how we're working to build that trust in community as we work to onboard more organizations. I'll also say that we're excited to announce, if everybody doesn't know yet, but that the community health worker program is going to be extending. So it'll be all statewide, and we're in the process of training and onboarding a whole nother batch of community health workers who will be on the ground supporting and helping, which I think will go a long way as we're working particularly to get into those rural communities and with marginalized populations.
Well, that's great, because as soon as you guys are done, Bonnie and I are then going to talk about the CPP data project, and this is going to be integral for them to engage with this thing. So I want to make sure that they're going to be comfortable and you guys are going to support us. So thank you so much.
Absolutely.
Yeah. Any other questions?
There is a question in the chat.
Okay.
What use targets do you have in the coming months? How many providers, clients, et cetera, and by when?
Vaughn, you want to take that one as related to the onboarding of provider and clients?
Yes. So obviously right now with Medicaid transformation, as we saw with all the slides, there's a really big push around our AMHs and CINs about trying to get more of those types of entities on the platform. We do have a priority list and action items that we work on very closely with FHLI and DHHS. And then the other priority partners, there's been a tremendous amount of work around housing. And how are we going to work in getting more housing resources onto the platform? I can say that. And then the last thing I will definitely mention is those healthy opportunities pilots regions have a lot of activity that will be spinning up soon in terms of those network leads, helping to recruit people to join the platform if they want to be able to participate in some of those. those services. So as far as specific target dates and numbers, those I don't have, unfortunately, off the top of my head, but those are some of the big areas of focus.
Super. Do we have any other questions? Okay.
Franklin, if I might.
Sure, please.
I joined the foundation last December, so I am coming up on a year. So Franklin, I can't say I'm new anymore, but I have worked to get up to speed on the NC Care 360. And I would say, as the person that's ultimately responsible for getting this program in the market and having it work for the state, if at any point you have questions or want to talk or share feedback or any of those pieces, please know that my door is open. I am happy to meet with anyone one-on-one or my team. And we just really appreciate the opportunity to be able to play a role in bringing this important program to the state. So please don't hesitate to reach out if you ever wanted to have a one-to-one conversation.
We will do that. Thank you so much. Thanks for both of you today. We really appreciate it. Vaughn, thank you for the demo. That was awesome. And have a great weekend, you two.
Thank you, Franklin. Thanks,
okay.
Everyone.
Take it easy.
Bye-bye.
Okay. Well, that was really interesting. So the next speakers are going to be Dr. Bonnie Coyle and myself. And so we've kind of introduced ourselves along the way, so we won't formally introduce ourselves yet again. And we're going to talk about a CPP data project that we're doing now. And so a special shout out to my CPPers that are listening and attending today. This will be especially interesting and important to you guys going forward. What we're going to do is spend a little time with you guys today trying to tie together all the things that we've covered this morning and earlier this afternoon, and then talk a little bit about a project that we have in a pilot phase at this point. So again, welcome, Bonnie. Thank you so much. Thank you, Danielle, for advancing our slides. So let's go ahead and get started. Here is our disclaimer. Thank you. That was a brief disclaimer. Okay. So as I said, our goal this afternoon is to tie all of this stuff that you guys have heard together to get today, this afternoon. Both the Healthy NC 2030, the social determinants that Madeline talked about, lifestyle medicine that the Ruckus Health folks talked about, and also NC Care 360, which we just reviewed with the FHLI folks. Bonnie, do you have anything else you want to add to that intro?
No, I think that's great.
Okay, super. Next slide, please. Okay, Bonnie.
Yeah, so I just want to take a step back and sort of review a couple of the topics, some of which have already been touched on today. And so those will just be sort of reviews. And, as we're trying to build the case for why it's so important for health care and public health to really be thinking strongly about social determinants of health and lifestyle medicine, it brings to mind the model of the triple aim. Many of you are probably getting exposed to the concept of the triple aim within healthcare, which is to cut costs, since we spend so much money in our country on healthcare, to improve outcomes, because our outcomes don't look as good as many other countries, and then to focus on the experience of care. And that's for both the patient and their satisfaction, but also to that third arm of the triple aim has been added the physician experience. And how are physicians enjoying the practice of medicine? And do they feel like this is definitely what they signed up for? And I just want to take a moment to talk about that, because a lot of physicians, you heard Brian and Mike talk a little bit this morning about how they started to say, boy, what is going on? What is my practice of medicine all about? And it oftentimes gets labeled as physician burnout. And that term has always been a little bit bothersome to me because it makes it sound like there's something wrong with us physicians, that we just can't keep up with medicine, or that somehow we're demonstrating weakness. And I just want to share that I think the term that makes a little bit more sense is called moral injury. And as we realize that we are using pills and procedures so much and not seeing all that much improvement in our patients, and trying to keep up with electronic health records and all these added stressors within the delivery of healthcare, really the term that's more fitting is moral injury, that maybe we see a better way of taking care of patients and we're just not sure how to get there. And part of what we hope comes out of this conference is starting to get folks excited about and talking about how can we stop physician burnout, stop that moral injury, and get to the root causes of what's making our patients sick, and start truly, truly moving those needles and making a difference. Go ahead, next slide. And so Brian already talked quite a bit this morning about blue zones, so I'll just touch on it very briefly too, in case folks are on now that did not hear Brian talk. But you mentioned Dan Buettner is the National Geographic individual who traveled the world looking for those communities where people live to be centenarians. And this picture shows Dan in one of his communities with his arm around one of those centenarians. And as you remember from Brian's talk, what blue zones really showed is that if you want to live a long and healthy life, it's not about pills and procedures. It's about social determinants and lifestyle. It's about that moving naturally. Like Brian said, it's not about going to the gym. It's about being active. I say sitting is the new smoking. We have become so sedentary. Even those of us who do work out a little bit every day, we spend a good chunk of our day sitting with our jobs, and that's not necessarily good. And we need that right outlook, that know your purpose, the ikigai that Brian was talking about, and needing to sort of downshift and remember what matters in life. And then the eating wisely bullets of that Hari Hachibu, only eating until we're 80% full, and making sure we're getting a lot of plants that are packed full of phytonutrients into our diets. And then that wine, or I actually like too, the Friends at 5, because that's really probably what it's all about. Is it's interesting because I think it was in Sardinia, one of the blue zone areas, that they noticed that the men in that blue zone were living longer and healthier than the women. And when they really looked at what might be making life different for the men than the women in Sardinia, it was that the women were sort of left to handle all of the raising of the kids and staying home and the cooking and the cleaning, and the men gathered at 5 in the town square to drink their wine. And so maybe they were the ones benefiting from that camaraderie and that connection more so than the women. And then belonging, having that right tribe, family first, a sense of really belonging to a group. That's what we need to focus on. And this is what we have to help connect our patients with. Next slide. So the EPIC study, which included over 80,000 individuals in Europe looking at prevention of cancer and heart disease, found that if you adhered to these 4 behaviors, there would be about an 80% reduction in your risk of chronic disease. So being a non-smoker at a healthy weight, eating those fruits and veggies every day, and exercising for 30 minutes per day, 5 times per week. Again, we could just really nearly wipe the chronic diseases that are becoming so common in our country off the face of the map. And so I just want to pause a second and ask all of you, how many of you manage to fit into all 4 of those? Like, do all 4 of those apply to you? And if I could just put out a little audience poll question here, anybody want to guess? You can put your answer in the chat if you want to take a stab at this. What percent of Americans adhere to all 4 of these behaviors? Go ahead and take a second. And so somebody puts 25%, 20%. All right, 4, 5, 20, 10. Yeah, no, oh, look at those all going. All right. Well, less than 5. The people who said 4 and less than 5, you just about nailed it. It's right around 3%. Only 3% of Americans actually adhere to all 4 of those behaviors. So boy, think if we could knock that up to 20, 25, 30% even, how much of a difference we could make in outcomes and making our patients healthier. Go ahead. So you've seen this a couple times today, so I won't focus on it, but this is, that last slide was all about like lifestyle. Like if we're gonna make people healthier, if we're gonna make a difference in healthcare, we need to focus on lifestyle. And then, as you've heard from several of our presenters today, social determinants of health. So those social and economic factors like education, employment, housing, things like that, the physical environment in terms of, do people have access to places to exercise and parks, and do they have healthy food that they can access? All those factors all come together and play a big part of how long we're going to live and how healthy we're going to live. And I love Brian and Mike's focus on that compression of morbidity. It isn't about how long we live. If the last 15, 20 years of our life are kind of miserable and we're sitting in wheelchairs or we can't, we don't have the energy to do anything. But imagine when we focus on lifestyle and social determinants, that we can compress that morbidity and help put life in our patients' years, not just add years to their life. Next slide.
Okay.
So do you want to go ahead, Franklin?
No, it's okay. You're on a roll. Go ahead.
So the North Carolina Medical Society was looking to start a Healthy North Carolina initiative right around the time I came into the leadership program with NCMS. And so Franklin and I got to talking, and my project became centered around helping North Carolina Medical Society kick off this Healthy North Carolina initiative effort, which would be promoting to healthcare providers the Healthy North Carolina 2030 effort, which you all heard about this morning in that great presentation. And then our intent will be to introduce providers much more effectively to social determinants of health and lifestyle medicine issues and topics, and help them feel more comfortable about it with implementing NC Care 360 or possibly another social determinant of health platform, and learning a little bit more about lifestyle medicine and how they can incorporate tools into their practices to help their patients. So we want to be able to track the metrics that are related to those topics so that we can demonstrate that this is starting to help patients get healthier. You just had that great presentation on NC Care 360, and the intent will be to have practices first starting with our 6 pilot sites incorporate NC Care 360, but then advocate that NC Care 360 and other social determinant of health platforms get implemented in practices across the state. We want to share examples of lifestyle medicine interventions. We'll be talking about a number of them tomorrow during our sessions that might help providers think about how they can start little by little incorporating lifestyle medicine into their practices. And then again, track those metrics to determine the impact. And so our intent is to start with some pilot projects this year, continue looking for funding and opportunities to keep expanding our efforts across the state so that we provide the opportunity to make all patients a little bit healthier. So Franklin, you want to add anything to that?
Yeah, thanks, Bonnie, for teeing that up. That's great. And in a couple of slides, we have some data from our initial pilot that we started, as Bonnie said, with 5 community practitioner sites from Clyde to Morehead City. So the whole state, we picked sites, and also, as Bonnie said, local health department. It's going to be important to show this stuff to you guys because we're going to ask that you start participating in it. And at the end of the day, we're also going to have a dashboard displayed on the North Carolina Medical Society Foundation site so that it'll have real-time data as you guys provide that back to us. And we'll get into some more details about that in a little bit. Next slide, please. Okay.
So let me talk a little bit about this slide because this is Healthy North Carolina 2030 metrics on a slide. And what you'll see there is Cabarrus County. I am the health director at the Cabarrus Health Alliance. And so we have looked at the Healthy North Carolina 2030 metrics, and we decided to hone in and pull the metrics down for our county. So what you're looking at is a comparison that shows you each metric, what the value is for that metric in Cabarrus County, what it is for the whole state of North Carolina, and then what the goal is that Healthy North Carolina 2030 has set. And Cabarrus County is color-coded because this is how we're looking at the data to say, well, where are the areas we need to focus on as we're trying to put more social determinant lifestyle medicine efforts into all of our clinical practices and some of our public health programs. And so if in Cabarrus County, if you see a metric color-coded green, that means our county is doing better than the entire state average. If it's color-coded yellow, it means if it's color-coded green, we are better than the North Carolina average, and we've already met the Healthy North Carolina 2030 goal. If it's yellow, we're at least doing as well as or better than the North Carolina average. And if it's red, it means we aren't even doing as well as the North Carolina average. So I want to just highlight a couple of them, especially focusing on the ones that aren't so good for us because they then lean toward programs that we may want to implement. And as we take this to more and more practices, I hope all the practices will take a look at the Healthy North Carolina 2030 metrics, look up what their county is so that it helps them guide where they may want to focus some of their efforts too. So take a look at the last metric in social and economic factors, 3rd grade reading proficiency. Now, in Cabarrus County, it's only 60% for us, but you'll see it's even a little lower in North Carolina at only 56.8%. And we want to get that up to 80%. 3rd grade reading proficiency, some of you may say, no, what does that have to do with healthcare? But quite frankly, if you're not literate, if you don't read well, you're not going to do well in school. You're probably not going to graduate from high school. You are then going to get caught up in that cycle of poverty and potential problems with drugs, alcohol, things like that. And 3rd grade reading is the metric that is considered so important because up until 3rd grade, you are learning how to read. And after 3rd grade, you are reading in order to learn. So it's really critical that in pediatric practices, we start incorporating as a social determinant approach, helping parents understand how important it is that they are talking with and reading to their children from a very early age. One of the efforts you'll hear about tomorrow is Reach Out and Read, which is an effort that the North Carolina Department of Health and Human Services is really promoting and emphasizing in the state. You'll see one of the metrics that we are not doing well on at all is decreasing drug overdose deaths. We have seen, as the whole country has, a very large increase here. And as a result of recognizing that as such an area of need in our county, we have It started a medical assisted therapy program within our prenatal care clinic, and we are looking for grants to expand that so that we're offering medical assisted therapies to additional members in our county. And then you'll see that we are also red for excessive drinking, and we need to make some improvements there. And so that's another area we're thinking about. How can we, from a lifestyle medicine perspective, start addressing that more effectively in our sites? So I wanted to share that with you to see that's one of the data platforms that are helpful for providers to start looking at, to take on that more population health approach and thought process to looking at the county that they happen to be practicing in and get a sense of what issues might be most prominent there. Franklin, do you want to add anything to that?
No, not necessarily, but I just want to say this is really gives us great targeted information, and they're going to see some more about where we're going in just a few slides with your data from the survey. Okay, let me talk a little bit about this. I mentioned that we had practices basically from Clyde, which is in Western North Carolina, all the way to Morehead City. We looked initially for CPP practices that would fill OB, family practice, and peds, which we have done. We started with, I want to say it's about 90 days ago, with those 5 practices in a local health department location, that they were delivering these surveys to their patients via email, via UCR code, and one of them was even printing them out and allowing patients to, answer them in paper form in the waiting room, which I thought was very interesting, but they were doing it, okay? The survey was developed from social determinant questions, which Bonnie and I looked at and decided which ones we would put in the survey, and something called the lifestyle medicine short form. Bonnie, do you want to say something about the social determinant questions and of course the lifestyle medicine form?
Yeah, so what we want, since we want to help practices focus on social determinants in lifestyle medicine, and NC Care 360 has a social determinant of health platform already, we simply are focusing on the questions from NC Care 360 for the practices. That way, essentially, they can implement NC Care 360 and get and have a structured way of looking at social determinants. So what you see sitting here is the social determinant of health questions that are in our survey and that we are encouraging all practices to start to incorporate into their operations. And this matches perfectly back to the questions you saw on the slide from our previous presenters as they were walking us through the NC Care 360 platform. And so by including those questions and using NC Care 360, you'll be able to immediately see opportunities for community-based referrals that you can make for your patients. For lifestyle medicine questions, they focus on those 6 pillars that Brian and Mike were talking to you about earlier today. I'll be talking more about those pillars tomorrow and taking a deeper dive into plant-based eating. And essentially the questions are asking the patients around those 6 behaviors, since we know that by improving those 6 pillars of lifestyle medicine, that we will markedly help our patients be healthier and live longer. So we wanted to make this as simple as possible for providers and practices by essentially incorporating tools that are already out there, easily incorporated into electronic health records, and then for the social determinants with a referral database already in place so that you can match your patients to the best services out there.
Thanks. Okay, good. Yeah, go ahead.
So we have, again, we've recruited 5 CPP practices to engage in this study. and then the pediatric clinic at the Cabarrus Health Alliance. We really wanted to have one of the clinics that was associated with a public health department too in this. And so of those 6 practices, 4 of the practices have started to use the survey data and ask their patients to, using something as simple as a QR code, start to provide some data so that we get a sense of, okay, what is sort of the baseline health status along social determinants and lifestyle medicine factors that are impacting our patients. And then it'll help, again, drive where do practices want to start with thinking about interventions and projects and ways that they can modify their practice so that they will make their patients healthy. Now, we've only gotten about 500 surveys in so far. So this is just very preliminary data that we're showing today. Make sure everybody knows that. We wanted to show some data to give a sense of how this will evolve, but know that it is preliminary. It's just the very early stages of starting to do some of the data analysis. So we're just going to share a couple of data points with you today. I also want to point out and thank and do a shout out to Carteret OBGYN, because they were able to very successfully get the survey out to many of their patients. And so 70% of the surveys have come in from that particular site. So a lot of the data you're seeing is more heavily weighted by their statistics. And that's why when you look at gender distribution, you might notice that way more females so far have taken the survey than males, because 70% of the respondents are from that one practice. You'll see by looking at the age distribution that we have a nice spread of age groups, from a smaller amount in the pediatric age group of 10 to 19, but then nice spread of patients from age 20 all the way to 65 and over, which provides a real opportunity for intervening earlier in younger people's lives to help them make the changes that will give them that more robust and healthy life in their later years, but also the opportunity. It's never too late. We've seen lots and lots of examples of people 70, 75, and 80 who, by making lifestyle changes, were actually able to reverse their angina, like you heard from Brian and Mike this morning, and improve on their arthritis so that they felt more like getting up and out and hiking and biking and things like that. And so really added quality to the life, even of people who are in the older age groups. You also know by looking at the race here that the predominant race of the patients thus far is white. And I think that probably represents that a lot of the CPP practices are in rural areas where the predominant race is white. Anything there you want to add in, Franklin?
No, I think you did a great job.
Now I'm just going to share for a couple of the lifestyle factors that we've been able to do a little bit of the analysis on, what it looks like at these practices. So that first chart to the left is showing how the respondents replied to, do they exercise, and how many times per week do they exercise. And so first I'll point out to you that the black line that runs across the graph is the percent of people in North Carolina in general, not just these practices in general, that report that they are completely inactive, flat out couch potatoes. They do not much. And that's at 24%. And the Healthy People 2030 goal around people getting active is to get that down to 21%. So as the whole state, we have some work to do, but look at the work we may have to do if this preliminary data plays out and is representative across all of the CPP practices and beyond. So less than one time per week is the red bar. fully 32% of respondents said they don't exercise at all. They aren't even exercising 1 day per week. And then you probably all know that 5 or more times per week is the recommended guideline. And you'll see there that there is only about 15% of folks who meet that criteria. And so the vast majority of respondents thus far have some additional work to do to improve their health through their exercise. The chart on the right is for sleep. And I always find this interesting because it just seems that sleep is always kind of like this badge of honor where people think it's great to say, oh, yeah, I only sleep like 4 hours a night. And they're sort of almost proud of it, or think it's like, again, that it shows that you're strong. Bottom line, sleep is a physiologic function and we all need to sleep. It's when our body rests and repairs. And there's amazing research coming out more and more over the past couple of years showing how much we sleep is directly related to morbidity and mortality and development of chronic disease. Mike said this morning, he kind of capitulated on, is nutrition and diet most important? Well, maybe it's sleep too. And I'm right there with him. If people don't get enough sleep, their body doesn't have enough time to repair. And that really becomes a critical problem. And you'll see in the United States, only about 2/3 of Americans are getting at least 7 hours a night. So 1 in every 3 adults isn't getting enough sleep. The Healthy People 2030 goal is to kick that up a little bit. But now, again, look at our patients here, and 45% are getting 7 to 8 hours per night, and then just another smaller 5-6% are getting higher than that. So only a little over 50% of the respondents to this initial survey said they're getting enough sleep. So that's like only half. Okay, so we've already, again, if this data continues to bear out, we need to start talking more with patients about the critical role that sleep plays in their overall health. And then these 2 slides both focus on nutrition metrics. On the left side, you see that one of the lifestyle questions is asking folks how much of that processed food they eat. So like Mike and Brian were going over this morning, fast food, sugary drinks, sodas, sports drinks, food that isn't really food. Let's be honest, look at the ingredients in those items, and most of the things listed there are not actually foods. These processed foods are what play such havoc in American health. And so we need to avoid them. And the question is, how many times over the past 2 weeks have you eaten these kinds of foods? And the responses can be not at all. And you'll see that only a little more than 10% of the respondents said not at all. And then several days was the most common response, with a little over 50% saying, yes, several of the days I absolutely am eating those junk food, processed food items. And then if you add to that, people who said more than half the days, another 15-16%, and then nearly every day, another 15-16%. See, again, 85% of the patients in this initial survey data are essentially saying that they are eating moderate to large amounts of processed junk foods, and that is going to be definitely contributing to their health. And then on the right, you see the slide for servings of whole fruits and vegetables are the patients eating each day. And I hope you all know that the recommendation is that we need at least 5 servings of fruits and vegetables, actually probably more, like 7, 8, 9, 10 servings a day to optimize our health. And so you'll see that the number of folks reporting that they're getting more than those 5 servings like we would like to see is the lowest percentage at well under 10%. And that maps out again to sort of national statistics where the most Americans just aren't getting anywhere near enough of the fruits and vegetables. But focus in on the less than 2 servings a day. So that means maybe 1 fruit or vegetable all day, 20%, 1 in 5. And then 2 to 3 servings, another 45%. So, 65% of the patients aren't getting anywhere near the right amount. And then only about 35% or so are getting close to the amount we want to see everybody eating. So lots of room for improvement around nutrition, at least in this preliminary data, and will probably bear out as we break this data out more, as more data comes in and as that we work through the rest of the social determinants too. So just wanted to show some initial slides, not to spend a whole lot of time on the data since it's not yet complete, but showing you what we're trying to do here and the metrics that we're starting to take a good look at. Okay, so what are the next steps? I'll touch on it briefly and then Franklin will build on that too. So we are holding this summit as a way of introducing social determinants of health and lifestyle medicine more broadly to providers and public health professionals and others through that are in the allied health fields, in hopes of creating partnerships and opportunities for really improving the health of our communities. We'll be promoting the adoption of the NC Care 360 platform and lifestyle medicine short forms into electronic health records at the CPP and the PEDS clinic at CHA, and then work with the pilot project sites to help them identify some lifestyle medicine efforts that they can engage in and fit into their practice. Again, we'll have some great presentations and discussions tomorrow with folks who are already doing that in our state and are really seeing some good success. But we don't want to stop at just the CPP practices in the state. We want to work across the state to get all providers involved, and then not just providers, but how do we have public health departments focused more on these issues and community agencies referring their patients and engaging them. So essentially, the concept here is that we're advocating for transformation efforts across the state. And we don't expect the CPP practices, don't get worried, to be necessarily getting into the policy side of things and advocating to insurance companies and medical schools and health systems, but that we will find individuals who want to work along with us in this project where we are trying to transform all of the systems that we might work in, whether that's as a provider in healthcare or an allied health individual in healthcare or the public health sector or the education sector or research, that we're looking for all opportunities to be working together on applied research projects to figure out how to help patients change and how we transform our systems so that our systems support our patients, our community members to make the changes that will help them get healthier.
Thanks, Bonnie. And I want to give a little bit more specificity to, of course, the CPP practices. As we've said, we had this initial pilot group that has been submitting these surveys to their patients, and then we've been getting the data back. We are now going to move into phase 2, where we're going to ask the remaining CPP practices to participate in this effort. We have made it very easy for you to do so. We have created, as I said, QR codes that folks have been using, utilizing a lot, quite frankly. We have got a customized website link that you can actually put on your website so your patients can use that. Some folks have been utilizing that. As Bonnie mentioned, Carteret OB has been doing a great job. So we have got some best practices from them to help you guys with that. And what we'll be doing after this meeting is probably organizing a webinar that will be specifically addressing how we're going to want you guys to do that. Now, as Bonnie said, we want more than the CPP. So anybody that's on the call today that has interest in participating in this survey, we want you to participate, okay? So we have something in the chat from our Carteret OB that says, we hang the QR code in all exam rooms and say, while you're waiting, do this, which is great. Obviously, that's a success story. So don't be nervous. We're going to make it easy for you. And we're headed in the right direction here, folks. Bonnie, do you have anything else you want to add?
No.
Oh, okay.
I think at this point, we've got a couple of minutes left. If we can put out there, if anybody has any questions. You can either unmute and ask or pop your question into the chat.
There we go.
Okay, so one of the questions in the chat is, what is the time frame for rolling this out? So again, this year, our focus is really working with those pilot practices, which have already been identified. And then as other sites and practices may want to join in, they can either come in this year, or we would certainly be looking to try to get this out to more of those sites in the next year.
Okay. Someone says, how long will the pilot project run? Great question. Well, we started, as I said, about 90 days with this initial group. I don't really have an answer for that yet. We're going to see how long it takes. My CPP practices are in the program for 5 years. It won't be 5 years of pilot information or of the project. I can tell you that. It will be until we can get another plan together and be statistically significant. And I would defer to Bonnie in terms of what that means.
Yeah, I think we're going to need to at least be piloting the implementation of social determinants and lifestyle medicine for a year, because of making the referrals and making behavior changes. As many of you know, that occurs as kind of as a process. You know, we can't just say to our patients, okay, starting tomorrow, you're going to exercise 5 times a week and you're going to eat only real and whole foods if they haven't done anything in years and they eat mostly processed food. So you have to meet patients where they are. And so for us to start to measure impact of this will likely take about a year of collecting the data.
Right. We have another question from Dr. Helen Fan. Some grants or support for lifestyle medicine practice project, ? I guess that's directed at me. The foundation will be supporting this financially. Yes, that's the answer. Okay. Any other questions?
There's a question about somebody's daughter is I'm not went away on me now though. I think it fed down there. I am going to put my email address in the chat for the person who said, how can her daughter get involved? We are always looking for opportunities for folks who want to get involved. So if you want to be involved, if you're with a practice other than the pilot sites, but you want to get more involved in projects around lifestyle medicine and social determinants of health, if you know folks who want to get involved, that's the whole point of this. Like, how do we really start building impetus and excitement around transforming of health to support people in adopting healthier lifestyles and addressing the social determinants so that we have an impact.
Final question, Bonnie, do you see this about the inpatient psychiatric facility?
Yes, Michelle, you'd love to help with this, but you work at a psychiatric facility. Is this survey appropriate for inpatient psychiatric patients? Absolutely. If you I just popped my email in there. If you email me or you put yours in the chat too, so I know how to get in touch with you. I think social determinants and lifestyle medicine are appropriate for any setting. And the research that shows that when you focus on the 6 pillars, the dramatic improvements in mental health outcomes is pretty stunning. So it would be fun to work with a practice specifically around, can we make a difference for psychiatric patients too?
Great question from a CPPer.
Everyone, I hope everybody's back from their breaks and again did something somewhat healthy for that little 15-minute break that we all took. We are now going to have a really fun presentation on introduction to culinary medicine. And with us today to do that are 2 individuals from Wake. We have Dr. Joseph Skelton, who's the director of Brenner Fit and professor in Department of Pediatrics and Department of Epidemiology and Prevention at Wake Forest School of Medicine. And with him is Melissa Moses, who is a registered dietitian and is also with Brenner Fit and is program manager and registered dietitian with Wake Forest Baptist Health. So with that, welcome Dr. Skelton and Melissa, and thanks for your presentation.
Thank you so much, Bonnie. And we're just going to launch right in because it is Friday afternoon. And we're going to sort of tag team this talk. Melissa and I have been working together about 6 years, so we kind of think with one mind now. So there's AMA credit statement and disclosures. I don't think we have anything major to disclose. Do you?
No.
Okay, you sure? Okay. An intro slide there. And so today we're going to talk about culinary medicine, how it can be used to improve health. And then even in sort of in a small sense of the ways that you can take, even if you don't have a teachy kitchen like you see behind us, this is something that you can incorporate into your practice in big and small ways. So what is culinary medicine? It's one of those things that people argue about all the time in various definitions. It's utilization of a unique combination of nutrition and culinary knowledge to assist patients in making and achieving and maintaining optimal health. So in my simple way is you basically teach nutrition through cooking skills, because that's what we think most people are going to be taking in. The majority of their calories are going to be taking in will be within their own home of food that they prepare themselves. At least that's what we want people to do. And so therefore we think to teach good nutrition, you have to teach it through cooking. And in particular, the term culinary medicine really got started a lot with medical professionals. What it is not, it's not necessarily nutrition, dietetics. There's can be some overlap with integrative and preventive medicine, but it's sort of its own area. It's not culinary school. You're not learning to be a chef. It's not a single dietary philosophy. It's not a rejection of conventional medicine or of conventional nutrition. And it's not just about cooking good food. You can go to a lot of different cooking classes and learn to cook good food, and it not necessarily be culinary medicine. But what it is, it's a field that sort of blends art of cooking and food with the science of medicine, specifically preventive medicine, and also medicine actually geared towards certain disease states. It's aimed at helping people access high quality meals and how they can prevent it. It's a different way to talk to your patients. You might say something like, how do I eat for this certain condition, or how do I eat to be healthy? And it's also, I think it gives you a deeper understanding about your patients and the food and where they come from. And also, as my whole team will tell you, it's a heck of a lot of fun. Culinary medicine, the first sort of mention of it was in 2003 at SUNY Med School Upstate, where they had a cooking and nutrition elective that they offered in the first year of school. Harvard School of Public Health really took it big in 2007. The Healthy Kitchen, Healthy Lives postgrad conference at the Culinary Institute of America. A good part of our team actually went and did that conference, which really talks about how to improve nutritional intake through cooking. And then Tulane School of Medicine in New Orleans really hit it big in 2013 with their Golding Center there, where they became the first culinary medicine center at a U.S. medical school. And it became initially sort of an elective, and then it became every student in the school began taking it. And it has a big service learning component to it. So it's really become inculcated within that medical school curriculum.
So what you're seeing here is the top 10 causes of the US in, I believe, I can't see my screen, but 2013 maybe. But what you're noticing is that 5 out of the 10 actually could be linked to the food that we're eating and our diet. So that's fascinating to see that that's happening in the US. And what you see here is that, you know, out of this, it's triple related to the diet. So as you see, diet is really important.
So it can be really confusing at diet, because what specific diet should you follow? And it's been a huge issue within the medical establishment of that. And so we're really going to base this on what the best research has shown, what we know the best. And so for a lot of it, it's really done some universal truths that go between diets, that refined grains, processed meats, even unprocessed red meat, sugar sweetened beverages, trans fat, and sodium all lead to higher risk of cardiovascular disease, diabetes, and cancer. There's still a big question, and what we don't fully know is what diet is best and for who. And we could fight about some of the specifics between different nutrients, different macronutrients, different diets, but in the end, how do we get these basic truths, and how do we get people there? How do we get them consuming less of those foods, much less following some more of the specific diets? The fad diets have been with us forever, and they're not going away. And sometimes it seems like Groundhog Day, where the Atkins diet suddenly comes back as the paleo diet and then the keto diet. I mean, it really can be sort of Groundhog Day sometimes. And so I think it's very important that as medical providers, we can do a better job discussing nutrition, especially applied nutrition that we can prepare and get into our own bodies and get away and hopefully break away from these fad diets that are out there. As you can see, it just gets incredibly confusing, especially when you have medical professionals starting to tout their own diet. And even with some of these, there's actually some truths to some of these. There's parts of the South Beach diet that really push a healthy, well-balanced diet. But by putting it in that framework of a diet, people are always going to be destined to fail, because when things get too restrictive or too prescribed, it makes it very difficult for them to follow long term. You throw a medical degree on top of that, it begins to cast doubt on any other medical advice or any other nutrition advice that is coming to them. And so we really need to do a better job educating our own field and how to talk to patients about that. The majority of people in the US are actually trying to lose weight. And that's a lot of the world that we're coming from and the perspective that we're talking about, that 73% of women, 55% of men have desired to weigh less, 57% of women, 40% of men are actively trying to lose weight. And I think a good example of how this can go awry is The Biggest Loser. And if you've never seen the study, in our field, it's now called The Biggest Loser study, a very well done study where they look at the metabolic adaptations of people who had lost weight on The Biggest Loser. So you're talking about very low calorie diets, very high levels of physical activity, and how it literally screwed up their metabolism. And on the whole, almost all the people that went through that, as soon as they came off the show and began to go back to any sort of semblance of a regular diet or increase their nutritional intake, caloric intake just a little bit, how they had rapid and extreme weight gain and a lot of the metabolic problems that arose from that. And so even though we deal the world of weight management, we really want people to put a lot of that energy into trying to eat healthier or be healthier, cook more foods at home. And how can we lead people to that? But as I pointed out earlier, it can be hard because determining what is healthy can be hard for a lot of people. There's the idea that healthy equals tasting bad. And so you'll actually find us not using those words a lot when we talk about trying to eat healthy, because especially with kids, whenever a parent says, hey, we're going to, instead of having a burgers and fries, which you really like, we're going to eat healthy tonight. And maybe that parent is not used to cooking healthy, or maybe this is a new food to them. And oftentimes these kids will sort of process that of that food that you're saying is healthy, even though it may taste great, in their mind, they're going to have that equal being taste bad. But in teaching people to cook, especially teaching people to cook on the healthier side, can have huge implications for their health. And so David Eisenberg, who's the second author on this study here, he led the Healthy Kitchen, Healthy Lives program. And when they taught people to actually prepare meals at home, it actually improved their hemoglobin A1C and diabetes control. So oftentimes when we deal with culinary medicine or we teaching people how to cook, we first start with that process of trying to cook versus trying to cook healthy so they can focus on cooking foods that they want to eat.
Yeah, and so what you're seeing here, this is a depiction of consumer fraud back in 2011. And what you see is that weight loss products, it's double the amount compared to all of the others out there. And so that's why it's just even as important to share with, you know, our patients that they can get information out there that is incorrect. And it's always so important to make sure that you're going with the science first, because it can get confusing and they hear so much of it. There's so much noise out there. So as a provider, you really have to be the one to share the science-based information. And again, you know, even agencies out there, like they all have similar messages, but they can be a little bit different in a way. So it's still important to make sure that you're getting the right message and to know that different people are sharing different things. And even doctors like Dr. Oz can share things that aren't always science-based.
So there's something that I call the seminary effect, and it really goes to when you apply that to nutrition in 2021. We have as much research as ever about nutrition and how it affects our health. Yet there's as much confusion as there ever was. Please don't go on nutrition Twitter or hashtag nutrition Twitter, because it can be definitely a rabbit hole. There's really a lot of confusion about really what is healthy. And the idea of the seminary effect is you ask someone that graduated from seminary, that doesn't mean they know everything there is to know about God. They actually just know more about the mystery and a way to approach it. And I think we approach that way when it comes to nutrition, when it comes to cooking, is just because you have a medical degree or you have a nutrition degree or a PhD in nutritional sciences, there's still a lot of mystery to that. But when in our goal to improve the health of as many people as we can really stick to a lot of those universal truths about nutrition and guide them through that and not let them get led down these different rabbit holes that you saw earlier. So a lot of these studies, actually, we pulled this from that Healthy Kitchen, Healthy Lives. Eric Rim, who's a brilliant epidemiologist at Harvard, and he actually loves pulling together all the best studies in the world and really trying to I see it as him trying to get to some of these universal truths. And so for a lot of the people that are listening and watching this talk, are familiar with a lot of this old research and even some of the fads that have kind of come and gone. And I'm not going to call low-fat diet a fad, but we know back in the 80s and 90s when we had some of the most rapid weight gain possible, it was during sort of the recommendations to follow a low-fat diet. So we know that when it comes to weight loss, the idea of short-term trials, there can be modest weight loss and moderate compliance. But when you get the longer-term trials of low-fat diets, there's little to no weight loss and very poor compliance. And what we know happened in the 80s and 90s is replace the fat with highly processed carbohydrates. So overall, the idea of following a low-fat diet, trying to decrease your caloric intake through lowering the amount of fat that you're eating, overall does not work in the long term. Several others of these, you can almost always find a short-term trial that will show some improvement. But when you look at the long-term data, there is just no good long-term data. Now, I will say that maybe one day, and there's bits of research coming out that some of these diets or some of these approaches, such as lower carb or even intermittent fasting, for some people may be helpful. But what we do know is the more restrictive the diet, the less likely they're going to be able to follow it long term. Now, the Mediterranean diet, and even though, again, it has that word diet focus with it, we do know the Mediterranean diet does have good short, medium, and long-term compliance. There's whole cultures that have been eating Mediterranean diet for decades. And when it comes to weight loss, as you can see in this graphic from the New England Journal of Medicine, that the Mediterranean weight loss actually over a 72-month period actually had some sustained weight loss with that. And we know a lot of the macronutrient balance and the fats that go with the Mediterranean diet are very good for our bodies. And so even though I just badmouth trying to follow any specific diet long term, we do sort of hold with a lot of the principles of the Mediterranean diet when it comes both for eating for our health as well as eating for weight loss. I'm very angry that we didn't get a chance to invent this, but our colleagues down Tobacco Road at Chapel Hill actually came up with the South Med diet. as one small example of, one aspect of the Mediterranean diet is using meat to flavor foods versus the meat being the center of the food. Well, just think about how we tend to cook different bitter greens, such as collard greens. We tend to flavor it with a ham hock, small bits of fat within that versus that being the main protein that you're eating. And so there's some elements of that come through in the idea of the Southern Mediterranean diet. So just because we live in the South does not mean that we can't incorporate some of these aspects of the Mediterranean diet. And we'll talk a little bit, we'll touch on some of that later, but won't go into great detail about the components of that. So again, thinking of the seminary effect of nutrition, think of Occam's razor, that more things should not be used as necessary, or keep it simple, stupid, that let's focus on some of those universal truths about healthy eating and try to incorporate that into how we're teaching our patients to cook for themselves.
Yeah, so you see here, this is the balanced plate method, and this was created back in 2011. So it was the pyramid before, and now we have the balanced plate. And I really like the balanced plate because it's a nice visual for people to really understand a little bit better. Like, I just felt like the pyramid was just hard to figure out. So we use this method in our own clinic, sort of loosely. We don't follow exactly how they originally created it, but what it's doing is it's really helping you get a variety of food groups in your diet. So as Americans, we do really well with our protein and our grain part of our plates, but we tend to leave the fruits and vegetables part off. So it shows people that it's important to make sure that we have these different components. But what it also does is it teaches them about, which different components are better for us. So like when you're looking for grains, it tells us, let's look for things that are more whole grain. Let's do leaner proteins. It can also educate on the types of vegetables. What's non-starchy versus starchy? So if it's a starchy vegetable, we're going to consider it maybe in the whole grain category. So it's just a simpler way to explain to our patients. But also we don't want to say that it's a portion plate, because sometimes we get into that with a lot of people use it as a portion plate. And what we really want to do is focus more on just having variety at the meal and really be mindful when we are eating, because we know that sometimes you're going to be a little hungrier than other times, and that's totally normal. And that's very true for kids too, with growing appetites. Some days they're going to be more hungry than other days. So it's just as important to kind of let them be in charge of deciding the amounts that they choose from the plate.
So again, kind of focusing on what we know and what truths can we stick to. This is an old joke about the Japanese eat very little fat and suffer fewer heart attacks than British or Americans. The French eat a lot of fat and also suffer fewer heart attacks than British or Americans. Japanese drink very little red wine and suffer fewer heart attacks. The Italians drink a lot of red wine and also suffer fewer heart attacks. So in the end, it really doesn't matter what you eat and drink. It seems like English is your biggest risk factor. So also, when always have to take into account of the environment that we live in and recognize the impact of the media and what's being marketed to children and families, how it impacts brand loyalty, snacking habits. That's a story that I tell oftentimes. In our clinical setting, as a lot of you guys do, is that snacks are supposed to be mini meals that gets us in between long periods of time. And a lot of these foods that were called snack foods were really kind of a market creation. They were supposed to be an occasional food. And so that's now been marketed that it's a daily part of our diet, that you have these to get you between long periods of time between meals, and it needs to be crunchy, salty, and sweet. This is an old marketing term that I learned about in the past called the drool factor. When a baby drools, they look at the wet shirt and they see a brand, because you really think this little baby worries about what type of shirt that they're wearing. But in the end, they're really trying to get brand recognition in the crib, and they know that actually works. And this is kind of a scary statement. If you own this child at an early age, you can own this child for years to come. And that was made by President of Kids R Us. This is one of the big reasons that we have the soda contracts, pouring rights, as they call it, in schools. That if you go to schools from elementary up to high school seeing one certain soda brand, you're actually much more likely to continue buying that soda brand for the rest of your life. So a lot of this is just trying to get that exposure to people when they're younger. And then this CEO, they aren't children so much as what we like to call evolving customers. So there's a lot of pressure, a lot of money being spent trying to market things, not only to adults, but also to children. This is some old things. Some people said that these are fake. I can't find any evidence that they were fake, but before they realized that sugar sweet beverages were bad for us, and they were pitching them to younger and younger kids, it was okay to give these younger kids. You'll notice these might look like the old, being up here in Winston-Salem, like some of the old tobacco ads of the freshness of a cigarette and things like that. So we have a really bad history with this. Obviously, the proliferation of fast food, the food insecurity paradox that so many of these foods, it's the only food option besides corner stores that you're going to find in a lot of neighborhoods, in a lot of food deserts and things like that. So there's so much external pressure really coming at us, coming at the families that we serve, using marketing techniques that are very powerful. And what we know is that no one can withstand tempting food forever. And so this constant marketing, it's going to seep into our patients' lives. This is the old food guide pyramid, but having it broken down by government subsidies. This was I want to say this was a little old, except I don't think it's changed that much. That, you know, the things that we need to be eating the most now, what you would say with their fruits and vegetables, the fruits get about 170 million a year in government subsidies. Vegetables get none outside of corn, even though 80% of corn is made into corn oil, corn syrup, or ethanol. So it's not even corn that's really going to benefit us in any way. And then some of the biggest subsidies are going to be up there with the meat, poultry, and then the fats. And so, you know, even from a government perspective, even they want us to eat more fruits and vegetables, they're subsidizing foods that aren't going to be as good for us. The 5 to 9 fruits servings of fruits and vegetables a day, they had a couple million in marketing at their peak funding, which has actually gone down since then. So why do we need culinary medicine? Well, in med school, we get very little nutritional training. There's been a lot of research in this that that we just don't get enough. Only a third of medical schools have a dedicated nutrition course with an average contact of 24 hours. 88% of instructors in medical schools have expressed need for more education regarding nutrition. Here at Wake Forest, it's somewhat integrated throughout our medical curriculum. We're trying to do more to change that with our culinary medicine. At my alma mater, UT Memphis, I had a 2-hour course that was actually taught by a biochemist. He did a great job, but I didn't leave there actually knowing a lot about nutrition. Only about half of graduating residents feel trained to counsel on preventive health measures. And this is a study that we recently published with some of the students here, where we look, so we know that our students are getting very little nutrition education while in med school. So we looked at what nutrition knowledge they have coming into med school. We'll come to find out very little. Very few of the students actually had a nutrition class. Only less than 10% were actually nutrition majors. I think it's only about less than a quarter actually had a nutrition class as an undergrad. And actually most of their nutritional knowledge, they were getting it from social media or study on their own. So, you know, no wonder we're actually seeing a lot of physicians pitching fad diets nationally. And when you think about that, this is a picture of an appendectomy on your right there. When we think about skills versus knowledge, and even if we begin teaching students, medical professionals, more about nutrition, it doesn't necessarily mean they're going to practice it. It doesn't mean they're actually necessarily going to teach it. I don't want anyone taking out my appendix who's only read about it. I want someone that's been able to practice it. And we need to give people, more health care professionals, time to practice good nutrition. Time spent in cooking. And so what you see on the y-axis is the percent of people in that country that were obese, and this was in 2000. And on the x-axis is increasing time spent cooking. And you can see the United States and the UK spent the least amount of time cooking, and guess what? They have some of the highest rates of obesity. So again, one last time, why do we need it? We need hands-on experience. The old adage in medical school training, they hate when we say this now, is see one, do one, teach one. We do know that, as we know with children and we know with medical professionals, if they're involved more in home meal preparation, they tend to eat healthier diets. Cooking skills positively correlate with vegetable consumption. As I pointed out that type 2 diabetes study earlier, home meal preparations associated with a healthier diet and decreased risk of diabetes. And for physicians, and I think this extends to all healthcare professionals, is if we experience it, if we practice it, we're more likely to talk about it. So physicians are more apt to counsel on health behaviors if they practice things themselves, exercise, seatbelt, sunscreen, smoking. Nutrition, there's a little bit of evidence, but I think actually some of that evidence is increasing. And this one study quoted, practicing a health behavior oneself was the most consistent and powerful predictor of physicians counseling patients about related prevention issues. So like a typical physician, we took a lot more words to say. If we do it ourselves, we're more likely to talk to other people about it.
what you're looking at here, this is a graph that shows just how many meals kids are eating with their families within a week. And what you may see is that really about a third of kids are only getting 0 to 3 meals a week with their family. So, you know, that's not a lot, right? And even if you look at it a little bit further, you know, into 4 to 5 days a week, they're still missing some of the meals. So it just shows how, you know, how many meals that kids are really not getting at home. And a lot of time the restaurant industry is the one where they're getting the food from. And so there's so much marketing out there now to get families to not cook at home as much. It's just so much easier to go out and eat these days. And looking at this is actually how much money was spent in the restaurant sales industry. So you see that it's just continues to rise over the years. And in 2017, it was almost $800 billion. So that's a lot of money there. And think about it now, like it's even easier for people to get food out these days with, you know, things like Uber Eats and DoorDash. They don't even have to leave the house to get food out to eat. And these are some culinary trends. So less than 60% of meals eaten at home were made or eaten at home were actually made at home. And then the fast food and restaurant meals are significantly higher in calories and saturated fat and sodium. We know that. And so this is a quote from Michael Pollan, and this is Dr. Skelton's quote. But what it's saying is, how is it that we are so eager to watch other people browning beef cubes on screen, but so much less eager to brown them ourselves?
And there's even some people that theorize, despite the rise in cooking channels, and there's now 2 major national cooking channels, that we should be cooking more and more. But actually, there's some people that think that may even intimidate people more. And there's even a little bit of evidence to say that of, man, I can't cook. These guys are professionals, or they're media stars now. I can't do what they do. Tom Cruise jumps from an airplane with no parachute and is able to land safely. I can't do that. And I think people start to think that about cooking too. So even though we've seen a rise in a lot of this cooking stuff, it doesn't necessarily mean that we're cooking more at home.
Yeah, and it's easy to watch it on TV, but it takes time to actually go and purchase the groceries and make those meals at home. So that's kind of makes it a little harder.
So, very old, people love talking about the Hippocratic Oath and things like that, but we oftentimes like this, so let food be thy medicine and medicine be thy food. And so there's several diets that are now, very well accepted with disease, both treatment as well as prevention. One of the biggest examples in pediatrics is going to be the ketogenic diet for epilepsy. We know the Mediterranean diet is probably one of the best for cardiovascular disease and cancer prevention. The impact of legumes or beans on cholesterol. We're coming off of butter bean season, so I don't give a flip about summer. I just was glad we have fresh butter beans. The DASH diet has been very effective at helping people control hypertension. There's increasing research of using different tree nuts for metabolic syndrome, and I think we're going to have more and more of this. In gastroenterology world, the FODMAP diet for irritable bowel disease. We obviously know celiac disease and avoiding gluten. So I think we will continue to see more of these. So this is a little bit of our take, given the work that we do in obesity treatment in children and families from very diverse geographic and socioeconomic backgrounds. Is in teaching this both to students as well as to other medical professionals, I think you have to account for the family. Whether you're treating a child, you obviously have to account for the family, and then a parent. We talk to our adult colleagues a lot and say, hey, remember that patient of yours may be a parent, maybe a sibling, maybe an adult caregiver, and always trying to take into account for that. We do a lot of work with the idea of parenting, which is very important when it comes to food, of trying to go with authoritative parenting. And there's a whole nother lecture that we could have on that, because we worry about authoritarian parenting. Parents that are the most controlling with what their kids eat, the kids actually have bigger problems with picky eating as well as with obesity. And so taking authoritative parenting where you provide structure but also warmth with it is going to be the most effective. You have to account for preferences, regions, and culture. We don't want anyone to abandon their food cultures. If you told me to get up grits, I would tell you to go take a jump off a mountain. And we have to take that into account for a lot of people and trying to work within their culture and making the changes that are going to be best for their family. Also, don't forget the basics. With generations of people not cooking as much, a lot of these cooking skills are not being passed down. How to hold a knife, we'll talk a little bit about that in our cooking demonstration. Food safety, we cover that a lot with our students. When I started teaching med students cooking classes, seeing them handle a raw chicken and then turn around and touch something, it keeps you up at night. And so teaching about food and kitchen safety, and then even basic equipments. Most of our students coming into med school here are using inherited pans, and they may not have some of the basic stuff. The same thing with your families. And we know that as they've been doing virtual classes during the pandemic of some of what we thought were basic cookware, a lot of these families didn't have. And then trying to meet them where they are. Mediterranean diet, following it really strictly, is not easy to do. It once you learn it, you get accustomed to it, it becomes a lot easier. But it's not always an easy thing to do. If my son sees me bring out parsley, he runs, because that used to be his job, is picking parsley. And half these recipes in my Mediterranean cookbook have parsley in it. And it takes time to develop these skills. Don't expect, and that, again, that's part of the intimidating part of cooking shows, is don't expect them to be doing sous vide within the next week. And so here's sort of the way we view a lot of this when we teach classes, especially when we're teaching very basic classes. We all have that goal, is we want people to eat healthier. Typically for most of us, that means eating more meals at home. So yes, you can eat healthy meals out, you can order healthy meals, but I think for the bulk of people, economically, we want them to eat more meals at home if they're going to eat healthier. Which also means that they not only need to eat more meals at home, they need to prepare more meals at home. Well, if you're going to prepare more meals at home, you need to learn about cooking. You need to learn about cooking healthier. But to cook healthier, you got to learn how to cook. And some people really vary in the levels of their cooking skills. I have many med students, they have a sous vide machine, but they don't know anything about food safety. Or, they have an Instant Pot, but they have no idea how to roast broccoli. So teaching people some very basic cooking skills. And then to apply all that in the most effective way, in addition to their cooking skills, they have to learn how to plan a meal, read a recipe, shop, cook, things like that. So there's a lot of stuff behind that cooking that people need to learn if they're going to continue to cook at home on a regular basis. And we think that's the key, completing this loop to eating healthier.
So as we take all of this information that we learned about today, how do we apply it? Big and small, because we know that everybody's in different places with, their interests in this. So if you're the one that's looking to go gung-ho and, we're going to do culinary medicine in our practice, it might be you first start with, purchasing a hot plate, getting equipment, doing demos in your office, having classes in your waiting room, even after hours might be a place. And then one of the new things out there is group medical visits. And Dr. Skelton, you can talk about that a little bit, but also even inviting in guest chefs to come in and be a part of teaching your demos.
Yeah, so group visits, it's coming. We're still working through a lot of the details about it. In North Carolina, it's not super easy to do, but that is something I think that could be on the horizon as people look for more efficient ways to deliver healthcare. And so there's several positions in different states that we know that will lead cooking classes within a setting and are able to bill, even if it's a smaller amount, they're able to bill for these group visits. And I do actually know several people working in weight management nationwide that do actually have local chefs come by to teach some basic cooking skills.
Yeah. And so then another thing might be creating some sort of cookbook that you're able to give your patients, you and your partners, featuring recipes that you like to prepare.
I can tell you, I have such uptake. If I give them a recipe and I say, I make this, I think this is good, more than 50% of the time, they will come back with a picture of that. And our team has that all the time. Yeah. There's something about that sort of relation, say, hey, this is something, my wife actually loves developing recipes. She takes stuff out there, simplifies it, same thing that Benefit does. And so when I say, hey, this is something my wife and I cook all the time, my son loves this, it really kind of means something. And it's a nice, there's some trust that's built up with that, and they trust you as their medical provider, and it can really make it personalized versus just handing them something you don't know anything about.
Yeah. And so also getting with other partner, organizations, whether it's culinary schools or high schools with culinary programs to train up them, restaurants, chefs to maybe even donate their time. Those are ways to kind of make it a little bit bigger. And also even recording your own YouTube videos, of you doing cooking demonstrations or, cooking classes with people. That can kind of be a bigger way to share the culinary medicine world.
If you look at our YouTube page, the Benefit YouTube channel, I would say quarter, a third of those are recorded actually on cell phones. The cell phone video quality is incredible now, and we're doing more and more like that. So you can actually do, and if you have a teenager, they know how to download the software that can help you edit it. And so it can be a fun thing to do for your in your practice.
So what if we can't do anything really big? Maybe we can do something small. Maybe we feature a recipe in the waiting room, like Dr. Skelton was saying. Maybe it's one of your favorites. Maybe even having some kind of magazine in the waiting room related to cooking. There's a magazine out there called Chop Chop that we used to have in our clinic that would give recipes and stuff to families and just have, general nutrition information. Collect other resources. What are the other things out there that you can share with your family? He was mentioning our YouTube channel, but yeah, you can go there and look that up. We've also got a Facebook page. I'm sure there's tons of other organizations out there too that have information to share. And then just awareness, it gives greater insight into barriers families face in cooking and preparing, and more targeted interventions. Don't make suggestions that won't be taken or aren't applicable. A lot of times we get into the practice of saying, you need to do this, but really, are they ready for that? And so letting your patient be in charge of deciding the things that they want to work on when it comes to their health and, culinary skills that they might have.
So in summary, overall in the healthcare profession, we need to do a better job to serve the nutritional needs of our patients. As I showed you earlier, there's tons of fad diets out there. There are lots of our colleagues out there pitching things that are not based on science. And even though there's a lot of confusion on the science, we do know some universal truths about, more complex carbohydrates, less processed food, less red meat, more fruits and vegetables. And think about teaching cooking about as applied nutrition. If the bulk of the food we want people to take in should be food that they prepare within their home. And so teaching them some cooking is a good way to facilitate that. And within your practice, you can do it in big and small ways, from doing something like a demonstration to just having it be part of the culture of your office to talk about these in very sensitive ways. So I believe that is it. We ended a little early. I don't know if we could probably take a few questions, and then we just need a very short 5-minute break to get our cooking is almost set up, and we're going to show you guys 2 of our favorite recipes.
We have a question in the chat. Group visit for obesity, ? I know about group visits for diabetes, asthma, and centering pregnancy, but how do you bill for obesity in a group setting?
We are investigating that still. We did not have that quite done yet. Typically in this state, what we have found is you have to have some personal interaction with people when you're doing that. And at least in our world, in children, that's a kind of a sensitive subject. And oftentimes a lot of people are not going to be that interested in that. And so we're still trying to experiment with that, much less with trying to do it with cooking. So it's something that we're still looking into with Medicaid transformation that is supposed to be part of that when it comes to nutrition classes. And so that's something that we're still investigating. But other states, people are doing that to some extent.
I'll jump in with a related question. I'm just in North Carolina for a year. So does Medicaid, in Pennsylvania, Medicaid covered up to 6 visits for obesity related counseling. Is that the same in North Carolina?
Medicaid does. Yes, it does. I'm trying to remember what the number is over a 12-month period. I cannot remember the max number on that. I don't remember it being that limited, but I would have to double check.
Another question in the chat. Do you work with any corporations that are pursuing well-being for their employees?
We have a little bit in the past. We've done some obviously with Wake Forest because we're the largest employer in Forsyth County, and so we've done some with our with the Wake Forest employees here. We've done a little bit with some local organizations. We actually have a mobile teaching kitchen and have taken equipment out there and done some things like that. So we have done some of that. The world of employee wellness, corporate wellness is kind of I don't even want to say in flux. There's been a lot of stuff over the past 5 years questioning the efficacy of employee wellness programs, depending on what the outcome is. So that field is really at a turning point right now, and I don't know which direction it's going to go. And so what we try to do is trying to speak to what's important to people's employees. And so we know with the language, our love language is going to be families and trying to approach those employees that are parents and what are ways that we can help you guys with your families. And if that's a quick weeknight meal, one of our most popular classes is called Chefs in Training of bringing kids in here so they can help prepare a meal for the family. Things like that can really speak to the needs and wants of families presently. And so that's some of the things that we're doing right now. But with our merger and with Atrium, we're kind of waiting to see where that's going to go as the next step.
Yeah, and we also have a program that we've created, a 12-week program that employees at Wake can participate in for free, that works with the parents and trains them about how to help them, with feeding their family.
Are there any other questions from the attendees?
We are not able to hear you, so if you have something to say, we will not be able to hear it, but we have somebody listening with her earbuds in. So we're going to go ahead and get started with our cooking demo, and Dr. Scott.
Bonnie, can we do a check? Can you hear us okay?
Awesome.
Okay. I'm not talking to you, Danielle. I was talking to Bonnie. No, sorry. So welcome to our kitchen. This is our Brenner-Fit kitchen. You can see a little bit. We have, we try to mimic this as much as possible to be like a home kitchen. So no big fancy wolf range, no immersion circulators. The fanciest we get is my pepper grinder, and they really wanted it to not have this. So I bought this with my own money, and they're not allowed to use it now. So this one's mine. So I'll put that there. So unless you want to get started? Oh, so I'm going to get started. Okay, so to stick with what I talked about with the Mediterranean diet, this is such a simple and easy recipe. It can even be made much simpler depending on what ingredients you're going to use with that. But this is a Mediterranean white bean and shrimp salad. The pandemic has been about cooking beans for me, but that's cooking beans. So one thing we really push with our patients is the idea of using canned beans. And a couple quick notes. If you talk to any of your patients about using beans, please tell them this. First of all, when you open up canned beans, it's going to smell like cat food when you first open it up. It is not rotten. It tastes great. It's just, I don't know what it is. I'm not a canning expert. It smells like cat food. Tell them it's not rotten. Tell them it's fine. The second thing is they're making a lot of beans now with lower sodium formulations. And there's a couple things to note. Some are no salt added. Some are low sodium or no salt. Have them always be looked for the no salt, low sodium, but also, especially if you're doing a store version, actually, we don't have one here. But if you get like the store version, oftentimes they're natural line. And that's one thing that we actually teach a lot of our patients as well as the students that we teach is natural means really nothing. My hair is natural, but that doesn't mean anything. So natural doesn't mean anything, but what we find is the store brands of natural are actually lower sodium than some of the no salt added versions. So we don't really give them some strict numbers as long as they're buying a low salt, no salt added, or the natural, they're really going to be well off. And just expect that good cat food smell when you first open it. Have them rinse it off, and that smell goes totally away. So anyway, beans, they're great. They're very cheap. So for this recipe, we just recommend using canned beans. These are cannellini beans. You could really use almost white navy beans. You can use almost any beans, but we do like the cannellini beans. This will call for 2 cans, and we just have them dump it in a strainer, do a quick rinse to get some of that canning fluid off of there. And so we have that right here. You can see that cannellini beans already cooked. They don't need to be cooked anymore.
Yeah, and I want to add too, if you can't find the beans that are lower in salt, just rinsing them under the water and adding your own liquid back or your own water, that takes close to 50% of the sodium out. So like people are getting things from, food pantries and stuff. That's one thing that you can tell them of how they can reduce the salt in their foods. And
then what I would say is if there's any salt to be added to in the recipe, if they're using the regular full sodium canned beans, tell them just to taste it after to see if they need to add any salt after that. Going to go into the shrimp here that's involved with this. What we like to do is you can actually get pre-cooked frozen shrimp. They taste fine. Do they taste as good as fresh grilled shrimp? Probably not, but you're going to be adding in so much more flavor into this recipe. And if you want to save some time on a quick weeknight, you can buy the pre-cooked shrimp that's already frozen. If not, you could buy it fresh frozen, thaw it overnight in the refrigerator in a pan because all that ice is going to melt. And it's literally a couple minutes to cook. I mean, a couple minutes aside. There's an old saying that I was taught by a chef. When you start to cook the shrimp, they're usually going to be sort of flayed out like that. As soon as they start to curve a little bit, you're usually going to want to flip them. And then when they reach a C, they're cooked. C for cooked. If you leave it on there, you take a phone call, they're going to circle around an O, and that means overcooked. Okay. So if you're going to cook your own, just really quick, the main thing is you just want to get them, take them from being sort of translucent to opaque, and they're going to be ready for that. The other thing is canned or oil-soaked, oil-preserved, sun-dried tomatoes. Actually, this one, we actually had it come in a bag, and so we did it sort of Piedmont, North Carolina style, and we just soaked it in olive oil with that. Chop them up and put them in there, but oftentimes they'll come in a jar. With this recipe, you actually want to save some of the oil that that the sun-dried tomatoes are in, because a lot of that flavor is out into the oil, and you want to save that. So get a jar of the sun-dried tomatoes packed in oil. Save a little bit of this oil. I think in this recipe, it's going to be about a 1/4 cup of that oil. And so those are the main ingredients with that. So the main things I sort of want to go through with cooking of that. And so this actual recipe goes really quick. You're going to make a quick vinaigrette, and you're going to take about 1/2 cup of olive oil. And again, this is one of those things that a lot of your folks don't really know how to do. This is a liquid measuring cup. If you're going to do something that's not a liquid, you're going to use a dry measuring cup. And that could be a big difference depending on what you're cooking. It's very important. We teach all of our med students that. So I'm going to do about 1/2 cup of olive oil for this vinaigrette. Another thing that I always tend to teach my students is you need 3 oils in your house. You need canola oil. And again, in very simple terms, canola oil and olive oil nutritionally are pretty much the same. But olive oil is going to have no added, canola is going to have no flavor. So if you don't want it to compete with other flavors, then use the canola oil. If you want to add in flavor, use the olive oil. The third type of oil that you want is a fancy olive oil. Buy a small amount of that, and that's going to be the olive oil that you're going to drizzle down. To say, are there any alternatives for shrimp for those with a shellfish allergy? Absolutely. I've done this recipe without the shrimp before. We didn't set it out to thaw in the fridge, and so I just did it with the beans and everything else. I doubled up some of the other ingredients. I'm a big red onion guy, so I doubled some of that up. You could easily use fish, tilapia. You could cut that in pieces. I mean, you're talking a couple minutes of sauteing in there just to cook it through. You could absolutely do chicken with this. You could probably even get into doing tofu. Ask us back next year. We'll talk about a lot of different ways that you can cook tofu. That'll be good. So back to my vinaigrette. I'm going to do that. I'm going to take some of my sun-dried tomatoes that I've chopped up very fine, and I've got about 1/4 of the cup of the oil that it was actually came packed in. So I'm going to add that in. It's going to add in a lot of really good flavor of the sun-dried tomatoes. And then vinegars. I love vinegar. I'm sort of a vinegar addict with this, and you're going to add 3 tablespoons of red wine vinegar. No, you do not have any vinegar of this would be fine. Again, if you want to add that South Med diet aspect to it, you could do apple cider vinegar if you wanted, especially for any of you that went to East Carolina and you really hold with the apple cider vinegar, you could do that. And then I'm going to do 2 tablespoons. Oh, so I've already got the oil already packed in there. So I'm just going to stir that up really quick. And that's kind of it. There's already some salt in there with the sun-dried tomatoes. I don't need, and plus we already have some salt going on with the beans with that. So I'm going to, before we start cooking, actually I'm going to put this on sort of a medium heat there. I'm going to set this aside for a second and focus on some of the other ingredients that we're going to add some of the crunch to this. So a celery stalk. You can buy these in a lot of different ways. Celery keeps for a long time. You could also put this in some water to keep it even longer. And so we're going to add some celery to this just to give it a chunk, some crunch to it, not a chunk to it. Melissa will talk a little bit more about this with knife skills. What I always like to teach is the proper way. I've got all kinds of arthritis from holding knives the wrong way for so many years. Is to kind of pinch the blade there. So you're going to pinch the blade and then kind of wrap. And what that does is that gives that the pressure on that first knuckle. And that means when you cut, you're mainly cutting with the motion of the arm and not using your wrist as much. A natural tendency is to put that sort of finger on there. And what I say is that's for yelling at people. And then when you hold it like that, that's for defense, really, if you watch any of the horror movies, and you can always know that person's never going to make it. So you want to hold the knife properly. That's a joke, guys. I wish I could see more of y'all laughing, okay? But holding it like that, you can leave these as big or as small as you want. I'm going to always sort of cut it down the middle. And another part of with the knife skills, this is the hardest part to learn. It takes time and it takes practice. If I can do it, anyone could do it. And it's the claw. And it's learning how to hold the food. And unfortunately, I bite my fingernails, so I don't have the greatest grip. But what that does is that keeps that tip of the finger from being out there. And if you want to look really closely, you can see what happens when you cut your fingernail to the quick, and you can see how my fingernails growing in kind of weird. So don't do that. Try to hold it and not cut the tip of your finger like that. So you're going to try to hold it like a claw, and you can see that sort of motion with the arm and not necessarily as much with the wrist. And the reason you want that claw is it really decreases the chances you kind of catching the tip of your finger there. I'm doing all three at a time. You don't necessarily have to do that, but we're on a limited time period here. So I'm going to keep doing that. And I'm trying to not do what everyone tends to do when they're cooking on camera, and that's cut themselves for the first time. So that's going to add some nice chunk to that. Or sorry, I keep saying chunk, add some nice crunch. And then red onion. And so this is another great way to practice some knife skills, is doing the red onion. So anytime you're cutting anything, you don't want it to be a round surface, because that's the quickest way for something to slip and the knife cutting the tip of your finger off. And so the first thing you want to do is try to get a flat surface. So I'll cut off that sort of, it's not really the stem end, it's the opposite end of the stem right there. And now I'll have a flat surface to work on. And I'm going to do about half of this onion. And so this is going to be a dice. If you were making something like fajitas and you need some bigger chunks, you would do this a little bit different. But this is when you're either going to be sauteing onions or just trying to add some texture into a meal. And so the way you do that, actually, I'm going to peel this outer part off just a little bit so we don't have too much onion in that, even though these are already peeled. And so put your hand on top, and then you're going to slice probably about 1/4 of an inch up, and you don't slice all the way through. You still leave that connected back on the stem there. You're not cutting all the way through. And this one's a little thicker, so I'm going to then go the level higher than that. And then I go up on top, and I'm going to cut back again, not all the way back to the stem, but just almost. And then I turn, and then it goes into a nice dice there, like that. And so that gives you that. I always call that, that's the Food Network way to dice an onion, and gives you, it's not perfectly even. And remember, the most important part of cutting anything when you're going to be cooking, actually we're not going to be cooking this, but you kind of want consistent sizes with that. And that's what we're going for there. The other part that we're going to add in this is going to be garlic. You could absolutely use canned garlic or jarred garlic, either in oil or in water. I will silently judge you and make fun of you for doing that, but actually everyone else around here tends to do that. I'm just a snob about it. So usually what you want to do is you do a little smash on that, and that's just going to get rid of the skin to it. Now, if you're a fancy Food Network chef, you can continue to dice that up really good. I'm not a fancy Food Network chef. I'm from Johnson City, Tennessee, so I'm going to put it in my garlic mince here. I actually love this one, and I'm going to mince it up right here. I already have 3 other garlic cloves already pre-minced. When I'm teaching medical students, I love getting into the science of it a little bit. What I did just there is I'm exposing some enzymes in that garlic to oxygen, which is going to actually start to change the flavor a little bit. And that's where I'm going to get that spiciness of the garlic. If you don't want a lot of that spiciness, what you would do, you could actually slice it. You'd have bigger chunks, but there's going to be less surface area exposed to the oxygen. Another thing is you could try sauteing the garlic ahead of time. That's going to deactivate that enzyme. And so then when you chop it up, you're not going to have as much of that harshness in there. And then finally, the last little bit I'm going to show you as far as prep with this is going to be basil. And so the basil aspect of this really adds an absolutely fantastic flavor at the end. It's just going to be sort of like a seasoning at the end. And so we're going to do, our basil doesn't look all that great today. We're going to do a chiffonade, which sounds really fancy. It's not really fancy. All you're doing is trying to line all your basil up. You then kind of do a roll, of it, and then you're just going to slice it thinly. And what that's going to do is going to give you little, almost like little strings of basil in there. And it's going to keep you from having just a whole mouthful of basil when you eat it. And it's going to allow it to mix more in with the rest of the dish. You know, you chop it, you're going to be losing a lot, and you end up kind of bruising it a little bit too much. And so doing this sort of chiffonade, you can still sort of taste it, but it's not too strong. And I can already smell it in doing that. It absolutely smells fantastic. You don't have to be perfectly lined up. You just got to get it sort of rolled up like that. And this will break apart more when you get it in there. So that's sort of our chiffonade of the basil. So I have my pan heating up there. Normally what you would do when cooking something like this, you would add a little bit of oil into there, but actually we're going to use our dressing, which already has the oil in there. So I'm going to mix that up again, and I'm going to put about a half cup of the dressing, and I'm just really going to kind of eyeball it here. Not really do the full half cup. So I got about half cup of that dressing going in. The pan's starting to heat up there. And then I want to throw the beans in there. And again, these are canned beans. They're already cooked. If you wanted to do the beans from scratch, you absolutely could. But I would still throw them in there because all you're doing here is you're heating up the beans and you're getting some of that other flavor infused into there. And so getting that going just a little bit. And again, that's oil, which is going to help with the cooking. You have the vinegar in there. Another good thing to teach people is, especially when you're heating up an oil like that, a lot of flavor molecules, most flavor molecules are either going to be water soluble or fat soluble. And so we're actually getting sort of both of this. We have liquid in there already that's going to help brighten some of those flavors up. But now we're heating it up in a fat, which is also going to activate more of those flavors, especially when it comes to things like the sun-dried tomatoes and such. So.
What I love about this recipe too is you can really make it and eat it the next day. It's almost
better the next day.
Yeah.
I think especially a lot of beans, things that begins to soak up a lot of the flavors that it's cooking in. And I mean, when we make beans at home, I almost prefer it to be, let me get that bigger bowl from you there, Janet. Because what I'm going to do is that's getting heated up now. I'm going to save this for a little bit later. All I'm really doing is heating that up. All right. So pan's still kind of hot. Got it back on there. I'm going to add some more of my dressing. See most of the rest of that in. I'm going to add my garlic in. Because again, that's kind of I won't say it's harsh. I never like speaking ill of garlic. I don't allow that in this kitchen. But for some people that don't like a lot of the spice or the strong flavor to garlic, you want to temper that a little bit. So heating it up a little bit, it's going to inactivate that enzyme, stop that sort of harshness, and mellow those flavors out really well. And then that is going. And then again, my shrimp is already cooked. If your shrimp was raw, you could throw it in there and cook it through. I feel like you would start to lose a lot of, you'd maybe start to burn or overcook a little bit of the sun-dried tomatoes or the garlic. So I do like, you could cook it, set it aside, and then throw your dressing and your garlic in there to cook. We have a question. What are your thoughts about the differences in vegetable oil, cooking oil, olive oil, grapeseed oil? I'm going to keep it really simple. I am 48 years old and I don't multitask very well. And so I can't really go into a lot of detail about that. Overall, I tend to stick with what I told you is I like to have a canola oil as a flavor neutral oil, has a high smoking point. It's great for sauteing. It's great as your fat, but it's not going to add a lot of flavor. I like olive oil as far as adding flavor. I get really snotty about my olive oil, but you don't want to cook with a really good olive oil because you're just sort of ruining all that flavor. Coconut oil, I will go to blows with any of you paleo people. Coconut oil, despite what they tell you about how the saturated fat does not cause inflammation, no, it's high in saturated fat. I love it for flavoring. I cook with it sometimes, but I also recognize it can be very high in saturated fat. Grapeseed oil, I actually use that to season some of my pans with. It's very sticky. I don't use it a lot to cook with. The only other oil I oftentimes use to cook with is going to be with some walnut oil, mainly just because of the flavor aspects of it. I know avocado oil is getting a lot of popularity right now because it has some of the it's very healthy and has some of the highest smoking points that there are. So you can really do some really high heat cooking with that. But overall, remember Occam's razor, I keep canola oil, tons and tons of olive oil, and then we keep a small bottle of fancy oil around there.
Yeah. And with canola canola, with coconut oil, when you see that it's solid at room temperature, you know that it has a lot more saturated fat than other oils. So we're looking for something that when it's at room temperature, it's not in the solid form.
All right, so I just got that, cooked that garlic a little bit. I've got that shrimp heated up into there. And now we're going to start to assemble that a little bit. I'm going to add in my onions. I'm going to do it the fancy chef way and just sort of toss it in like this. I'm going to add in my celery and as well as the basil. And you can add as much or as little basil as you want into there. And then you toss that up. I may not need much more of this dressing. I might put just a little bit more. We did the non, just because the beans we had were not low sodium. So what I would do is I'm going to taste for seasoning on that.
And I have to say, this is one of my favorite recipes that we did in our culinary medicine program. Out of probably like 20 different recipes, this one is really tasty.
Yeah.
Need something extra?
Yeah, so I think we did, even though we used the full sodium beans, we rinsed all that off there. I think we just need a little bit of salt. This is something you absolutely don't have to do to be home cooked. But starting to cook with kosher salt. They've actually found that when you cook with kosher salt, because it's larger flakes versus table salt, you end up cooking with less sodium in it. And also it's bigger flakes, so it tends to stay on the surface of the food. So me just doing a little sprinkle on top, those first couple of flavor tastes that you have, that salt will really hit you and you don't really end up using as much. Also, one thing to tell people, if they're trying to watch the amount of sodium that they're taking in, only 11% of your daily sodium intake comes from food that you cook. Most of it's going to come from processed food, fast food, eating out. So when people are trying to cook lower sodium, trying to cook at home, still tell them to season their food, because otherwise they're going to make very bland tasting food that they're not really going to want to eat, and then they're going to give up on it. Or still use a little bit of salt, but trying to use other spices associated with it. So that is our Mediterranean shrimp and white bean salad. It's really good. I'm going to start eating right now. And like I said, it's going to be even better tomorrow. So I think we'll kind of switch over now to Melissa.
All right. So what I'm going to be making today is the California fruit salad. You have the recipe for it. And we're going to be talking about how to cut different ways, use knives appropriately. I know Dr. Skelton, he already hit it on some of those pieces of how to hold the knife properly, but we're going to go into a little bit more detail with also just knife safety. So we're going to get started, and what we're going to do first is we've got some strawberries here. We've got about a pound of strawberries, and what we're going to do is we're going to hull and half them. So whenever you're cutting with strawberries, there's different types of knives that you can use, and so I like to use the smaller paring knife, and what we're trying to do here is we're trying to cut out the top right here, okay? And that's called hulling the strawberry. So I'm going to do that right now, is cut off all the tops. May take me a minute. But I also like to just at this point kind of talk about, if you were to do a cooking demonstration in your own practice, like how would you get started with that? And how would you know what to do? And so I have some tips just to share with you guys. And the first thing that you need to think about is you need to think about, determine what your focus is at your cooking demonstration. Are you trying to do a complete meal? Are you trying to focus on snacks? Are you trying to focus on vegetables? I do demos here at the Burner Fit Kitchen, and I focus specifically on things like breakfast, where I'll cook different breakfast recipes for families to try. And it's a great opportunity for them to try different things without having to actually purchase the groceries and then not like the recipe whenever they have it at home. And I also do one on vegetables. So I just did that last week. We'll actually cook, 8 different vegetable recipes, and they'll get to try all the different ones. And I have that ability here because I'm at the Burner Fit Kitchen. So I have a little bit more space than you might have. So it may be something as simple as just doing one demo recipe where you're at. But you also need to think about your recipes. Whenever you're doing a recipe, you really want to use a tried and true recipe. So it needs to taste delicious, right? So we need to make sure that it's flavorful and that you enjoy it too. Because if it's flavorful and you enjoy it, then more likely your patients are going to enjoy it. And then think about the equipment that you're going to need. You know, it's going to take some equipment to put together. Like we talked about earlier, that hot plate. You're going to need a hot plate if you want to cook anything hot. You can do a lot of recipes that don't require a hot plate, that just require you to just have a table and some knives and, you know, cut in front of them. And so think about your equipment that you have to have. Also think about the space. You know, where do you want to do your cooking demonstration? Is it, you know, in your waiting room where you're at, or is it in a room where you'll have a little bit more space? How are you going to recruit and get families to attend? That's one thing too, and that takes a lot of time sometimes to put together, especially, you know, whenever you want a lot of participants, because if you're just doing it where people are just coming in for doctor's appointments, then you might not hit a lot of people. So it might take a little bit of time to recruit. So what I've done right here, I've got all the strawberries together, and I'm going to take my chef's knife, which is a bigger knife here. And this is probably my favorite knife to use. Dr. Skelton, he loves this knife. It's Victorinox, right? Explain that.
The Victorinox 8-inch chef's knife. It's got sort of a softer handle. You can find it on Amazon. If you put it on alert, about once a year, it will drop down to about $35. Typically it's $45, but overall, Cooks Illustrated has rated this the best all-around knife that you need in the kitchen. Most things recommend that you need about 3 knives in your kitchen. You need a chef's knife about this size, you need a paring knife as she was doing, and then if you're a big baker type, then you need a serrated knife that can double as a tomato knife. But we actually have 3 of these knives in our house just because we fight over them so much.
Yeah, and the serrated knife, I have one here, right here, and obviously that is a nice tomato knife if you're cutting tomatoes, maybe something a little smaller than that. And any kind of bread that you're cutting, it's nice to have a serrated knife. One of the also neat things that we like to do in our classes is obviously have kids cooking here in the Brenner-Fit Kitchen. And so we have what Dr. Skelton was mentioning earlier, the Chefs in Training, which is focused on kids only in the kitchen. And so in the past, we've done classes where we've done kind of preteens and teens. And so when it's a younger crowd and they're not quite confident in the kitchen yet and don't really know how to use a knife properly or might not use it safely, we have these kids' knives. I don't know if anybody's ever seen that before. Let's try to move around. And this is nice because it's serrated. And so it's not going to cut everything, but at least it's a safety piece and teaches them how to hold the knife properly and use it. All right, so I've got my strawberries together. And what I'm going to do next is I'm going to just add them to my bowl that I have. And this recipe I love. It's so versatile. You know, whatever fruits in season is really what you can add. So if you wanted to add peaches, you could add peaches, or you could add oranges, you know, whatever tastes delicious to you at that point.
And the only reason we call it the California fruit salad is we learned this recipe in California, just so you know.
All right, so we've got our pineapple next. And sometimes we're like, how do we determine if a pineapple is ripe? Well, the first thing is we want to smell it. Okay, if you smell it and you can smell the pineapple and you can smell it, it's sweet, that means it's ripe. Another way that I use the method is if you're able to pull one of these leaves, which mine aren't pulling, so this tells me this pineapple might not be completely right. A lot of times the leaves will pull off the top. And then obviously you're going to see it change in color. This one's pretty green, but hopefully we've got some sweetness inside because it smells pretty sweet. What I'm going to do is I'm going to twist off the top, if I can, just like that. And I want to make a surface where it's not rolling around. So I want to cut off the top right here. And I want to cut off the bottom. And then what we're going to do is we're just going to shave down the sides like this. And I just find this method a lot easier than trying to hack at it different ways. And you end up saving a lot of pineapple too. That spot's right there, so you can cut that out. And so obviously the pineapple is going to have a core, just like any piece of fruit. So in the middle, it's going to be hard. And we're only going to be using half of this pineapple. So we are going to cut it down the middle, and we're going to take out the core, and then we're going to chop it up. All right, so there we go. Simple and easy to cut up our pineapple. All right, cut it down the middle, and then I'm going to cut it into one more part. And everybody might cut a pineapple differently, so you might have a different way that you enjoy cutting up a pineapple. This is what I find is the easiest for me. So I'm just cutting down the middle just a little bit where that core was and taking it out. And this makes pretty pieces, so you can have some nice slices like that. Or if you want to make it a lot smaller, you can cut it like this. Using the claw method, just like Dr. Skelton mentioned, to make sure that my fingers are out of the way. I'm gonna add that. I've got one more to do. And fresh pineapple just has such a different taste than your canned version. And it's interesting because, you know, I've worked with a lot of families over the years, and it always surprises me how many people have never had fresh pineapple before. You know, I can think of one family in particular. They came to a cooking class here, and we had a recipe with pineapple, and they learned how to cut it. And then they came back to clinic, and all they could talk about was how they had been eating tons of fresh pineapple at home and incorporating it into their meals. So that was really great to hear.
And another thing on that note is that's one of the big points of sort of doing food, especially with families, is oftentimes in our world where they're focused on weight management and you might have a picky eater, oftentimes issues around food are kind of not very positive. And so bringing them environment, empowering the children oftentimes to cook, not that that's all the secret, but you're getting the families interacting together again in a very positive way over food. And so normally with the family that she's talking about, you would be fighting over trying to eat more fruits and vegetables and the parents pushing them to eat more, which oftentimes leads to the kids eating less. And then now it becomes a positive experience. And so it can be a very powerful thing when you're getting people to cook together.
And it's so fascinating to me how more open kids are to wanting to try different foods whenever they're actually the one preparing it or planning for it. So it just makes it even more important to get families in the kitchen and get them cooking and incorporating their kids too.
And there's good research actually supporting that from kids growing foods to preparing foods to them just choosing what they have way more buy-in. We're always shocked when we ask people, what fruits and vegetables do you eat? And the parent will say apple, oranges, bananas. And we turn the kid and say, what fruits and vegetables do you like? And they'll name a dozen other things that the parents never even thought about.
So what I'm doing now, I started with the apple. I went ahead and did it, but what I'm doing is I'm taking the core out. So what I've done, an easy way to do it is to slice the sides just like this. And then I'm going to cut it into cubes. Dr. Skelton taught me this way. This is the way you do it, right? Yeah. So then, so that it is not moving around, again, I'm going to place it on the flat side, okay? So it's not rocking around. And I'm going to cut it into dice pieces. So this is going to be added too. And the last thing we're going to add are some grapes. And you could use whatever kind of grapes you want. Purple grape, whatever or purple or green, whatever you enjoy as a family. And so when it comes to putting a meal together, like for a family, it takes time, right? Like it's not just as simple as always like pulling something out of the fridge and cooking it. You got to have time and preparation to think about what you want to prepare in advance. And so with our families here at Brennerfit, you know, our first step with families might just be trying to cook at home more, or trying to eat at home more actually. So it might even be, okay, we're going to take our fast food that we normally get and we're actually going to take it home and eat it and not eat it in the car. The next step might be, okay, well, what if we planned one meal a week, you know, one meal ahead of time, so you'd have the groceries and you'd be able to cook one meal at home. And then once they get a little bit more advanced, if they're interested in trying to cook, you know, a week's worth of meals at home, that's what we can focus on. It takes a little bit of thought though to it whenever you're thinking about putting a plan together, and we like to incorporate the kids. Like if there's kids in the family, we like to get their opinion too of what type of meals they want to prepare. So one of the first things we do is get them to create a list of different meals that they enjoy and write those down, because a lot of times whenever we're planning, it's hard to remember everything that's in our head of all the meals that we enjoy. But if we get it all down on paper, it makes it a lot easier to kind of plan for the week, because you're not having to think off the top of your head. And so then once you have that plan in place, you got to think, when am I going to shop and go to the grocery store and buy these ingredients? What day works best? There's all these details that go into it to helping a family be successful and eat more meals at home. So maybe it's the weekend that they're eating more, that they're able to go and shop. And that's what it is. Maybe they need to order their groceries and pick it up. Maybe that's going to help them be more successful. And then in the evenings, think about what is happening in the evening times, because a lot of times we're really busy in the evenings. And so on nights that it's really busy, maybe those are times where you plan for leftovers. Maybe you actually plan to go out to eat versus doing a spur of the moment trip. That's okay too. It's on your plan. And then on those nights where you have a little bit more time, that's where you guys may be able to cook together.
Most families only cook about 12 recipes on a regular basis. And if you'd ask me to name all the recipes that I've cooked in the past 6 months, I would probably name about 10 to 12. And then I go up for a recipe stand and I found 35 there the other night when I was trying to find a recipe. So we cannot, and it's hard. This is a big step. People don't think they need to do it, but have them get those recipes, that meals to remember, get them to have it down and have them look through it. It keeps them from getting bored with a lot of this cooking.
So lastly, I'm adding some grapes in here, and I already added some earlier. And now we're going to make a quick dressing, and it's super simple. It's vanilla Greek yogurt. You wanted to do plain, you could do plain and add whatever flavorings you want. We're going to add some lime. So I've got my lime. I'm going to cut it in half, and then I've got this lime squeezer.
It's another thing we fight over. They don't think we need that. You can do it with your hands, because actually limes don't have seeds in them. But I bite my fingernail, so I always have a hangnail, and I need this thing. Otherwise, there's a whole lot of yelling that goes on. So these things are wonderful. You can actually fit smaller oranges in there, but limes, lemons, they make them sort of orange size. But I love these things. It's a very, very worthwhile purchase to have.
Yeah, and so you've noticed that I've been cutting on a green cutting board. And so a green cutting board is actually what's recommended if you are cutting fruits and vegetables. Also got this white cutting board, and this is more preferred for like already prepared foods. So if you were chopping breads or things like that, your red cutting board would be for meat, like red meats. And then your yellow cutting board would be for like poultry items on this. Now we know that at home, not everybody has all of those different cutting boards all the time, right? But what I would recommend, if you could have at least 2 cutting boards, one that you use for meat and one that you use for your raw produce. That is really my recommendation, because what happens is whenever you're cutting with raw meat on the cutting board, the meat can really get down into the grooves that are created in the cutting board, and you can't always get that as clean. So we want to try to not cross-contaminate and have those things on there so they don't make us sick. I'm adding this dressing, and all we're going to do now is toss it. Dr. Skelton's going to help me with that.
And it really didn't look like a lot of dressing, but I mean, that little bit of dressing goes a long way, because all you're doing is putting that little bit of coating onto there. Also, the acid in that lime will help slow down the browning that'll happen at the fruit. So you have this at a party or even eating it left over the next day, you're not going to get big mushy pieces of fruit in that. Again, it's that acid that's preventing that browning in there. Get it in an airtight container, and this thing is good to eat the next day as well. And you can see that little bit of dressing goes a long way. And it really, all this fruit's good by itself, but that little bit of dressing, that very simple thing, really, it's kind of amazing what it does to that. So, you can even get a little fancy. You could chop up even some of the basil in there. You could take some of the lime zest, and you can even do a little bit of the zesting on there. That's the peeling that has the essential oils, not the essential oils that you burn in a candle. It's the essential oils that actually add a lot of flavor to that. add even just a little bit more color into there, even though I don't think you need much more color.
Yeah, mint is a good flavor.
Oh yes, that's a great idea.
So we
That's
are
it.
finished with our cooking demonstration. So wondering if anybody has any questions for us that we can answer during this time.
I think you have answered everything that has been popped into the chat up to now. So any
I'm
more
having a little
questions?
trouble hearing. She's going to translate it for us.
There we go. Okay, we can hear you.
Bonnie, can you say something?
Yeah. Can you hear me now?
Nope, I don't think you can hear.
No.
All right. If you have any questions, you could type them and we could try to answer.
There we go.
Sorry.
Okay. There we go.
Yeah.
Who gets to eat the food now that it's made?
I'm actually the people behind the scenes that you can't see. That's usually sort of the deal. And they did all the dirty work, and then they made the cameras, so they get to take it all.
I wish we were in person because that looks very good and I would love to try it. All right. Well, thank you so much, Dr. Skelton and Melissa, for those two great presentations, first on Intro to Culinary Medicine and then the cooking demonstration. We really appreciate all your efforts there. And again, we'll be wrapping up just a little early, and I will encourage all of you to join us again tomorrow as we continue the learning with more folks who are passionate about social determinants and lifestyle medicine. Danielle or Tina, do you have anything to wrap up for the conference before we let everybody get started on their Friday evening?
No, I just thank everybody for being here with us today. Thank you to our wonderful speakers. I don't know, I don't feel like I've been sitting down all day, even though we have. So it's been a very exciting day, I think, and very inspiring as well. Thanks to all of our CPPers in the group. Thanks to all of our practice transformation participants as well, and everybody else that joined us today. We hope to see you all tomorrow. And we hope that you now go out and move and have a healthy and delicious meal that we just saw on the cooking demonstration, and that we can see you all tomorrow again. So thank you so much.